So there was no relevant surgical or medical history except for a LSCS 1 year ago. So all her labs, including CBP, LFT, are normal. A USG abdomen, initial USG abdomen showed 9 bar 9 bar 8 centimeter SOL in segment 5, predominantly in segment 5 and 8. A CT scan, which will be discussed subsequently by Dr. Lakshmi, showed 90 mm into 82 mm into 95 mm iso to hypodense exophytic lesion arising from segment 5 and 8. So she has also got left hepatic artery arising from left gastric artery and axillary right hepatic artery from superior mesenteric artery. So I'll call Dr. Lakshmi to take to discuss upon the imaging of this patient.
Good morning, everyone. I am Dr. Lakshmi Kumar. I'd like to thank these people for making this presentation happening today. So these are the two cases that we are going to. So these are the two cases that we are going to discuss today. So these features I'd like to discuss along with the general description of hemangiomas.
Yeah.
In the main course, I'll discuss them.
Sure, sure.
So this is the outline of my talk. Introduction and features on each imaging modality, atypical features and differential diagnosis. So introduction, hemangiomas are the benign mesenchymal vascular lesions. They are the most common benign non-cystic liver lesions. They can be seen up to 20% of the population, common in women. And these are a congenital abnormality in vasculogenesis, and they grow slowly from birth. And the increase in size of hemangiomas is due to progressive vascular ectasia, and it is not due to hypertrophy or hyperplasia. That's why they are recently termed as that's why they are recently termed as venous vascular malformations instead of hemangioma. But colloquially, hemangioma is more prevalent among us, so it is still used. So these hemangiomas are mostly asymptomatic, but they can present with pain if they impress upon the hepatic capsule, or they can rupture and present with hemoperitoneum, or rarely they can cause Kasabach-Merritt syndrome, in which platelets get entrapped in this hemangioma and they are destroyed, leading to thrombocytopenia. They can be multiple in 10 to 20% of cases. So on histopathology, these are clusters of blood-filled cavities lined by endothelial cells, and they have very little intervening extravascular space. So this is the reason for the appearance of hyperechoic appearance on the ultrasound, and this is also the reason for the characteristic enhancement. So what happens is when the contrast comes from artery into the hemangioma, so the rate of flow decreases in the hemangioma as it distributes into these tiny vascular channels, and the equilibrium, that is the distribution of iodine molecules in the contrast from these blood-filled cavities into the extravascular extracellular space, takes time, as the extravascular extracellular space is very little. So that is the reason for contrast retention in these spaces. So also the slow flow contributes to the thrombosis of the hemangioma, which can lead to scar formation, calcification. So hemangioma, it typically doesn't have any hepatocytes or bile ducts, no capsule, no fat. Fat is commonly seen in adenoma, and Kupffer cells may be present, but they are very sparse, and they are hypervascular. And central scar, as I have discussed, if they are thrombosed, and hemorrhage is also very rare. So ultrasound features, typically these lesions, they appear well-defined hyperechoic with posterior acoustic enhancement. So that is the typical appearance, but they can be atypical appearance like central hypoechoic area or uniformly hypoechoic, or in case of a fatty liver, they can appear hypoechoic, like in this case. So CT, on non-contrast CT, they are hypoattenuating, but they are isoattenuating to the vessels. So this is one feature, and hemorrhage and calcification can appear hyperattenuating. And in livers with steatosis, they will appear isodense or hyperdense. On MRI, they are hypointense on T1, but isointense to the vessels. And on T2 and T2 fat sat images, they are very bright. They are almost as bright as the fluid, the CSF in the spinal canal. And they are homogeneously bright, and they are brighter than the spleen. So these are the specific imaging features on T2, unlike many other malignant conditions which are heterogeneously hyperintense or less hyperintense. So this is also called bright spot sign. And on diffusion, they don't show restriction as shown in these images. So post contrast, their enhancement is similar or more than the blood pool, that is the enhancement in the vessels. And on delayed images, they never show washout. That is the characteristic feature. They never show washout. And the scar in the hemangioma, it will not enhance, unlike the scar in the FNH. So on CT and MRI post-contrast images, the pattern of enhancement is similar. There are 3 patterns of enhancement. Pattern 1 is the uniform immediate enhancement in the arterial or late arterial phase, almost completely filling the hemangioma. This is commonly seen in smaller hemangiomas of less than 1 centimeter. So the differential for this appearance is liver metastasis. So I don't have a pointer. So the differential is liver metastasis, hypervascular liver metastasis. So they will show washout, unlike these flash filling hemangiomas. On delayed phases, so this is the flash filling hemangioma. On delayed phases, they either fade or show faint enhancement, whereas the metastasis mostly will show washout. So second pattern of enhancement is the classical pattern. If you see this pattern of enhancement, there is no doubt regarding the lesion. So this is the peripheral nodular discontinuous enhancement, which shows centripetal filling and clumping in the subsequent phases. So this is seen in small and medium-sized hemangiomas. So this is the classical pattern. These hemangiomas are called cavernous type hemangiomas. And pattern 3 is the seen in the larger hemangiomas, more than 5 centimeter. So central, if there is thrombosis, like in this case, so vascular thrombosis can lead to scar formation. This scar will not enhance even in delayed images. This type is called the sclerosing type hemangioma. So the enhancement rapidity can also be variable. They can be slow enhancing, medium or fast enhancing. If at 2.5 minutes, if the enhancement is less than 25%, it is slow enhancing. The differential for this pattern of enhancement is hypovascular metastasis or post-chemotherapy metastasis. And if the lesion shows 50% enhancement at 2.5 minutes, it is medium. And if it is more than 70%, it is fast enhancement. So for fast enhancement, the differential is hypervascular metastasis. Most commonly, we will see the slow enhancing hemangiomas. So these are 2 cases showing slow and medium enhancing hemangiomas. So on the 2.5 minute scan, it is less than 25% enhancing. Here it is almost 50% enhancing. So coming to atypical appearances of hemangiomas. So for a typical hemangioma with peripheral nodular discontinuous enhancement and bright homogeneously bright on T2, there is no need of any follow-up or additional imaging or biopsy. Whereas for these atypical appearances, you either need a contrast MRI if it is not done, or a follow-up if it is only mildly atypical. If it is very atypical with concerning features like washout, and then you have to do biopsy or excision. So atypical appearances, first one is perilesional hyperintensity. So this can occur in subcapsular lesion due to compression of portal vein and autoregulatory increased arterial supply. So other appearance is pedunculated hemangioma. This can have a thin stalk which may be imperceptible, and this is the hemangioma. This may undergo torsion also. So central enhancement apart from peripheral enhancement is also a atypical appearance, and they can also be multilocular cystic hemangiomas. And one more thing is bright spot sign. Here it is very slow enhancing lesion. Even in the delayed phase, there will be only 1 or 2 nodules of enhancement, which may not show complete filling even up to 3 hours. So these can confuse with hypovascular metastasis. So delayed lesions showing nodules can differentiate this from metastasis. So in setting of cirrhosis, hemangiomas will decrease in size, and the amount of enhancement in the nodules and the interruption between the nodules will decrease. Also, in any case of CLD, if a hyperechoic lesion, always think of dysplastic nodule or HCC before labeling it as HCC. So this is appearing as a hemangioma, but in fact it turned out to be HCC. So there can be perilesional fat sparing in case of steatotic liver around the hemangioma due to increased arterial supply. So coming to the differential diagnosis, first one is the post-chemotherapy metastasis. As in this case, it was initially showing a ring-like enhancement in the periphery. Post-chemotherapy, it was showing nodular enhancement with the centripetal filling. So this can be very confusing. The history and previous imaging can help. So intrahepatic cholangiocarcinoma and metastasis, this will show peripheral enhancement with centripetal filling, but the enhancement will be mostly linear, and they will not be so bright on T2. So these are the features that we can use. And angiosarcoma, it will have satellite nodules. So some guidelines on the management of hemangioma, American, European, and Brazilian guidelines I could find. So if you find a lesion of less than 3 centimeter on ultrasound, it is well-defined, hyperechoic with posterior enhancement, no halo. You can confidently diagnose it on hemangioma on ultrasound. If there are no risk factors like CLD or hepatitis B or known malignancy, and if you can confidently diagnose, there is no need of additional imaging. If there are any atypical features, then contrast-enhanced ultrasound or CT or MRI is required. And
Dr. Lakshmi, here, can we go to the directly case, to her case?
It is done, sir, 1 minute.
Okay.
So if it is a classical case, there is no need of follow-up. If there are any typical features, then we need follow-up. And biopsy is required if there are any concerning features as a last option. So most of the guidelines, they don't advocate any intervention unless the patient is symptomatic. So as I mentioned, I'm also an interventional radiologist. So this is the case of hemangioma presenting with pain. So I did embolization for this case 2 years back, and the patient is doing well. These are my references. Thank you.
So can you discuss the imaging of the patient, present patient?
So this is a typical cavernous type hemangioma.
This is second patient, large one, right?
Okay.
Segment 5 and 8.
So both are cavernous type hemangiomas with peripheral discontinuous nodular enhancement and centripetal filling in the subsequent phases, and they are mostly exophytic tumor, around 9 centimeter. So the enhancement is following the blood pool. It is similar or more than the blood pool, so it's a classical hemangioma.
Here we can go to the previous slide. There we can see on plain scan the lesion is hypodense, which showed on arterial phase, peripheral puddling, with subsequent centripetal filling. So it's a classical hemangioma. So based on this, as the patient was symptomatic, we planned her, we posted her for lap right hepatectomy. So the decision during hepatectomy is of two types. It could be enucleation or hepatectomy, formal hepatectomy. As most of the hemangiomas are partially exophytic, enucleation is the gold standard, but whenever the hemangioma is within the parenchyma without, it is not obvious externally, we can plan for formal hepatectomy. So in this patient, we have planned for lap enucleation, right enucleation. So first, after the initial entry from the umbilical port, based on the principles of triangulation, we have placed two working ports on either side, and the retraction ports are auxiliary. These are the working ports: the left hand working port, and the right hand working port. The right hand working port. Here you can see the large hemangioma arising from segment 5 and 8. So then here we are trying to, we are planning for Pringles manure. So we use a Foley's catheter for Pringles manure. We encircle the portal structures with the Foley's, with the cut Foley's, and we do the Pringles. This is a very safe technique, as the Foley is being made of silicone, soft material. It doesn't damage the vessels also. So it doesn't eat up the port also while doing the surgery. The leftover port will be used by the surgeon. These are the advantages of this technique. So we have applied the Pringles. Here you can see a large feeding vessel. I'm trying to we have detected this feeding vessel on imaging also. I'm making sure that it is not the replaced right hepatic, so I dissected it for a certain length. And confirming that it is not right hepatic artery, I have cut this vessel between two clips. Clipped and cut this vessel. Immediately, you can see on table the shrinkage in the size of the hemangioma. Sorry, so the hemangioma becomes softer and smaller in size. This may not be the case in most of the times. You might not see a single feeding vessel. Most of the times there are multiple feeding vessels. Here you can see it has been cut. So the third step is dissecting the falciform. Here I use the falciform for retraction from the right side by the assistant. I am marking the area of transection. As I said, I will be planning enucleation. I have pre-marked the area for transection, plane for transection. This is a hybrid technique of transection. I have used Kelly-Gleit's technique and as well as CUSA. Initially, I started the procedure without using the Pringles, but as I see there is a bleed, I started applying Pringles. Well, Kelly-Gleit's technique, whenever possible, actually it is a faster way in most of the times, but it is at times bloody. So I'll be using Pringles. In enucleation, especially in enucleation, the chance of bleeding will be there. So Pringles manure is mandatory. Here you can see I am applying the Pringles. I am proceeding with the transection. In enucleation, you don't expect major pedicles, portal pedicles, or major biliary radicals. Every 5 minutes, I will be releasing the Pringles. Here, once I take out the cystic duct, and the cystic artery, you'll see the hemangioma getting lifted off easily. This is the gallbladder. As you encounter the vessels, you can easily, actually during laparoscopy, due to the positive pressure, the chance of bleeding will be less comparatively. Here the cystic artery is being cut, followed by the cystic duct. Then I'll be coming from the opposite side. The specimen has been transected. This is the hemangioma. Then the hemostasis part. I will be taking the help of gauze pieces. Here you can see the final look after the hepatectomy. So in enucleation, here there is only one stump, there is cystic duct stump. Specimen is being extracted using a specimen bag, and the specimen was extracted from the small phalansteal incision. So I'll quickly go to the second patient. The second case is a 44-year-old female who presented with a pain in the upper abdomen of long history on and off. She says that the pain has been bothering her, so we decided to subject her for a surgery. Here the hemangioma was deep-seated within the parenchyma, so we planned for a left lateral sectionectomy. So the imaging, can you discuss about the imaging of this patient in fast image in a couple of minutes? Podium.
So this is another case of classical cavernous hemangioma. It is appearing hypodense to isodense on non-contrast images, and on arterial faces it is showing peripheral nodular or globular enhancement with interruptions, and further clumping and centripetal enhancement with central scar in the delayed images, which is not enhancing. As it is more than 5 centimeter, we can expect this scar, but it's still a classical hemangioma. So it's partially exophytic, almost 50 to 60% is exophytic, we can say.
File is not able to open the file.
request Dr. Fanny Krishna Rao sir from KIMS Kondapur to share his insights on the benign SOL of liver, followed by Dr. Sridhar Reddy sir from KIMS Hospital to share his views from IR point of view.
More than 10 centimeters, we can describe it as a giant hemangioma. So as the hemangioma gets bigger, the chance of symptoms is more. The technicalities of surgery in terms of your approach, you really have to think about it because there's increased blood loss, perioperative morbidity, and risk of complications. The complications, the Kasabag-Meredith syndrome, we rarely see it, but more often we see sometimes cytopenias like leukopenia and low platelets because of the consumption in it. And rarely intrahemangioma bleed with pain. So my focus is going to be on really large hemangiomas. I mean, is there a word to describe hemangiomas which are more than 25, 30 centimeters? There's no terminology. In some literature, when they've looked at hemangiomas size in correlation with complications, they've used the term enormous hemangiomas. So, more than 10, they've called it giant, and more than 15 or 20 centimeters, they call it enormous hemangiomas. So I guess my talk is about really enormous hemangiomas, because understanding the principles of how to approach an enormous, large hemangioma tells you a lot of principles of liver surgery. In fact, you would understand better. So when do you operate these patients? One is, I mean, of course, one thing I say is, hemangiomas, most of the surgeries done are unnecessary. I think in GI surgery, if you look at splenic trauma, lap adductolysis, and hemangioma resections, these are the three, most of the time, many times unindicated surgeries are performed. So it's very important which cases do we do surgery and which cases we follow up. Of course, if you have a doubtful diagnosis, you're not sure it's hemangioma on imaging, it's better to resect it. And symptoms, so data has shown that patients who have chronic symptoms, they're unlikely to resolve. If a patient has hemangioma, let's say a 11 centimeter hemangioma right lobe with chronic pain, those kind of symptoms are unlikely due to hemangiomas because there could be some costochondritis, musculoskeletal pain, neuropathy or something. While acute symptoms, like patient has a sudden episode of bleed with acute presentation, those kind of symptoms are more likely to resolve. We keep quoting rupture as a complication of hemangiomas. I've never seen it. A free peritoneal rupture in literature also is extremely rare. So that it's, as an indication, it's not this thing. Well, what about increasing size? So if a hemangioma is increasing in size progressively, definitely it's something we should consider. The site of hemangioma has an important bearing in making this decision. Intraparenchymal hemangiomas, in which they're compressed by parenchyma on all sides, they generally don't tend to enlarge much. But subcapsular hemangiomas, which are sort of expanding into the abdominal cavity, they tend to enlarge. So let's say you have a patient with a hemangioma more than 10 centimeters, the so-called giant hemangioma, comes to you. If they're asymptomatic, one option is you could just follow them up. About more than 2 or 3 centimeters in a year, if it's increasing in size, at some point in the future, you could take a decision for surgery. But if it's a very large hemangioma, even if the patient is not symptomatic, like more than, again, I don't have a set number, but more than 25 centimeters, more than 30 centimeters kind of hemangiomas, if technically feasible and patient is fit, you should operate. The reason is it's grown to this huge a size, and if patient has a decent life expectancy of at 10 years or more, you expect it to grow bigger and bigger and create challenges. The appearance of the hemangioma can have a bearing. on the CT, if it's hypodense, or on the ultrasound, if it's hypoechoic, it's generally likely to enlarge much further. It's a very heterogeneous and a hyperechoic hemangioma. It is, it is unlikely to enlarge. Hormone therapy in women and pregnancy is a known documented about 30% of the hemangiomas, 30% increase in size occurs during the pregnancy. So before I just talk about giant hemangiomas, especially when you have a huge hemangioma, there's a debate about whether we do a hepatectomy or enucleation. Suresh showed, I think, enucleation one. And so which cases do we do a hepatectomy? Which cases do we do an enucleation? I mean, I wish Madhu was there. He is one guy who always believes in hepatectomy for hemangiomas. I'm always for enucleations, but it's not like very sacrosanct. You can sort of categorize it in a case-wise manner. Literature shows that overall, definitely going in because there's a good plane there in the hemangiomas, the bleeding, the bile leaks, duration of surgery, all these factors wise, enucleation is a better surgery for hemangiomas. While in comparison, postoperative morbidity and mortality overall are similar. So for left-sided hemangiomas, peripheral hemangiomas, you should enucleate always. Where would you sort of consider resection? I think central hemangiomas, like the video which Suresh showed, enucleation is still a good surgery, but I'd be very skeptical if it's going on to the hilum, because when you're doing the enucleation, you can damage the bile ducts, you can damage the inflow, and so you should keep it in mind that in those kind of cases, you could potentially look at resection as an option. So, and I'll show you two cases. For example, something like this. We have a pointer? Something like this kind of hemangioma on the left side, with a lot of intraparenchymal extension, and you see it's going on to the hilum. We would definitely, this one? Wait, which is that's okay, that's okay, fine. If this is not the pointer marker, is it? So that's okay. So if with so much of intraparenchymal extension, I would definitely consider a resection rather than an enucleation. I think you can understand, because if we enucleate, there's so much of parenchyma we're going to be bearing with high chance of bile leaks and bleed from that. In this case, and it's going onto the hilum, a resection is better. This is another thing which actually I had a couple of cases, then I really looked at literature a lot. This is something called, this is a case which I'm going to show. It's a diffuse nodular hyperplasia, it's described as, or diffuse hemangiomatosis. So here you see, compared to the other cases where, like, for example, the case on the left, the plane is so neat between the hemangioma and the liver. But here in that, you see that there's a lot of small hemangiomas. Is described as diffuse hemangiomas. So in this kind of a patient, there's no plane, clear-cut plane. You do have hemangiomas in which there's no clear-cut plane. So in those, if you try to enucleate, you will actually end up in more bleed. So if you identify that pre-op, it's better to resect. So this is one patient. I'll just talk about three giant hemangiomas, three really enormous hemangiomas, and how we approach those cases to give you an idea. This is a very large hemangioma. You can see all the typical features which Lakshmi described. You can see the diffuse nodular hemangiomatosis in the transition zone between the hemangioma and the liver parenchyma. So it appears like really huge and very daunting actually. If you're beginning in liver surgery, you think, okay, this is a really challenging surgery. And when you open also, it really looks like, how do we tackle this giant hemangioma? But one thing I'll tell you, hemangiomas which are expanding into the abdomen, I'll tell you the reverse scenario later, but if they're expanding into the abdomen, it's safe only. So you are able to lift the hemangioma. Once you're like, the uterus or this thing, you can actually deliver it into the wound, and then you have very good access to both the hilum as well as the outflow. So once you go in this kind of hemangioma, it's obviously replacing almost the entire left lobe. So it's moot. Am I doing a resection or a enucleation? But like I said, because the hemangiomatosis, you can see the transition there where the yellow arrow, that's the normal parenchyma. This is the hemangioma it's ending here, but the rest of the liver, you can see the diffuse nodular hemangiomatosis. And is this pointer points with the light or something? No, I don't think it's. So you can see the differentiation there. Is it a light pointer or? Sure. Oh, okay, sure. That's good. Thank you. You can see that. That's the normal liver parenchyma, and this is the area of the diffuse hemangiomatosis. So you go in, you have to occlude the inflow. The hepatic artery is fairly simple. But again, when very large hemangiomas, be very, very careful when you're doing the inflow occlusion. because the assistant is pulling up the liver to his side, you're retracting, and very often, and things are very stretched out, you can confuse the, like for example, this is the left portal vein. You have to make sure, you could see the right portal vein going down there. You have to make sure you identify the main portal vein, the right portal vein, and the left portal vein before ligating the left portal vein. Because with the splayed out on the hemangioma and the distortion caused by the assistant retraction, you could confuse the anatomy. So you always make sure that you see the right and the main before you ligate the left. And like Suresh was describing, basically, once you ligate it, at the end of the surgery, by the time you take out the specimen, it really looks very unimpressive. The huge hemangioma looks very unimpressive. Again, bile duct in these kind of hemangiomas, for the left it's okay, especially for the right, you really need to make sure that you are not injuring the main common bile duct, because it can again get straight and fragile. This is the left hepatic duct. I'll just show you a brief video. I didn't put much because Suresh already told me that he's showing the videos of hemangioma resection. So in this case, this is like a standard parenchymal transection, the two-surgeon technique. The surgeon on the right uses the CUSA, the Liga clips, and a bit of the some vessel sealing device. And the surgeon on the left, we give him suction and bipolar. I mean, that's the very standardized and very efficient way of doing a hepatectomy. So in this, nothing much to show. It's like a standard hepatectomy technique. Towards the end, I'll just show you the difference. Again, I'm just trying to demonstrate here on table. That's the standard enucleation plane we would go through. But here you see you had all these diffuse, multiple fine hemangiomas. And you can see the liver there. You can see it's completely normal. So in this kind of a case, a resection would be required. So again, like I said, by the time you do the inflow occlusion and you get the specimen out, it looks probably 1/3 of what its original size is. This is another sort of similar case. The reason why I put it is here you can see the plane between the hemangioma and the normal liver, which is very good. And then you have a lot of patients, like he said, 10 to 20% have multiple hemangiomas. What do? There's no need to dig around for all the hemangiomas. I mean, you can just put them under observation, especially if it entails unnecessarily extending your parenchymal resection. So in this case, like for example, these kind of hemangiomas, which are not really exophytic much, these are almost intraparenchymal, subcapsular, but they're not really exophytic. We can definitely leave them alone, and there's no need to operate and remove all the hemangiomas. So this is again a huge hemangioma, and we did enucleation for this. Again, like I said, it looks very big, but we can deliver it out of the wound and resect it cleanly. This is just a enucleation. I mean, again, this is so like Suresh, I will repeat a few points which Suresh said. The Pringles nowadays we've started doing the way he described, but this is an older video. So the enucleation, one thing is you don't need a CUSA for it. CUSA is a good instrument for enucleation, but if you don't have, it's absolutely easy to enucleation with a gentle dissection with your suction, or even with your any vessel sealing instrument. Just gently keep pushing and peeling off. Ideally, it should be peeled in enucleation, but be liberal with these all these strands of tissues, because enucleation is a plane, but there's a lot of vessels and Glisonian structures entering the hemangioma as you enucleate. Keep liberally clipping and dividing all of them. And there you can see, even in Suresh video I was seeing, and in this also, at the base, behind you can see some whitish Glisonian pedicle there in that video. See at the back there, in that area you'll see a Glisonian pedicle. So major pedicles will come. So that's one advantage of enucleation, because in the hemangioma sort of splays out all the crucial structures, and when you go enucleation, you can work on the hepatic veins but save them, because there's already a neat plane. This is a challenging hemangioma. So this is a kind of hemangioma, it's occupying the entire right lobe, and you can see that. But like I said, this is also, when you open, it's sort of protruding into the abdomen. So once it's protruding into the abdomen, you can lift it and you can work under it and do the surgery. So, especially for right-sided hemangiomas, if you're attempting these surgeries, few points, always have suprahepatic and infrahepatic IVC control, whichever way. So in this case, actually, it slung the IVC below the hemangioma, above the hemangioma. We didn't sling it, but we had enough place to put a clamp. And if early inflow occlusion, if possible, in hemangiomas, one thing that's described to further reduce bleeding is the outflow occlusion. You can, if you have access, like you're doing a left-sided hemangioma, the LHV, MHV common trunk, if you can clamp, if that will further reduce the bleeding. And like I said, in these giant hemangiomas, beware of the portal vein anatomy. And bile duct injury during cholecystectomy, we sort of talk a lot about, obviously it's an important point, but that's bile duct injuries during hepatectomies is another major topic actually, especially for these kind of large lesions which play out the bile ducts. The bile duct is played out on the lesion. So be sure of the biliary anatomy and not just the intraop cholangiogram, that you're making sure that you're dividing the bile duct correctly. And also we do the post-op propofol cholangiogram. When we have these large raw areas, in the past 3-4 years, we've started doing routine propofol cholangiograms for all hepatectomies. That has really helped us reduce the incidence of bile leak. So this patient, so we did the entire, this could be fairly easily removed. The same situation for a right lobe hemangioma. What is a challenging situation? This is not my case. Actually, this is I got an image I got on the internet, but I have had bad experiences with similar kind of cases. So it's always good to learn from the mistakes of your seniors. So when you have this kind of a hemangioma, the difference between this and the previous is huge. That was actually bigger. But this is projecting above onto the diaphragm and splaying out the diaphragm while that is projecting below. So in this kind of a hemangioma, when you're trying to separate and gain access above, you're at risk of tearing the hemangioma, you're having uncontrollable bleed. So I would be extremely careful in this. So in this, if I get this case now, I would go for to be the safest, I would go for an IVC control, do a partial sternotomy, or we can do a pericardiotomy. From the abdomen, we can open the pericardium and gain access and sling the suprahepatic IVC there. Below, I would sling the IVC, of course. Have proper IVC control, because it is very easy to lose control and have massive bleeds during this kind of hemangiomas. And if I was attempting this kind of case, it would be, I'd plan for total vascular occlusion. Total vascular occlusion is not just having control. You should prepare your anesthetist for this kind of a case. Okay, I'm going to do a trial clamp when the situation is cool. How does the patient tolerate it? What is he supposed to do when you do the clamping? What is the exact sequence of clamping? If you clamp the IVC first and forget the Pringles, the patient is going to just bleed like hell on table. And ideally, in the current, if you're in a good multi-specialty setup which has a good cardiac unit, I would do this case under a veno-venous bypass. I've done such cases previously, but now I'm waiting for one such case. If I had it now, it would be a veno-venous bypass. I think so Sridhar is going to talk about transarterial embolization. In the context of a giant hemangioma, this is often a debate. I mean, in our groups also, one of the surgeons puts it up. This giant hemangioma is obviously risky to operate. Should we go for TACE? A few points, on TACE. Definitely in patients with complications like a rupture or patient has some severe cytopenias, DIC, and if they're unfit for surgery, TACE is transarterial embolization is a good option, embolization or TACE. Well, if the patient is unwilling for surgery, I mean, you feel that he needs surgery, but it's a benign lesion. Why do I go for surgery? There's nothing, this thing. If you want to go for TACE, there is a risk of this post-embolization syndrome, biloma, necrosis is there. We should discuss that with the patient. So in the context of preoperative, should you embolize a preoperative giant hemangioma, 40 centimeter hemangioma, to shrink the size? That's one thing that a lot of people propose, but based on experience of others and literature is something I would strictly not recommend. Two reasons. One is early post-op, one is late post-op. Early post-op, what happens when you embolize for HCCs and hemangiomas? I've had personal experience also. When you embolize, there's so much of necrosis in the tumor that once you start handling the tumor during surgery, there's going to be a lot of TNF and all this cytokine release. The moment you handle, patient goes into hypertension. The moment you release, he comes back to normal. So it's become a very difficult surgery. So immediate preoperative, I would definitely not recommend. And late revascularization, again, this is my colleague, Dr. N.R. Dash in AIMS. They did some, for giant hemangiomas, embolization went in a month later. Again, he says that, again, literature also describes it, because the revascularization, there's an increased incidence of bleeding, and he's found the surgery much, much tougher than what we would normally expect. And then, especially in the context of very large hemangiomas, Maybe Dr. Sridhar can also clarify this point later on. There are studies, most of the studies report 1-year result, 2-year result, in which all of them there's excellent shrinkage. But when you follow up for a really long period, let's say 5 years, 10 years, obviously because these are benign diseases, you want a very long-term follow-up. Most of them have regrowth. Almost 2/3 of them in one large series of about 150, 170 patients, 2/3 had regrowth beyond 5 years, and half of them end up going up to the table. And the larger the hemangioma, the less the long-term efficacy. I mean, like you said, it was less than centimeters, or half of them it was efficacious or long-term, but in more than 20 centimeters, almost 90% of the patients it was not successful. So to conclude, select hemangiomas judiciously. I mean, I think it's, again, I repeat, it's like one of the areas where unnecessary surgeries are done. Just make sure you're doing justice to the patient. When you go for control the inflow always for hemangioma, like Suresh described. Giant hemangiomas, absolutely important, have outflow control. If not, you don't want to have an on-table death on hemangioma, which is possible when you have giant hemangiomas. Resection versus enucleation debate, we've sort of this thing, and if there is intrathoracic extension, be extremely beware of it. Don't just rush in heroically. You really need a lot of planning, and you need to discuss with your colleagues before you plan the surgery. Thank you.
Thank you, sir. It was a very insightful presentation. Now I request Dr. Sridhar Reddy, interventional radiologist, to share his thoughts from IR point of view, followed by which there is a second master video. I request Dr. Vimalakar Reddy from Team Vimalakar, HOD Senior Consultant, Kim Sunshine, to present his video. Thank you.
Good morning, everyone. To begin with, I thank Dr. Vimalakar and his team for involving the diagnostic and interventional radiologist as a part of this CME. Coming to my presentation, role of intervention radiology in the management of hepatic venous malformation. According to the mission, and should not be called as hepatic hemangioma. Coming to my case, this is a 7-year-old male, consulted local doctor for pain and swelling in the right upper abdomen, investigated with an ultrasound followed by a CT scan, which showed large hepatic venous malformation in the right lobe of liver. Advised surgery. Patient was not willing to undergo surgery. So the cardiologist, known to the patient and to us also, referred to IR department to see if any minimal invasive procedure can be done to reduce his symptoms. This was the CT scan done outside. Which shows a large hepatic venous malformation occupying entire right lobe of liver and extending from the dome of the diaphragm down inferiorly into the pelvis, displacing the kidney inferiorly and medially. The size measures around 22 centimeters and the volume is around 4000 cc. These are the representative images. Like whenever there is a peripheral nodular enhancement, centripetal filling, and persistent of contrast in the delayed scans, then we are very sure that it is a venous malformation. So this we can see, like it is elevating the right dome of diaphragm, almost is extending from the right dome down almost up to the level of iliac crust. So we planned to go ahead with transarterial chemoembolization using, and he has also suggested that he might need 2 sessions of TACE, admitted and informed consent taken. Routine blood investigations were done within normal limits. PAC was done, started on prophylactic antibiotics, single dose of 8 mg of dexamethasone given to reduce post-embolization syndrome. This is how we perform the procedure. Under ultrasound guidance, we puncture the femoral artery, then we'll navigate a catheter into the celiac axis, then into the common hepatic artery, and in this case into the right hepatic artery, and we'll try to reach as close as possible for the feeding artery which supplies the lesion. So bleomycin comes in a powder form, and we'll dissolve it in 5 cc of normal saline and then we'll mix 10 cc of lipidol using standard 3-way stop cloth to make a thick emulsion. What does bleomycin does? It is a cytotoxic antibiotic with potent anti-tumoral activity. So it not only causes destruction of the endothelial cells, it also inhibits cell proliferation. So why don't we use only bleomycin? The disadvantage is like it is very thin, not a viscous, so it will not stay in the tumor for a long time and escapes into the systemic circulation. So the cytotoxic endothelial damage will be less, and it is also not radiopaque, but we can make it as a radiopaque by mixing with contrast. But what does lipidol does? It is a viscous radiopaque oil based contrast agent. It serves as a carrier for the chemotherapeutic agent, enhances its localization within the tumor, and prolongs its contact within the target cells. It also has embolic effect, contributes to blocking the blood supply to the lesion, inducing ischemia and subsequent tumor shrinkage. So this catheter, this is the cobra catheter. By seeing the shape, we can say that's a cobra catheter. This is a celiac axis run. So the celiac axis is very tortuous. Normally we'll expect in the midline, and the splenic will go this side, and the common hepatic is very tortuous. So this is the splenic artery, and then this is a common hepatic artery. In the next step, we'll try to negotiate the catheter into the common hepatic artery over a guide wire. This is the hepatic artery run. So there is a puddling of contrast, which are the vascular venous spaces which are being filled with the contrast. We can see all this puddling of contrast within the vascular spaces. So then we started injecting the bleomycin and lipidol emulsion into the lesion. So these are the DSA runs just before the procedure. Like we can see all the puddling of contrast, and then after the embolization, almost we can see the near stasis within the arteries, and no more like a filling that with the contrast. Post-procedure embolization is because of necrosis and systemic inflammatory response due to the necrosis. So which was, and in this patient it was very mild and was managed with adequate hydration, antiemetics, antipyretics, analgesics, and antibiotics. Patient was discharged on second day on oral antibiotics and analgesics. Asked to come for second session of test after 3 months. Like this is the CT scan when he came for follow-up after 3 months. This is the baseline CT, and this is the recent CT after the first session of test. There is a mild reduction in the size, like around 2 centimeters in overall the diameter, and the volume reduction is almost close to 1200 cc. So second session of test is being performed. Like after this end result, like where there is no, almost the vascularity has been cut off to the lesion. Instead of 1 year follow-up, we came nearly after 2 years. Sorry. This is the CT scan. On the left side again is the baseline CT scan, and this is the recent CT scan. Now we can see almost the tumor has reduced to 1/4 of the size of the baseline CT. So the size right now is around 9 centimeters, and the volume has come down to close to 800 cc. So this is the representative, when compared to the normal liver, this is almost 3 to 4 times size of the tumor was 3 to 4 times, and this is the first follow-up where this almost, when compared to the left lobe, it's almost equal to that of this, and now it is almost looks like 1/4 the size of the normal liver. And the percentage reduction was almost 40% in the after the first TACE, and is almost close to 81% after the second TACE. Technical success was successful embolization of all the feeding arteries, and the clinical success was reduction of the tumor or the venous malformation by 50% or more, and also in the relief of the symptoms. In our case, both the technical success and clinical success were achieved. Hepatic venous malformations are the common benign lesions composed of endothelial lined vascular channels. Cavernous subtype is the most common and strong female predominance. Majority are asymptomatic and non-progressive, often discovered incidentally during imaging. These are the various imaging modalities where we can help for diagnosing the venous malformation. Anything less than 4 are labeled as small and medium and requires no intervention. Giant hemangiomas, if they are more than 5 centimeters, and according to Chinese scholars, they say it should be more than 10 centimeters to call a giant hemangioma. Sorry.
Thank you, sir. Thank you for the broadened outlook to the hemangioma. Now I request Dr. Vimalakar Reddy from Team Vimalakar to share his master video and share his insights over hemangioma.
This is not the reason with the makeup of reason that is the hemangioma is the reason for pain. So such a case, one such case we had, 40 years old lady presented with dragging type of pain, right upper abdomen, right hypochondriac region for almost 1 year. She has come for 3 to 4 follow-ups. We told, we have done CT scan, we told this is not the reason. We tried to explain, even we have explained about the TACE also if you are that much worried. But obviously somebody will tell that that is the surgery is the option. So this is the case. If you see in the 6th and 7th segment, there was a 10 into 5 centimeter lesion with classical arterial phase peripheral puddling with the centripetal filling in the portal venous phase, followed by complete fill in contrast appearing isodense or hypodense in the delayed phases. So for the sake of postgraduates, in all hepatectomies, the patient position usually will be the steep head-up position with, based on the condition, right up or left up, and you will be placing one sandbag just below the right lower chest. And always you have to have a central line. If you're doing Whipple's procedure, if you don't put central line, we don't mind, but for all laparoscopic hepatectomies, you have to have a central line. Why? Because you are having a positive pressure in the abdomen, and apart from that, if you open any portal vein, hepatic vein or IVC, the CO2 embolization and causing sudden death will be there. That's why always you should have a central line in, apart from bleeding, central line in liver surgeries. This is a common port position for all hepatectomies. So apart from central port, right side, why did I put 10 mm port? Usually for the clipping purpose, we should be ready with the laparoscopic bulldogs also. So to apply bulldogs, to apply clips, so better to have a one more 10 mm right hand port. So this is the lesion in the segment 6 and 7. You've seen, by now you've seen enucleations, you've seen open hepatectomies for hemangiomas. So is there any role of classical sectorectomy? This is a right posterior sectorectomy. If you have lesion in a proper position, if you see in this case, it is properly located in the 6th and 7th segment. So than enucleation, I think we can go ahead with the proper right anterior posterior sectionectomy. So portal pedicle control or Pringle's maneuver with the usual I do with that gauze, and that is the reverse sulcus. So identifying the right posterior sectoral pedicle is the key. Doing right hepatectomy, doing left hepatectomy, to my knowledge, it is easy. But doing one sectorectomy is a difficult task. In this case, I still remember I had to call Gayatri to confirm the right portal early bifurcation. There is no stump at all. So 6th and 7th were coming immediately. So if you see, while controlling, that is the right posterior pedicle, immediately 6th and 7th segment it has given. So I can't use stapler, I can't use clips also. That's why one clip, two clips towards the common trunk and two separate clips for the 6th and 7th segment we have placed. And there is the right posterior sectoral artery. I was clipping. So in all right-sided surgeries, better to go for gallbladder cholecystectomy. But if you just clip the artery and cystic duct, and if you use that gallbladder for the retraction, that will be good. So if you see, I was placing clips towards the trunk 2 and 6th and 7th separately. So artery and portal vein is done. For the right posterior sectoral duct, basically it is little bit intraparenchymal, so I don't want to meddle with it. So just I isolated and kept it, and from the parenchyma side I took it. So this is a clear line of demarcation with the hemangioma. So this is one more technique recently I have started doing with the barbed suture. Use barbed suture and put one clip down and above, so the chances of slippage and cut through will be less. In one more other master video, without this stay sutures also we can do hepatectomy, that we were going to show. And this is a clear line of demarcation. You need, for the 6th and 7th, as you know, this is the right posterior segment, sector, so you have to mobilize the right lobe of the liver properly. Those are posterior adhesions to the liver. And parenchymal transection under low CVP has started. Here, how to do? Usually you score with the monopolar, then you start doing with the harmonic, and you skeletonize the portal pedicles with the CUSA. Usually this is a 3D video recorded in 2D, that's why the color is not matching. So those are the hepatic veins of the segment 7. So then followed by parenchymal transection is going on. After 6th and 7th hepatic venous control, so it is easy to go with the parenchymal transection. Almost I am at the end. So this is to show that, so if it is in the one sector, you can go ahead with the proper anatomical sectorectomy, and laparoscopically you can handle. The difficult sectorectomy is 6th and 7th and 5th and 8th only. 5th and 8th also reasonably easy, but 6th and 7th because it is posteriorly located. But in this case it was hanging, and we could control the portal pedicle well. We could do that, and the patient got discharged on 3rd or 4th POD. So with this, I think we are going to close this session, hemangioma session. We need insights from Shastri sir and Pratap Reddy sir. Then we don't have any formal handing over of mementos. We will take one group photo.
Sir, kindly share your insights. Thank you.
Good morning, everybody. Wonderful discussions. My compliments to all the speakers, and of course compliments to Vimalakar for the wonderful initiative of a single theme. We're of course eagerly looking forward for further episodes of this series. Now, as far as hemangioma is concerned, a perspective is important. As is repeatedly emphasized, it should decide on when not to operate on these lesions, and most of the time they do not require surgery. The problem is because of the difficulties in assessing the symptomatic nature of the hemangiomas. You say they are painful, but pain, abdominal pain being such a non-specific symptom of hundreds of abdominal lesions, attributing pain to hemangioma is one of the very difficult tasks. Now, exceptions in surgery are important. Exceptions sometimes are more important than normal because it gives us a lot of scope for a depth into the discussion of why they are exceptional and why exceptional decisions have to be made. Now, the hemangioma, yes, the exceptions are mentioned here. The other exception I would think of is a small hemangioma in the liver, absolutely atypical as far as its vascularity is concerned, the flow patterns on imaging are concerned, and it's impossible to sometimes differentiate from more ominous lesions like secondaries or primaries. It's important to recognize these, and it is this kind of situation which is important for us to decide on, one, whether to keep them on a closer follow-up and do short-term imaging follow-ups, or do a biopsy, or do an excision itself. These difficult decisions are sometimes, they would require second or third opinions, and they cannot be made by a single person. We should also probably discuss with the imagiologists what make them the exceptional. Is there anything, any small clue as far as imaging is concerned to explain their symptom in that, so that we can shortlist these patients for major intervention. A sectionectomy or even a resection procedure is quite a major procedure for a benign lesion as hemangioma, and one should think twice or thrice before we decide on that. It's important lesson for the junior colleagues here. Don't jump onto sectionectomies just because you see a video here. I think it's very important lesson. I think these are the few observations I thought I'd make.
I think for the sake of residents, in the management of hemangioma, you should remember, irrespective of size, if patient has minimal symptoms or no symptoms, observation is the best treatment. If symptomatic also, now with the availability of interventional radiological treatment, to give the option of non-operative management has come into discussion. So we should put it across to the patient. Very few hemangiomas lead to complications like spontaneous bleeding or death from complications due to platelets being trapped in the thing. Almost all of them can be managed by non-operative means, including interventional radiology. Surgery for joint hemangiomas which are symptomatic, you should remember that enucleation is considered the best treatment. Very rarely resection is needed. And before you decide on resection, you should remember resection carries more morbidity compared to enucleation. Whatever little problems occur in enucleation, they are on the table. Slight more bleeding, things like that. But you don't get complications like severe bile leaks or things like that in enucleation. So remember that conservation is the goal you should think of in management of hemangiomas.
Thank you, sir. Thank you for the enlightening session. Now we'll proceed further with the second session of GICS, that is malignant SOL of the liver. I request Dr. Venumadhav Tuma from NIMS Hospital, Professor, and HOD Consultant, Dr. Gayatri Senapati, Radiology, and Dr. Senthil Nathan, Senior Consultant from GEM Hospital, Chennai. He will be presenting through the online Zoom, and Dr. Gaurang Shroff from Team Vimalakar to share their insights on malignant liver SOL. Yes. I request Dr. Ved Madhav sir to start with the clinical presentation, where Gayatri madam from radiology will simultaneously discuss about the case findings.
Yeah, good morning everybody. I thank Dr. Vimalakar and his team for inviting me. So today I will be presenting a case capsule of a young girl. She is around 12 years old, and she is symptomatic for the last 2 months in the form of pain abdomen. She had a visible lump as well, and abdominal distension, and in the last 2 weeks there is increased pain abdominal abdominal distension. When we were evaluating, there was increase in size of a lump and abdominal distension. That's the patient complaint. But there was no history of jaundice, fever, vomiting. Examination revealed a firm to hard lump in the epigastrium, smooth surface, moving with the respiration. Initially non-tender, but later on mild tenderness was there and pain abdomen was there. She was evaluated with ultrasound abdomen, which showed a heterogeneously hyperechoic lesion of size 12 into 9.7 centimeters in the left lobe, with minimal vascularity and area of cystic degeneration. There is no evidence of calcification. It's not coming. Normal CBP was normal, LFT, INR, everything was normal, creatinine. And because the CT was showing, ultrasound was showing left lobe, we proceeded with CCT triphasic, which Gayatri will present now. I will hand over Gayatri.
Very good morning to all the seniors present here. It's a privilege to be here, and my immense thanks to Team Vimalakar for this wonderful opportunity. And I think it's a great idea to have a collaborative meet like this, where surgeons and radiologists and interventional radiologists discuss cases. It'll be of benefit to radiologists as well as surgeons. We become better radiologists only with clinical inputs. So coming to the imaging of this patient, here I've projected, this is a triphasic CT study. So we are starting with the plane, and the one to the next one, 1 second. Yeah, my arrow is visible, right? Okay, so this is the arterial phase, where we can see bright contrast in the artery, in the aorta, and in the other vessels. This is the plane phase. Now what we can see on the plane studies, there's a large lesion, appears to be predominantly involving the left lobe. So first thing we do whenever we look at a liver SOL, which we'll subsequently discuss, is see if it's a cirrhotic or a non-cirrhotic liver. Now in this case, we look at the age of the patient. Now we know this is a pediatric case, which brings in a few additional differentials than what we would consider in adults. Now to locate the lesion, we have the gallbladder here. So the whole lesion is to the left of it predominantly, at least on this. We will further confirm in the contrast portal and venous phases. So this is the lesion in the left lobe. It's partially exophytic. We can see it going beyond the confines of the liver anteriorly. And how is it on the plane? We're seeing some puddles of areas which look hyperdense. Even caudally. We see some hyperdense areas, meaning the lesion is predominantly hypodense. So whenever we say hyper or hypodense, we are comparing it with the surrounding normal tissue from which it's arising. So this is the density of the liver. Compared to this is less. So this is a hypodense lesion and having some interspersed hyperdense area. Are there calcifications? No. If we were to see calcifications, they would look similar to that of the bone here, like the spine or the lips. Now in the arterial phase, what are we seeing? We see that one thing that the lesion is doing is, it is compressing and displacing the common hepatic artery posteriorly. What about any enhancing areas? So we are not actually seeing enhancing tissue, but we're seeing prominent vessels feeding the lesion. Now here in the cranial part, you can see areas of prominent arterial feeders. Now even caudally you can see that. And you can notice that the areas of these puddles of hyperdensity or hemorrhage are close to these arterial feeders. So that is one finding. We are actually not seeing enhancement within the mass in this early arterial or the angio phase, but we're seeing prominent arterial feeders. Let's next go to the portal and to the venous face. Now in the portal phase, we can see that these same feeders are a little more prominent. Now we can localize the lesion better here. Now we've come to the cranial most section. This is the IVC. So to divide between the right and left lobe, I don't have to tell the surgeons, you're all experts in this. When it comes to the Conard segmentation, anything to the left of the middle hepatic vein would all comprise the left lobe of liver. Now we can see that the gallbladder is somewhere here. So this would be segment 4. What we can see is it's become very small. The segment 4 is kind of compressed, it's become a little atrophic. That's the rest of the left lateral segment here. So the lesion is in the left lobe. You can still see some part of the middle hepatic vein. The segment 4 is also involved, so is the left lateral segment. Now what's it doing to the portal vein? Now this is the main portal vein. This whole portal vein is coming into the right lobe. So what we are seeing here is the right anterior and the right posterior portal vein. Are we seeing the left portal vein? I don't think. I can't see the left portal vein. So I'm assuming that it is compressed or probably even thrombosed. Now how can we see better? Let's go into the coronal plane, along which as surgeons you visualize the liver and the tumor. So in the coronal plane, this is that's the main portal vein, bifurcating. But is it actually bifurcating? This whole thing is going to the right lobe, which means that this whole thing is the right portal vein. You have right anterior and right posterior. So I'm going a little posteriorly, that would be the posterior anterior. Now the left portal vein should have been somewhere here. We can actually see that it is thrombosed. It has been compressed and it is thrombosed. So the information that we as radiologists are expected to give is, one is localize the lesion, characterize it, and see what it's doing to the surrounding vascular structures to help guide the surgeon to plan the surgery better. Now what is happening to the tumor? Are we seeing progressive, any enhancing stromal tissue? Are we seeing any solid component which is enhancing? It looks actually predominantly hypodense, predominantly cystic, but with some prominent vessels in the periphery. Now a plain MRI was subsequently done for this patient. Now we can see actually, we can obviously see that this is the axial and the coronal T2. A contrast wasn't done. Now on this axial T2, the lesion looks very, very heterogeneous. You're seeing areas of all kinds of signal intensity. There's some fluid, there's some hypo areas, some hyper areas. It looks very dirty and heterogeneous. But what we can also see is, Venu sir just told me that the gap between these two was like less than 2 weeks. In less than 2 weeks, the tumor has enlarged significantly. It looks like it has lots of cystic areas. And on the coronal, we can see that there's a large exophytic component axially, probably infiltrating the parietal wall as well, though you can predominantly see a plane. It is displacing the stomach further, and on coronal, it's closely abutting and probably elevating the diaphragm as well. So not only has the lesion grown, we can also see a greater mass effect over the surrounding structures in the very short span that we've seen in. All right. So we're looking at the same thing in the axial plane, 2 different sections. There is T2. So these are axial T2 and these are axial T1. Now for the benefit of residents, be it surgeons or radiologists, how do you differentiate between T1 and T2? One thing you look at is, look at the CSF in the spine. When you see a bright CSF surrounding the cord, which means that it is a fluid sensitive signal, which fluid sensitive sequence, which is T2. Here it is all black. You can only see the spinal cord, not the CSF around it. So this is T1. Now on T1, most of the masses are generally hypointense, means they are generally dark. Now exceptionally, when you see T1 hyperintense areas, there are 2 main things we have to remember, most common of which is hemorrhage. When there are areas of hemorrhage, bright signal, it means that it is a very hemorrhagic tumor. Now in a pediatric age group, when we see a tumor which is large, predominantly appearing hypodense or cystic, very heterogeneous with areas of hemorrhage, it leaves us with very few differentials. So we know now that this is an aggressive tumor. So we're not thinking about the benign cystic lesions like a mesenchymal hematoma. We're not thinking of a hemangioma because it is not showing. So you've just seen a session on hemangioma where you see progressive contrast enhancement from the periphery towards the center. This is not fitting into that. Not only is it heterogeneous, it's having areas of hemorrhage. So that leaves us with very few differentials in the pediatric age group. So cystic hypodense liver mass, prominent vascularity, but actually not enhancing solid component. With hemorrhage in a 12-year-old, the most common diagnosis we would think of would be an embryonal sarcoma. The other differential, again, still being a hepatoblastoma. So hepatoblastomas can have areas of hemorrhage and heterogeneity and necrosis. It can also show calcification. But a lesion which is predominantly cystic, you're hardly seeing any solid component, a sarcoma would come first in the differentials. Now, what other malignant lesions can we think of in liver? We can also have an infantile hemangioendothelioma. There can be very rare other kind of blasts, but most common will be a hepatoblastoma, which is generally seen in a much younger age group. Now, this is almost 12. Now, in the later age, we think more in terms of a sarcoma, especially tissues with, so any tumor which looks very dirty with large areas of hemorrhage, whichever part of the body it is in, especially even in the uterus when we look at it, we do think about a sarcomatous transformation. All right, so we'll now go into protocols. Now, we've seen that how a triphasic study helped us characterize the tumor and also look at the vascular involvement of the surrounding structures. So when we're looking at focal liver lesions, how do we approach? First thing we look at is liver morphology. Is it cirrhotic, non-cirrhotic? Because in a cirrhotic liver, we are looking at field cancers. They are prone to developing malignancies because of constant regenerations and dysplasias. So presence of cirrhosis changes the way we approach any tumor, and we directly go into a category called LIREDS to decide how likely it is to be HCC or how likely it is not HCC. The next thing is age, like we've seen in this case. Embryonal cell sarcoma or a mesenchymal hematoma or a hepatoblastoma is not something we will think of in adults, but we will definitely think of in children. The next is it solid or cystic? Now, once we've seen all this, the next thing is solitary or multiple and any known primaries, because once we know there is a primary, our first thought process will be, is this metastasis or not? Now, after that, it is mandatory to characterize almost every lesion. Like if we're looking at a known case of carcinoma rectum, when we're looking at a liver lesion in that case and trying to characterize it, there have been cases where a hemangioma has been misinterpreted as a liver metastasis and there have been trouble. So ideally, when there is a known primary or when you're looking for any liver lesion characterization, please do go in for triphasic. It really helps in many cases. So in a multiphase contrast, what are we looking at? Of course, we will first do a plane to look for areas of hemorrhage, heterogeneity, calcification. We will then go for an arterial. Now, what is the kind of arterial phase you need to characterize a tumor? It is not the early angio phase where only the vessels are opacified. There is more to it. Next thing you look at is a portal or a venous phase. Basically, it's an extracellular phase where the hepatocytes have enhanced and the venous return has started to come. The next would be a 5 minutes delayed phase. So SOL in liver, cirrhotic liver, there's something called LIREDS. I won't go into the details, but this is essential to know because any liver lesion in a cirrhotic liver has to be categorized under LIREDS. We won't just call it a hemangioma or a HCC, etc. We put it under LIREDS and then try to further characterize it. So this was created by the ACR. It has been updated several times. It is used in a newly diagnosed lesion in cirrhosis and also for a follow-up. So even when they're doing an ablative therapy, even after transplant, we have to use LIREDS in such patients. Only for those with cirrhosis or high risk of HCC. We don't use it in a non-cirrhotic liver. The only exception being, anybody? In a non-cirrhotic liver, where can we apply LIREDS? In a known hepatitis B. So if the patient has hepatitis B chronic infection, even if you don't see a cirrhotic liver morphology, we still apply LIREDS. Now in LIREDS, what are the features we look for? This will tell us why it is imperative that we do a triphasic. What we look for is an arterial phase hyper-enhancement, which is non-rim. That is the substance of the tumor and not just the periphery have to enhance. Next is we look for a washout, for which you need a subsequent phase to compare with, and then a delayed enhancing capsule. You can see that all these three criteria require a triphasic study minimum. And then we also look at the absolute size and threshold, and based on all these, we put it as under a category of LIREDS 0 or 1 to 5. So LIREDS 5 will only be if it is arterial phase hyper-enhancing and more than 20 mm, also showing a washout or a capsule. Now everything else will come under 3 or 4. Now once we call a lesion LIREDS 5, it is not even necessary to do a biopsy. Even if AFP is normal, we have to assume that this is a HCC. 4, we look at other factors such as elevated AFP or PIVCA. 3, we have to either follow up or biopsy. So that's about why we use triphasic. In a cirrhotic liver, we have to put it into LIREDS. Now I told you that we require something called a late arterial phase in a triphasic. So what is an optimal late arterial phase? If you are only seeing the artery and its branches enhancing, it is an angio. It is a CT abdominal angio or an MR abdominal angio. It is not a late arterial phase. A late arterial phase is one where the hepatic artery and its branches are fully enhanced. You also see hepatic veins which are not enhanced by antegrade flow, which means that in a triphasic study, you are going to give contrast with a pressure injector. So there will be a specific injector which injects contrast at a rate of about 4 to 4.5 ml per second. Now with that pressure going through the veins, there can be a reflex of contrast into the IVC. But you will still see that even this contrast, if it is there in the IVC, the hepatic veins are still not going to be opacified, which means that the liver hasn't enhanced yet and it hasn't started producing venous return yet. So the hepatic veins should be black. They should be unenhanced. But the portal vein has just begun to enhance. Okay? So if you don't see the portal vein at all, and you only see the arteries, you're looking at an angiophase. So if you don't see something enhancing in an angiophase, you can't say that it is not arterial phase hyperenhancing unless you've seen the rate arterial phase. Let's look at a few examples after this. So having seen all this, what do we do when we see a liver SOL? We have seen whether it's cirrhotic or non-cirrhotic. Then we look at the size, location, and morphology. Morphology on the regular, that is on the plane, and on MR we look at the T1, we look at the T2 diffusion, whether it's restricting or not restricting. Then arterial phase hyperenhancement. Now suppose it's arterial phase hyperenhancing. What do we think of? See if it is homogeneous or heterogeneous. If the enhancement is homogeneous or heterogeneous, because that again changes the differential. Generally focal nodular hyperplasias, whether they have a scar or don't have a scar, will show homogeneous enhancement. Is there a scar? That's the next thing you look at. And in the subsequent phases, is there a washout? And is it paralleling blood pool? This is a very important finding. So we've just seen that in hemangioma, that in whichever phase you're looking at, whatever contrast you see within the lesion will have the same density as the phase of contrast in which it is being done. So the density of the contrast within the lesion will be same as that of the artery in the arterial phase, as that of the portal vein in the portal phase, as the IVC or the hepatic veins in the venous phase. So it will exactly parallel the blood pool. It won't be more or less than that. So paralleling the blood pool is a sign of benignity. And in the first subsequent delayed phase, which has to be done at least 5 minutes later, is there a delayed enhancement? Is there other, we look at other things, like is there capsular retraction? Is there biliary radical dilatation? Is the lesion infiltrating the biliary radicals? So based on all this only, we have to give a diagnosis of what kind of a lesion it is it benign, is it malignant, and then further characterize it. All right. So I told you there is something called rim enhancement and a non-rim enhancement. Now when we're calling a lesion as arterial phase hyperenhancing, it is not enough if it just enhances like this in the rim. It has to enhance within the substance. Look at this. This is a cirrhotic liver. How do you tell it is a cirrhotic liver? The margins are irregular. The fissures will be widened. We might or we might not see ascites. There will be lobar volume redistribution wherein the right lobe becomes relatively smaller and the left and the caudate lobes become relatively larger. Now we're seeing one of the most important findings, which is irregular liver contour. So it is a cirrhotic liver. We see that this mass here is enhancing in the arterial phase. You see contrast in the artery, it is an arterial phase. So it's enhancing in the arterial phase. Whereas here, it is only a rim enhancement. So we will not call this APHE. It's only a rim APHE. So having seen all the criteria, let us look at this liver. We're going to try to characterize whatever we're finding here. So is this a cirrhotic liver or a non-cirrhotic liver? It's a non-cirrhotic liver. So the caudate lobe is small, the fissure, the falciform fissure is not widened, the liver contour is very smooth. Now this is a T2 and this is a T1. What are we seeing here? We're seeing a well-circumscribed lesion. Where is it located? Is it completely in the liver? It is not completely in the liver. It is predominantly involving the left lateral segment, but there is a large exophytic component where it is going into the gastrohepatic ligament, also abutting the stomach. So we've described the location and we've defined it's the non-cirrhotic liver. Now how do we look at the lesion? It is predominantly T2 hypointense, but what else is it showing in the center? There is a T1 hypointense and a T2 hyperintense scar. Okay, non-cirrhotic liver, we have seen a scar. It is well circumscribed exophytic. We'll now look at the triphasic contrast. Now what phase is this? You're seeing the artery, the aorta is brightly enhancing. You're seeing the artery here. That's the left hepatic artery here going, to the left lateral segment. But are you seeing the portal vein? No, not yet. We do not talk about hyperenhancement in this phase. But this, you're seeing reflex contrast in the IVC, but look at this is the hepatic vein. The hepatic vein continues to be black. So it is not a portal or a venous phase yet, but you're starting to see the portal vein here. So this is the ideal late arterial phase, and this is where you look for late arterial phase hyperenhancement. Look at this. How do you call it as hyperenhancing? You compare everything with the surrounding liver. The liver is showing a particular signal intensity, but this is brighter than the liver. So this is a definite arterial phase hyperenhancing lesion. And you also see a scar in the center. Now we are now looking at the subsequent phase. This is a portal phase, the hepatic vein is also enhanced, so this could be a portovenous phase. Basically what we need is, it's an extracellular phase. So what is happening here? The liver is now brighter than the tumor. So compared to the liver, we know that there is contrast washout. Now not only that, you're also seeing an enhancing surrounding capsule. All right? So this is an arterial phase hyperenhancing observation in a non-cirrhotic liver with a central scar, which also shows contrast washout and a enhancing capsule. Now what are the possibilities here? A lesion with a scar which is arterial phase hyperenhancing. There are only two differentials mainly. Of course, you can also have a hemangioma with a scar. You can have a hepatoblastoma with a scar. But this classic APHE with a washout, mainly we are looking at two differentials. We are looking at HCC or with a scar which is T2 hyperintense. This is an FLC. This is a fibrolamellar carcinoma with a scar. The scar will generally be T2 hyperintense in a fibrolamellar carcinoma. So we've seen that how the multiphasic contrast has helped us come to a diagnosis here. All right, this is another lesion. Is this cirrhotic or a non-cirrhotic liver? It's the same case that I just showed you a while ago. I'm just showing all the phases. It's a cirrhotic liver morphology, an arterial phase hyperenhancing mass here. Now in this phase, you can probably see subtle washout, but in the subsequent delayed phase, there is a definite washout with a capsule. All right? So where is this lesion located? Are we looking at the cranial sections or the caudal sections? What can you see here? What is all this black? These are all the lungs. So once you're seeing the lungs, you know that you're in the cranial sections of the right lobe of liver. Is it posterior or is it anterior? I don't know. Maybe this is the right hepatic vein. Because it's a cirrhotic liver, the right lobe tends to be atrophic. Now if I tell you that this is the right hepatic and this is the middle hepatic vein, where would this lesion be located? Cranial segment between the right and the middle hepatic, which means it is in the right anterior cranial. What would that be? It's segment 8. All right, segment 8, there's a lesion, arterial phase hyperenhancing with a washout and with a delayed enhancing pseudocapsule. So in a cirrhotic liver, we wouldn't just call this a HCC, we would call it a Lyret's 5 observation because we know for sure it's more than 20 mm. All right. Now there is another phase called hepatobiliary phase which I will discuss later. Now this is a very, very useful phase in patients where we are trying to differentiate between a FNH or an adenoma. Now for this you have to use a specific contrast in India called multi-Hans. Now we will just look at a few other examples of hypervascular liver masses. So we've seen a HCC, we've seen a focal nodular fibrolamellar carcinoma. Now what are the other possible lesions? All right, I'm sorry about this overlap. All right, so this is an example of a lesion in a non-cirrhotic liver.
Yes, slide.
Give me a second. All right, we've seen a triphasic CT, we'll look at a triphasic MR. A cirrhotic liver for sure, irregular contour, there's some fluid, which means there's ascites. There is a large heterogeneous lesion, which is T2, hyperintense compared to the liver. It's showing restricted diffusion. Now you're seeing several other bright lesions. All of these are not restricting, so we look at something called ADC to decide whether it's restricting or non-restricting. Triphasic, this is more of an angio, but also an RD arterial phase, it's enhancing. And then you see that some areas which were previously bright are now dark compared to the liver. So this is a classic HCC diagnosed on a cirrhotic liver, so that would be a Lyret's 5 again. Now I told you in a hepatitis B infection, chronic hepatitis B infection, even if there's no cirrhotic liver, you would still use Lyret's. So this is one such example, a lesion in the left lateral segment, arterial phase hyperenhancement with a washout and a capsule. Here it is. That's a delayed enhancing capsule, and there's washout for sure. Enhancing here, washout here. So this is an example of a hepatitis B virus infection with a lesion. Even if there's no cirrhosis, we will still put this under LIRETS 5. Yep. So another example of hypervascular, we will look at adenoma and FNH in a subsequent session where there is an exclusive session on benign liver lesions again. Now what are we seeing here? This is an arterial phase, a late arterial phase. We're seeing multiple hyper-enhancing liver lesions, okay? Multiple such foci. There's also another finding here. Look at the stomach. The wall shows nodular thickening with hyper-enhancement. Similar findings in the duodenum as well. So if you were to find arterial phase hyper-enhancing lesion, what would be the other differentials we would think of when you see a lesion in the GIT as well as in the liver? NET. This is a case of NET. This was a ZE syndrome where we're having multiple extensive involvement of the stomach and the duodenum with multiple hypervascular metastasis. Now, if we were to do a single phase CT, okay, if we were to do only a venous phase CT, not only would we miss the gastric and the duodenal primaries, we would also think these are unknown metastases from we don't know where. We will only see a hypo-enhancing lesion in the venous phase and completely miss that this is a possible NET, which is why no matter what, even if we're looking for mets, it's ideal that we do a triphasic CT in every case to characterize any liver lesion. So that would be the major take-home point. Now this has already been discussed. This is the last slide. You were just shown that something which is very, very bright on T2 in the first session is likely to be either a cyst or a hemangioma. Now the same lesion, we will look at how it parallels the blood pool. Now look at the contrast here in the early arterial phase. It's really bright, but peripheral nodular enhancement. In the subsequent phase, you're seeing more puddles, and then when you see it in the delayed phase, the contrast is exactly similar to that in the hepatic veins and in the IVC. So it's paralleling the blood pool, progressive, homogeneous centripetal enhancement. This is a classic hemangioma. So hemangiomas, so if we were to do a plain study in this case, and I see something like this, I can't really characterize it. But I would say it's really bright on T2. I will look at the diffusion, see if it's restricting or not, and then say this is either a cyst or a possible hemangioma, requires further evaluation with either a sonography or with a triphasic study. So that's about the importance of using a triphasic study. That's about it.
Thank you for your insights on this important topic, ma'am. It was very enlightening. Now I request Venu Madhav sir to continue with his case.
Thank you, madam. So this is our history. Patient had pain abdomen, lump, and then preoperative investigations, LFT was unremarkable, anemia was there, serum AFP was normal, CA19-9, CA everything is normal, viral markers were negative. So madam has discussed beautifully about the CT scan triphasic abdomen. We did CT scan triphasic abdomen. The important features, salient features are in the arterial, in the plain phase it's hypodense. In the arterial phase there is minimal enhancement except we are seeing some vessels. And in the delayed phase there is some stromal enhancement is there. The left portal vein is severely compressed and effaced. Left hepatic vein is not seen. Middle hepatic vein is seen in the lower margin, but as you go to the origin of the IVC, middle hepatic vein is severely compressed and effaced. Right posterior pedicle is normal. Volumetry wise, right posterior pedicle is, right posterior sector is okay. It's a normal liver, more than 20%. So, just for recap, this is the portal vein phase, venous phase, because arterial phase and portal vein phase, nothing was there, but in a delayed phase, there is some enhancement of the stroma. And if you see, it is abutting the anterior abdominal wall, and also, if you go to the next cut, delayed phase. So you are seeing the abutment with the diaphragm proximally, and the stroma is still enhancing the delayed phase. And you can see the ureter lower down. So, based on CT triphasic abdomen, the differential diagnosis given was hepatoblastoma. Of course, hepatoblastoma can be heterogeneous. However, our AFP is normal. Mesenchymal tumor was definitely a consideration in this case, any mesenchymal tumor, and of course, undifferentiated sarcoma. That will come again. We did a MRI abdomen as well, and if you see the MRI abdomen and the CT scan phase, this was done about 2 weeks later. You can see the anterior abdominal indentation, it has increased a little bit. And of course, in these 2 weeks, the patient developed increased abdominal distension and more discomfort and pain abdomen also. And you can see the indentation clinically visible also. So coming to the CT scan and MRI features, what is the next option? Do we operate directly, or is there a role for PET scan or CT scan? Is there a role for biopsy is the question. So the role for biopsy in this case is because this patient definitely had atypical features, and there's increased size of the tumor and patient is becoming symptomatic. We did even a PET scan because there is clinical deterioration of the patient in the last 1 week as well, because she was becoming unwell. We had signs of dissemination, and of course biopsy is useful because some of these tumors can be treated with neoadjuvant chemotherapy as well. So PET scan was done. PET scan showed a large lesion with heterogeneous uptake SUV max of 6.1 with increased FDG uptake in the solid areas. And there's scalloping as we see in the mass. There is peripheral neovascularization, and there are some lymph nodes as well in the hepatoduodenal ligament, which are internal mammary, costopenic perigastric, of size 12 into 9 mm, but it's mildly FDG of it. So this is the PET scan. But if it's a sarcoma, the locoregional spread is unlikely, and so we did a biopsy. There is definite role for biopsy in this case because of the increased size and abutment to anterior abdominal wall and to the diaphragm as well. So we did a ultrasound guided liver biopsy. So when we did ultrasound guided biopsy, it was, they saw a lot of small blue round cell tumors, and of course the lot of necrotic area as well. And the sample was around, the size was around 3 mm only. So whatever with that, they have commented that it either can be a desmoplastic small round cell tumor or an rhabdomyosarcoma, and desmin positivity was there. They wanted to do further IHC, but then the sample was inadequate, so they wanted repeat biopsy. So the question was to do whether to repeat biopsy or there was some clinical impression that the patient is having imminent rupture or something because of the increase of size and a large tumor. So we proceeded with addition of surgery because again doing a repeat biopsy and waiting for some more time. So coming to the pediatric malignant liver tumors, we have basically epithelial, mesenchymal and vascular tumors. Epithelial are hepatocyte derived. Hepatoblastoma, these are most commonly in the first initial years, but adult hepatoblastoma is still seen. Hepatoblastoma with normal AFP is also seen, and hepatoblastoma with round cell differentiation is also seen. So it's a rare possibility in this case, being her age is 12 and AFP is normal. So it's a very rare to have a normal AFP and have hepatoblastoma. The other malignant liver tumor to be considered in this case was hepatocellular carcinoma. Hepatocellular carcinoma, there is no typical features, so it's not a consideration, or fibrolamellar carcinoma in this age group can occur. Mesenchymal tumors, very much yes, because this patient was having a delayed enhancement, the stromal enhancement, the vascularity. The imaging features are very much in favor of a mesenchymal tumor. But what type of mesenchymal tumor, to be precise, it's very difficult to tell because these are very rare tumors reported. And one of the common thing is embryonal sarcoma. If you take the age-wise group, embryonal sarcomas are usually in the first 8 to 10 years of age. She is a little bit older. Rhabdomyosarcomas are usually extrahepatic from skeletal muscle and all, but however, rhabdomyosarcoma of the liver is also described. And of course, any angiosarcoma is one of the possibility. However, in this case, the imaging features are not very much suggestive of angiosarcoma. So we proceeded with the diagnostic laparoscopy because of some free fluid and in the abdomen when we did ultrasound, and so we did a diagnostic laparoscopy. And once diagnostic laparoscopy showed, didn't show any evidence of metastasis, then we opened, and then we found intraoperatively a large mass which is occupying the entire left lobe with extension to segment 4, 5, 8. and tumor appears to be solid cystic with increased vascularity. The mass was densely adherent to the anterabdominal superiorly and lateral to diaphragm. So once we are opening only, it was very difficult for us to open. So we took a decision of doing a thoracoabdominal incision. So this was the incision we took. First we started with a small incision, then extend the thoracoabdominal because there was no space to enter the abdomen. So we had to extend thoracoabdominally. Then we had intraoperatively we sent left hepatic artery, IAC lymph node, intra-articular lymph node, hepatodental lymph node was sent for frozen. It was negative. We did an intraoperative Doppler. Left hepatic vein MHV was also not visualized, and we marked the right hepatic vein. Now we'll proceed with the operative video. So after opening, the video will start when we have done already a thoracotomy, and then we have entered the abdomen. Where's the video? So we have already opened the abdomen after diagnostic laparoscopy, ruling out distant spread. And as I said, there was a large tumor in the right lobe of liver. We did a diaphragm, wherever it was adherent was excised. You can see the lung protruding as well. And superior part, it was slowly mobilized. And then our plan in this case was especially, it would amount to a left trisectionectomy as well, but we wanted to preserve some parenchyma towards the right side. We want to minimally handle the tumor because these tumors are very vascular and friable. They are prone to rupture. So we have taken adequate incision before handling and had the adequate, we wanted suprahepatic approach, suprahepatic control as well in this case because this was mainly extending towards the diaphragm. So you can see we have opened and then we are approaching the suprahepatic IVC. Whatever the adherent tissue was slowly released from the IVC. So before opening, there was it was adherent to pericardium as well. Under vision, we have excised the pericardium also. We can see here the tumor, the suprahepatic IVC is slowly cleared of all the fibrofatty tissue where it was adherent. And then we are taking control over the suprahepatic IVC. So by doing a thoracotomy, we had adequate space. We didn't have to meddle with the liver tumor or mobilize it. There was minimal retraction. We had adequate space, adequate control. So initially, that was the right phrenic vein, left phrenic vein, which is ligated and cut. The exposure of the suprahepatic IVC area was eminently increased because of the thoracoabdominal incision we have taken. And of course, the diaphragm was excised because it was adherent, and so it also aided in identification and easy mobilization of the and taking control of the IVC. So this is the tissue over the IVC. So now we have completely encircled the IVC, and all the tissue which was adherent was taken with the liver itself. An umbilical tape is being passed around the suprahepatic IVC, so we had a suprahepatic IVC control. Then we did the Doppler and then marked the right hepatic vein. The middle hepatic vein, left hepatic vein was not seen. This is again the way towards the right hepatic vein. The diaphragm attachment towards the liver was slowly mobilized. Then again we went to the inferior surface, slowly mobilized the inferior part of the liver, and small vessels to the IVC was ligated. So approach was minimal handling and minimal mobilization. So we came to the inferior part of the liver, which there's a large vein which was draining, which was ligated and cut. Now you can see this was a pericardial incision. There was a small excision of pericardium also because it was adherent there. It is being closed after sucking with the pericardial sucker, so the pericardium is slowly closed. So by now we have excised some part of diaphragm and pericardium and had adequate control of the IVC, and this is the pericardium being sutured. Now we went to the HDL ligament. In HDL, we already looped the left hepatic artery, as you see. We are clearing the hepatoduodenal ligament nodes, because in PET also there was mild uptake was there, and also we are trying the area of gallbladder, which is the tumor is splayed by splaying the gallbladder, and then we are slowly separating. Then all the fibrofatty tissue in the HDL was slowly separated. We had looped the common bile duct as well with the yellow tape we are seeing, and this is the nodal tissue, which is at the bifurcation of right hepatic artery and left hepatic artery. A big node is separated and sent for frozen. The frozen was negative for malignancy. So now we had control of the HDL, the right artery, the left artery, the left portal vein was severely effaced. We had control of that as well. The portal vein, is the portal vein being taped, the blue one. The right artery is ligated, left artery is ligated and cut. Now that the inflow is controlled, this is IVC in the carotid lobe. For a left trisectionectomy, you don't have to mobilize the right lobe, but because of a very bulky tumor and in pre-op imaging, there was no major hepatic veins, we just mobilized it carefully to have control, so that we don't want to mobilize the left lobe because the tumor was large and risk of rupture was there. So carefully we are separate. Now the entire tumor is in our hand. This is the tumor which is extending into the right lobe, segment 5 and 8. Now because there was space and so this is the caudate lobe being lifted, because the caudate lobe was also compressed and at areas it was infiltrated as well. So the caudate lobe is separated and that is also taken part of the tumor. And now we again went up, and then we have taken control of the left hepatic vein as well, because normally we would not take if there is no space, it's not mandatory. But in this case, before we want to minimally handle the left side, so we took even control of the left hepatic vein. So it's approach to the left hepatic vein, the Arancius ligament and all is cut. So the left hepatic vein is taken. Now we started with the parenchymal transection. And slowly we proceeded with the parenchymal transection. Then we ligated branches of middle hepatic vein to the left side. The small vessels were ligated. The branches of middle hepatic vein lower down, which were taken down. Now you usually see the liver tumor is entirely in my hand, because I have already ligated the left hepatic vein and the inflow is also there. So there is minimal pressure on the left lobe, and the entire lobe is in my hand. And now I am approaching the hilum. First we looped the entire Glisonian capsule, but took control of individual vessels intraglycerolally only. This is the left. As you saw on CT, the right anterior portal pedicle was involved with the tumor. So we have taken the right anterior portal pedicle. And of course, we have did the bile duct as well by this time, and then slowly separating the caudate lobe from the tumor. And this is the terminal part. We have taken a loop and then carefully separated the vessels. And this is the right part, the middle hepatic vein, which was cut in the last part. So the entire tumor was delivered, and intraop it was in our R0 section. So that is the right anterior portal pedicle. The portal vein, the bile duct. So the diaphragm rent being closed. And the thoracoabdominal, this is the incision which I have taken, the thoracoabdominal incision being closed.
Hello.
So post-operatively she had some bile leak for which the already drain was showing bile leak, was controlled fistula. Then we had to do an ARCP stenting as well, and patient was discharged on post-op day 15. This is the final histopathology of the patient. It is reported as embryonal sarcoma of liver, encapsulated pseudocapsule, large spindle cell and stellate cell embedded in myxoid stroma, and the margin was negative, and the frozen of the lymph nodes, of course, and all the lymph nodes are negative. And this is the immunohistochemistry panel. So post-operatively, patient recovered well, and then she was started on 9 cycles of rhabdomyosarcoma European protocol, which includes alkylating agents, ifosfamide, vincristine, actinomycin D. She tolerated all the 9 cycles, and post-op, 3 days back, we have done 1 year follow-up scan. She showed a focal FDG uptake soft tissue density lesion at the porta hepatis about size 1.2 in 1.1 centimeter. It's an ill-defined lesion. SU max is 4.2. We are planning a biopsy of this now. So undifferentiated embryonal sarcoma of liver, usually the age group is 5 to 16 years, and it accounts to 14% of tumors in the age group of 6 to 10 years of age. Coming to literature, about 71% of patients are children, and the 5-year survival rates are 79.9%. Most of these patients required a combined modality of treatment, including surgery and chemotherapy. There are also recent literature coming increasing use of neoadjuvant therapy in these patients following the European soft tissue sarcoma protocol. The 5-year survival rate with this protocol is 90%, and with preoperative chemotherapy, they have reduced tumor size as well. The prognosis usually historically has been poor outcome, but now with the improved use of multimodality treatment, the survival rates are increased to more than 70%. And there is continuing ongoing research about the standardized protocols. Thank you.
Thank you, sir. We now proceed. Thank you, sir. So we now proceed further with master video from Dr. Senthil Nathan from GEM Hospital, Chennai. Thank you for connecting to us from all the way from Chennai, sir. The stage is all yours.
Thank you very much. So, can I please allow to share my screen? So at that sort, I'd like to thank my dear friend, my brother, Dr. Vimalakar and his entire team, not only for inviting me, but also taking the initiative of conducting these kind of programs, beautifully named GICS. I think we expect more such programs which integrate all aspects and all subspecialties which aid us as surgeons in our day-to-day practice. I've been enjoying this talk since morning, a comprehensive overview of what only we do, but also the others which help us, like the radiologist, the other supporting the departments which come to our help. So I think, yeah, I'll share my screen. Yeah. So I'll be showing a video of right hepatectomy. That's my, I wanted to show a couple of videos, but in the interest of time, I'll cut short to one video. I bring greetings from GEM Hospital, Chennai. See, in fact, I think I can skip these things, but anyhow, I'll run through these videos of, see, this is a clear-cut case of a hepatoma, beautifully elucidated by the radiologist. In fact, I learned a lot. And she was telling that in her opening remarks, they interact with the surgeons, they understand, and then they report it better. I compliment and then I reciprocate by saying that the more we interact as surgeons with the radiologist, we also learn, so that our intraoperative mapping, intraoperative knowledge will improve. Basically, discussions, group discussion, one-to-one discussion, be there in the console, sit with the radiologist, discuss what we want, and then so that we don't have any surprises, and that will help us in proper planning, because especially in this kind of very closely intricate anatomy where vessels, the margins, everything count, I think sitting together with the radiologist, extracting what we want is important. And more importantly, at the end of the procedure, we have to give feedback to them, whether we are dot on with our preoperative diagnosis, as well as any deviation, like you would have thought of no vascular involvement, there may be a little vascular involvement. So any deviation from the preoperatively diagnosed criteria, I think that also have to be reported to the radiologist for them to understand, to learn, and then to course correct for the future reportings. So that's my thing here. You can see beautifully hyper-enhancing lesion. Hyper-enhancing lesions can be one neuroendocrine tumor or HCC, but in HCC you can have a washout, so that that differentiates from a neuroendocrine tumor. This is one tumor where we have HCC, a small HCC operable, liver is normal. On the other hand, look at this particular again, you see arterial phase, nicely seen, big large lesion, heterogeneous lesion starting to enhance, and this is HCC, but it's a large one, closely abutting the vessels, and the rest of the liver is normal and non-cirrhotic liver. This is interesting one. This is again arterial phase or delayed arterial phase, as you can see, a little bit portal, IVC is also just opacifying. Here, this is a tumor which has got large heterogeneous lesion. How it is different from HCC in the sense, why we are not calling this as HCC in the sense, this has got capsular retraction, and there is no immediate arterial enhancement and washout. So this qualifies for, I would say, intrahepatic cholangiocarcinomas. IHCs form about less than 20% of the entire cholangiocarcinomas. Predominantly it's perihilar, but still we do see quite a bit of intrahepatic cholangiocarcinomas. So though it's third in the order, perihilar first, second one is the lower down CBD, the third one is only intrahepatic, but still This has got a much different prognosis when compared to hepatocellular carcinoma. I think we need to differentiate between HCC, intrahepatic cholangiocarcinoma, secondary is liver and neuroendocrine. As far as neuroendocrine with malignant potential, as far as the majority of the adult malignant SOLs are concerned. Of course, we have a host lot of benign lesions which can occupy the liver, which you have seen in the previous session. I restrict myself to the malignant, discounting sarcomas and other rare malignant lesions. So with this, I'll go for the right hepatectomy. This is done for, HCC. The initial phase includes division of the attachments. This is one area. Here the ICG was given 3 days prior. As you can see, this is a large HCC. It retains, and even surrounding area liver also retains the ICG. So this is preoperative staining. Preoperative staining is helpful for anatomical resections as well as identifying additional lesions, especially the colorectal liver metastasis. So then we move on to the portal dissection. Retracting the hepatic artery, ligating it. Right hepatic artery is hooked, divided. So is the right portal vein. Right hepatic artery is always you have to look at the free margin of the hepatoduodenal ligament. So once that is done, we go to the lateral border. That's the segment for 5 branch, which is divided. And then we go to the posterior portal vein. Portal vein, you have seen a beautiful video of a right posterior sectionectomy, which has got a less extrahepatic course. So we have to be careful in identifying and then encircling the right hepatic right portal vein. Bulldog is applied. We can also ligate in continuity. This is ICG mode, monochromatic as well as synchronous mode. And then we mark it over the surface. ICG helps us in delineating the right and left liver better. So, and then we divide, if the space is there, we divide the portal vein. Otherwise, we ligate in continuity. That can be tackled later. This is called dynamic rubber retraction technique. The retraction onto the cut surface can be modified depending on the need by using this dynamic rubber retraction technique. Then we proceed to parenchymal transection. The initial one would be the segment 5 draining veins into the middle hepatic vein. We'll try to preserve middle hepatic vein unless it is infiltrated by the tumor. Now we proceed. You see everything. This is endo-mini retract, which is very helpful in dissecting larger structures. So all the outflow pedicles, including the segment 5 vein, segment 8 veins onto the middle hepatic is identified. And then we encircle it, clipped and divided. So the best thing is we don't really slog at any point. As you can see, this is and then as we open the opening the book, once we open the parenchyma a little bit, we go to the caudate lobe, divide the caudate lobe as well. So it gives more space rather than initially ligating and then dividing the caudate. So this is the area where you can see the entire staple is divided for the caudate. We can also use, in case if the timing there is space, we can also use QSA to divide it. So it all boils down to the personal preference. So once that is divided, we go to the segment 8. And then same thing, as you can see, it's completely bloodless. Endomini tract is used for a segment 8 draining vein. It's clipped and divided. So this kind of fine parenchymal transection is possible using QSA. Posteriorly, this is a tumor situated in the posterior. So we followed the anterior approach rather than the conventional approach of not dividing initially. And this is, as I told you, the dynamic retraction technique is used one more cranially for us to retract the segment 4A. Endomini retract is used liberally to divide all the outflow veins. Up to 7-8 millimeter, we can very well do using right angle or long Maryland forceps. Beyond that, endomini retract will be useful. As we go near, we will be coming to the right hepatic vein. Again, we have to be very careful in identifying the right hepatic vein. Generally, staple is used, as you can see. Once we can dissect it completely, or a little bit of liver tissue left surrounding the right hepatic vein is also fine. Then we stitch the remnant lobe, especially falcium ligament, to the anterabdominal wall to avoid kinking and torsion. And topical hemostat is applied if that's a personal choice. And you see the nice vascularized left lobe with no unvascularized. Generally, if you go in the proper plane, unvascularized segment will be less. At the same time, wavering to the vascularized segment is also less. So this is about a pure laparoscopic right hepatectomy using ICG guidance. Thank you. I'll skip one more video. I plan to show one more video, but in the interest of time, I will skip it, and then I'll be happy to take any questions.
Thank you, sir. Thank you for the wonderful presentation. Now we next move on to presentation from Team Vimalakar. Dr. Gaurang Shroff is going to present his next and share his insights on malignant liver SOL atypical.
Hello. Hello. Okay. Yeah. After a series of presentations by Dr. Venu sir and Gayatri madam and Senthil sir regarding especially pediatric liver tumors, anatomy, radiology, all, just to do complete the spectrum. Most important, especially in pediatric background being an hepatoblastoma, we'll share a similar case that we had in our institute. Small 7-year-old boy presenting with pain, abdomen and vomitings since 3 to 4 months. Initial tumor marker AFP was very high, 15,000. Imaging wise, after an ultrasound, he underwent a CT scan outside, which showed a large tumor involving the whole right lobe of liver. This is the CT images of classical triphasic CT with the early arterial phase, late arterial phase showing the arterial enhancement and gradual portal and venous washout, typical of how a HCC and a hepatoblastoma should also be, with areas of few hemorrhage. So just to add a small word, hepatoblastoma is usually staged according to the pretest classification, stage 1, 2, 3 and 4, based on the amount of segments that we need to remove. Now, along with the prognostic factors, including the pretext stage, the annotation factors like the vena cava involvement, portal vein involvement, and other things, along with age and AFP, have graded the tumor into four grades: very low grade, low, intermediate, high. This is especially important because there are guidelines stating except for very low, most of the times we may have to proceed with some neoadjuvant chemotherapy and then take up for the surgery. Just as in this case, the patient had to receive 3 cycles of neoadjuvant capecitabine with doxorubicin therapy, even though it was a fetal type pretext 2, but the tumor was very big and the child age was 7 years, after which there was significant improvement in tumor marker and the CT size also. This is the intraoperative video. We took a Makuchi incision, opened up the abdomen, proceeded with ligation of falciform ligament and gradual mobilization of the right lobe of liver. Here you can see the gallbladder is being mobilized, and we proceed to the hilar dissection, cystic artery and cystic duct being clamped. The cystic duct will be retained to help retraction of the biliary tree. And then gradually we will do the HDL dissection, identifying the right hepatic artery and right portal vein. Here you can see lowering of the hilar plate and the right hepatic artery being identified and being looped. That is the right hepatic artery which has been looped. After this, the HDL lymph node dissection is being done so that we can loop the hepatic duct also. So after this is the right hepatic duct which is lifted, and posteriorly you are able to see the right portal vein. So that is a hepatic duct, right hepatic duct. Sorry. That is the right hepatic duct being looped, and posteriorly you are able to see the portal vein. Small corded branches are there which are being ligated to visualize the right portal vein. So after ligation of that small twig, you are able to see beautifully the right portal vein. That is the right portal vein that has been looped. So this is the hepatic duct, artery and portal vein. After the inflow control, we mobilize the remaining part of the liver. Then you are able to see posteriorly IVC and multiple small tributaries of segment 6 draining directly into the right IVC, which are ligated so as to mobilize the right lobe completely. And once you start ligating and moving them up, you get to see the right hepatic vein, that is the RHV, and that you are seeing in the superior part. This is the IVC completely bared and separated from the right lobe of the liver. And here moving coronally, that is the right hepatic duct, right hepatic vein, that is RHV that has been looped to achieve the outflow control. So now basically we have the inflow control and the outflow control, and after achieving both of them, we start clamping the right portal vein, and that leads us to the demarcation line, the Clantil's line. We are able to see the right segment has become bluish and the left lobe is looking good. So then we score the liver along the line of desired transaction, and then we start the transaction initially with monopolar or bipolar and slowly with QSA, identifying the intrahepatic biliary and vascular structures and clipping them sequentially, and proceed down. So as we go in, we try to preserve the MHV and ligate the segment 5 and 8 branches separately. And then continuing with the parenchymal transection, we go to the hilum, where we divided the right portal vein, hepatic artery and hepatic vein, so to achieve a proper right anatomical hepatectomy. So you can see the bloodless field because we are in proper anatomical planes. We are approaching posteriorly, where we divide the few small corded branches and finally achieve the hanging maneuver. The whole of the liver is lifted away from the IVC, and then we finish the corded dissection so that the tumor comes completely into our hand. So that is a complete completion. Now the outflow hepatic vein is stapled with a vascular stapler, and the tumor is completely removed. That is a tumor involved in the right segment. So proper classical right hepatectomy. Post-operatively, as we know, it came to be hepatoblastoma 9 cm, pure fetal type. There was no capsular invasion or lymphovascular invasion, but because of the size and the tumor factors, patient received post-operative 3 adjuvant cycles of chemotherapy, which was capecitabine with doxorubicin combination, and the patient had a beautiful recovery and is doing well. Thank you.
Thank you, sir. Thank you for the beautiful session and broadening our knowledge on atypical HCC. I kindly request all the speakers of previous session to join for a group photo and capture the moment. I also request any insights or comments from audience, seniors. You're most welcome. The tea break will be a working tea break due to the time constraints. All the refreshments are served, and whoever are interested can take a break. And next session will be started soon.
Hello, chick, 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 chick. Hello, chick.
Welcome back, everyone. I hope you are all refreshing. Now we'll continue with the academic feast here. So third session, we are starting with malignant liver SOL, which is hepatocellular carcinoma. And for this session, the primary case presenter will be Dr. Kalai from Professor Surgical Gastroenterology from JIPMER, Pondicherry. And the radiologist who will be discussing his case will be Dr. Hari Prasad, Professor Radiology from JIPMER. And also, Dr. Brahmadatta Patnaik from AIIMS Bhubaneswar will join with his master video along with Dr. Kalai. And Dr. Rupesh Mandava, interventional radiologist from KIMS Hospital, Secunderabad, will share his insights. And I, Dr. Manisha Bhandari, will show our surgical video, what Rupesh sir is discussing with his case. Thank you. I request Dr. Kalai sir from JIPMER, Pondicherry, to join us online and proceed with your case presentation, sir. Thank you for joining us.
Very good afternoon to all. I hope I'm audible.
Yes, sir, audible.
Yeah. At the outset, I'd like to thank Team Vimalakar for this wonderful initiative. I think that's something which should be useful for both residents and also the practicing surgeons. As we are running short of time, I'll directly go to the presentation. So we did have some discussion on the HCC. This case also will have some overlap. I think there are some sessions on the HCC in the background of CLD. So this patient did have some CLD findings too. But we will restrict the discussion primarily to management of large HCC and some of the imaging features and the surgical tips in management of large HCC. So we had a patient of 60-year-old male. He was from Netherlands and had a history of pain abdomen of 2 months duration, significant weight loss, and no other significant history. He is a known hypertensive, and he was HCV positive, previously treated 30 years back. Actually, we don't have the records, and he also had a history of recreational drug use. He had good performance status, and vitals were stable, no para or icterus, and he had a large right hypochondrial mass. So he had a large hypochondrial mass on examination, and we have this before we go to the
Sorry, sir, 2 seconds. We'll mute.
Yeah. Maybe we can just mute. Yeah. On the biochemical and the hematological investigations, so the important points to note here: a normal platelet count, is liver function test where within normal limits, both proteins and bilirubin. KFP was 6.1 and CN99 also was within normal limits. His ultrasound abdomen showed a large right lobe liver mass, and which was non-homogeneous with vascularity and displaced portal vein. I'll invite Dr. Hari Prasad, our radiologist, to show the CT findings of this patient.
Okay, good afternoon to all the delegates present today. I'm Dr. Hari. I'm senior resident at JIPMA Pondicherry. And at the outset, I'd like to thank the organizing committee for giving me this opportunity to present this case, and to my professors, Dr. Kalayaras and Dr. Shaktivel, for letting me present the CT of this case. So in light of our time crunch, I'll go directly to the case.
Yeah.
Okay.
Yeah. Yes, we got the image.
Okay, thank you. As Sir said, this patient presented with a right hypochondriac mass, and an ultrasound was done. It showed a large heterogeneous lesion within the right lobe of the liver, heterogeneous in nature. So we went ahead and did a CT triple phase protocol. And as Gayatri ma'am had beautifully demonstrated in the previous session, for any liver pathology, our ideal go-to modality would be a CT triple phase protocol. So unfortunately, we were not able to retrieve the plain CT and delayed phase cases in this case, considering that it is a slightly older case. So I'll be starting right away with the arterial phase of this image. So this is a CT triple phase, and this is the late arterial phase. So the late arterial phase shows a large, well-defined lesion in the right lobe of the liver, which is showing non-rim intratumoral arterial hyperenhancement. So you can see this is a huge lesion which is occupying a large segment of the right lobe, showing arterial phase hyperenhancement, which is non-rim and intratumoral in characteristic. Another important thing which surgeons would definitely want to know on a CT scan would be the arterial anatomy. And of particular importance in this case is that we can actually see that there is some arterial anomalies in this case. We can actually see the common hepatic artery, which is arising from the celiac artery, and then it is going on to form the common hepatic and the proper hepatic artery, which is then dividing to form the right anterior segmental artery and the left medial segmental artery. So in normal patient, the right hepatic artery should divide into a right anterior segmental and a right posterior segmental artery. Similarly, the left hepatic artery should divide into a left medial segmental and a left lateral segmental artery. But in this case, the proper hepatic artery is dividing into two branches, which is the right anterior segmental and the left medial segmental. So now the question comes, where is the other two arteries arising from? So in this case, the left lateral segmental artery is actually arising as a branch of the left gastric artery. So here we can see it is coursing above, and this artery, which is coming from the left gastric artery, is the left medial segmental artery. Similarly, the right posterior segmental artery is arising from the SMA. So we have a branch of the right hepatic artery arising from the SMA, and it is going on to supply the right posterior segment of the right lobe of the liver. And as you can see, the artery is coursing along the margins of the lesion. So you have the right posterior segmental artery arising from the SMA and the left lateral segmental artery arising from the left gastric artery. And arterial phase also demonstrates prominent internal vascularity of the lesion. Now, as Gayatri ma'am had actually said in the previous session, it is important that on a CT, we must identify if there is cirrhosis or not, because that obviously changes the differentials in a case. So in this case, if you can observe, you can see some mild service irregularities, which is not characteristic of florid cirrhosis, but likely to be an early cirrhotic change. Now, this was correlated on an ultrasound, which showed altered liver echo texture and high fibrosis score on an RF scan, which is used to diagnose fibrosis of the liver. So we have a cirrhotic liver with the arterial phase hyperenhancing lesion. Now, after the arterial phase, moving on to the portovenous phase. So in the portovenous phase, we can see that there is washout of the lesion which is nothing but hypoenhancement of the lesion in respect to the surrounding background liver parenchyma. So we can see that the lesion is appearing much more hypo or darker in comparison to the surrounding liver parenchyma. So this is nothing but portovenous non-rim washout of the lesion. And also in the portal phase, we can actually comment that there is actually a mild enhancing thin capsule to the liver. So it is a decently well-defined lesion. Now, to find out the location of the lesion, again, in portovenous phase, we can take the help of the hepatic veins and the portal vein. So first, coming to the hepatic veins, we can see that there are these three hepatic veins joining the IVC. So we have the right hepatic vein. The part where it is joining the IVC is visible, but however, as we trace it distally, adjacent to the lesion, the right hepatic vein is not visualized. So this is probably because of compression due to the lesion or thrombosis of the right hepatic vein. Similarly, at the porta, we can see that we have the portal vein which is entering the liver, and the portal vein is dividing into a left portal vein and a right portal vein. So the right portal vein again is coursing along the branches, along the margins of the lesion. And here we are not able to separately make out the right anterior and posterior segmental branches because again, it's likely compressed or displaced by the tumor mass. Within the lesion, we are also able to make out certain areas which are much darker than the normal tumoral parenchyma. So these areas which are not enhancing either on an arterial phase or a portal phase is most likely due to necrosis of the tumor lesion. So how we identify necrosis is basically it will be almost fluid attenuating and will not show enhancement either on arterial or portal phase. So we have a lesion which is showing arterial phase hyperenhancement, which on portal phase is showing washout. We have a thin capsule to the lesion, and we have some necrotic areas within which is non-enhancing areas. The lesion actually is reaching almost up to the surface of the liver, but there is no gross extra liver extension of the lesion. There is no exophytic growth that we can see on either side or on any side of the lesion. Because of the size of the lesion, there is mass effect on surrounding organs. So we have the right adrenal gland, which is being mildly compressed by the lesion, and inferiorly we have the right kidney, which is also being mildly compressed by the lesion. However, there is no gross tumor extension into these parenchyma. Similarly, the lesion is also appearing to compress on the infrahepatic portion of the IVC. Other things that we can observe on a portovenous phase would be the biliary anatomy. So in this case, we are not seeing any dilatation of neither the common bile duct or the intrahepatic biliary radicals. So this almost rules out bile duct infiltration of the lesion. So we have talked about the arterial state, we have talked about the portal and the venous anatomy, and we have also talked about the lesion characteristics. There is no bile duct involvement of the lesion. Now coming to the surrounding areas, we are able to actually see a few nodes in this hepatico-duodenal region. So these are nothing but hepatico-duodenal nodes, which maximum short axis diameter is coming to around 1 centimeter. So in a case of hepatic tumor with surrounding nodes, the nodes will always have to be considered with an eye of suspicion. So the same thing I can demonstrate on a coronal section, so which would be of much more use to a surgeon. So this is a coronal section again showing the same findings. We have a large lesion in the right lobe of the liver, showing portovenous washout, arterial phase hyperenhancement with a distinct capsule. And size of the lesion is definitely more than 2 centimeters. The maximum diameter was coming to around 13 centimeters. Again, occupying the right lobe of the liver. And just one thing that I not mentioned earlier is that the lesion is actually located to the right of the right hepatic vein. So a major chunk of the tumor is actually in the posterior segments of the liver, which is the segment 6 and the segment 7 of the liver. There are no other similar lesions elsewhere in the other liver parenchyma. In the arterial phase, there is no arterial enhancing lesions in any of the other solid abdominal organs in the abdomen. There is no ascites, there is no significant retroperitoneal nodes, there is no pleural effusion. And just touching up on the lung window also, there is no suspicious focal lesions in the bilateral lung parenchyma. So summarizing, we have a large well-defined lesion, which on arterial phase shows arterial phase hyperenhancement, which is non-rim in nature. On subsequent portovenous phase is showing portal phase washout with an enhancing capsule, size more than 2 centimeters. In a case of cirrhosis, in a case of a patient with cirrhosis, and he also has a history of hepatitis C, so he is automatically falling into the high-risk category. So in such a case, we can confidently give this tumor a LIRADS 5, which is diagnostic of an HCC even without a biopsy. So just touching upon a few differentials. So although this lesion is a classic telltale HCC, a few other possibilities must always be considered in mind, especially in a case of cirrhosis. It can be either a dysplastic or a regenerative nodule. But what sets apart a dysplastic nodule from that of an HCC is that a dysplastic nodule is a pre-malignant phase of the HCC. So the typical washout which you see on in case of an HCC won't be seen in that case of a dysplastic nodule, because dysplastic nodule, the neovascularization has started, but however the portal venous supply has not been completely obliterated. So in the case of an HCC, the portal venous phase has almost been obliterated, the portal venous supply. So if you see a dysplastic nodule, you will see arterial phase hyperenhancement, but however, you would not see the normal portal venous washout, which is expected that out of an HCC. A regenerative nodule will be more or less isoattenuating to the liver parenchyma in all phases. Now, just touching upon a few other possible tumors, but not in this case, we have the fibrolamellar HCC. Now, how ma'am has said in the previous session, the age group is a more younger category. It will usually occur in the background of a non-cirrhotic liver parenchyma, and it will have characteristics such as central scar and calcification, which is not seen in this case. An intrahepatic cholangiocarcinoma is one possibility, but however, in this case, we are not seeing any bile duct dilatation. Intrahepatic cholangiocarcinoma will show a more delayed enhancement, attributable to the fibrous nature of the tumor. Certain non-malignant pathologies, for example, a sclerosed hemangioma can also look like this, but however, in those cases, we won't see this typical portal venous washout, and also you will see rim enhancement. Now, last, touching upon this possibility of hypervascular mets. Now, that is again a very strong possibility. It will also have this arterial phase hyperenhancement and can show necrosis like this. But however, in our case, we were not able to pick up any other arterial enhancing lesions in the arterial phase. Not only that, in most of the cases of hypervascular mets, you will see rim arterial phase hyperenhancement because of the central necrosis of the tumor. So in this case, cirrhotic background with arterial phase hyperenhancement, portal venous washout, and enhancing capsule in a size more than 2 cm. I, as a radiologist, would assign a LIRADS 5 score of this, which is more of diagnostic of an HCC and would not require a biopsy for further confirmation. There are no suspicious metastases in the case. So this would be a case of HCC. Over to sir.
Thank you, Dr. Hariprasad, for the excellent presentation. So you can stop sharing, then I'll. The Zoom window, you can just stop sharing. I think I've shared my. I think my screen is visible, right?
Yes, sir, visible.
Can anyone from the hall respond? Is my screen
yes, sir,
visible?
Visible. Your screen is visible. Yes, sir, your screen is visible.
Yeah, okay, fine. Okay, so we have seen, so far to summarize whatever we had seen in this case, so there's a large tumor in the background of, I would say, cirrhosis. Based on the CT, we didn't have typical findings, but ultrasound showed altered architecture and the RFE of in the fibrotic range of 1.5. So now the decision making is whether this patient is a candidate for surgery. So we need further evaluation. One is obviously the volumetry, and if you see the volumetry, the tumor volume is actually 1,244 centimeter cube, and if you actually include the tumor volume, then the healthy liver is 27.63%. But if you exclude the tumor volume, then this patient, the FLR was 42%. So you have a FLR of 42%, and only the volume is not sufficient in this type of cases. So you need to have functional assessment. You can do a ICG retention, but as we all know, ICG retention just tells only about the global function of the liver. But what we are interested is what is the function of the FLR in this patient. And so what we routinely do is a mebrofenin scan. If the FLR uptake is more than 2.7% per minute per meter square, generally the possibility of post-hepatectomy liver failure after major hepatectomy is less than 5%. And this patient had 2.9%. And evaluation for portal hypertension, there was no clinically significant portal hypertension. Now, with this investigations and considering his liver function, platelet counts were within the normal limits, so we decided to go ahead with surgery. And this in the background of a CLD, the minimal invasive approach has advantages. So we decided to go ahead with the robot-assisted right hepatectomy. And whenever you have a large lesion in the right lobe, so the typical approach of mobilizing the right lobe is generally not recommended. So we decided to go ahead with an anterior approach. I'll just show some of the intraoperative findings in this patient. So this is what we can see on the initial evaluation, staging laparoscopy. No other signs of metastasis, but as expected, the liver surface was irregular. And so what we did initially is mobilize the round ligament, and then you retract it with a suture, because this type of lesions, when you plan a surgery, sorry, can I go ahead? Okay, so the difficulty in a large tumor is you need to have good exposure, and your trocar positions have to be planned in such a way that where you expect that difficulty, so you need to have a good vision. So in this case, more than at the level of the inflow, we were expecting some problems close because the tumor was involving the right hepatic vein, just proximal to its incision. So you can see the trocars were slightly on the higher side, so that we have a good view on the superior surface. And when you have that type of trocar placement, you need to have a good exposure of the hilum. And that's where we retracted the round ligament. And you can see here this gallbladder is distended. So what is recommended is you decompress, and then you apply a retraction suture on the gallbladder. So the key principle in robotic surgery is you have 4 arms. So you should not use one of the arms for just a simple retraction of structures like gallbladder. So whenever you can use this type of self-retraction techniques, liberally use it. As you can see, we retracted the round ligament, and then now we are retracting the gallbladder by taking a suture. So once the gallbladder is retracted, then you have a much better view of the hilum. So the first step is the inflow control in this case, as beautifully described by Dr. Hari Prasad. So this patient also had an arterial anomaly, which means the right anterior sectional artery was coming from the celiac trunk, and the right posterior sectional artery was coming from the SMA. So this is actually the cystic artery which is being clipped and ligated. The cystic artery actually was coming from the right posterior sectional artery. What you are seeing here is actually the right anterior sectional artery. So first we expose the right anterior sectional artery, and then this is cystic duct which is clipped. The reason why we do this clipping at this stage is to have a better exposure of the right side of the HDL. We want to retract the bile duct. So what we do is we clip the cystic duct and then apply a long suture, and this suture is brought out, and this gives a good exposure of the right side of the HDL. So you can see here the cystic duct is nicely retracted. So liberal use of this type of self-retracting techniques are good, essential. And as also described, the patient had one significant node on the right side along the course of the replaced the right posterior sectional artery and also on the right side of the portal vein. So that's a portal vein which is being exposed, and this is the right posterior sectional artery which was coming from the superior mesenteric artery, and the node was in relation to this artery. So the node was dissected and separately sent for histopathological evaluation. Typically, you don't require a lymphadenectomy in patients with HCC except in maybe some of the fibrolamellar variants, but because there was a single prominent node, we had taken this node for evaluation. So once this node was dissected, then we had a good exposure of the right side HDL. So you can place this node. So this is actually a glove finger. You can place it inside. That makes it easy to retrieve the nodes. And now what we are doing is we are ligating the right posterior sectional artery. And now we are ligating the right anterior sectional artery. So next step is dissect the portal vein, and you can see this is the right portal vein, and this is the left portal vein. So before you try to loop the right portal vein, you need to dissect on both the anterior and the posterior aspect. And this is a Maryland, and this is a fenestrated. So whenever you need to dissection on critical structures, so we replace the scissors with Maryland so that you have two grasping instruments while doing the dissection. So before, so you can either apply a stapler, but actually the angle was not favorable to apply the stapler. So we decided we just tie and then place a clip. And finally we, while taking the inflow at the after transection, we apply the stapler. So after ligation of the right portal vein, you can see the ischemic line of demarcation, which is reconfirmed with the ICG. And so as we all know, so that transection line is rarely straight. So you have this type of irregular transection line. So we are marking that with scissors, both anterior and also the posterior aspect. So once the transaction line is marked, then before we proceed with the liver transaction, parenchymal transaction, it's important to have control of the HDL for Pringle. So in robotic surgery, we use the Foley catheter. This is a 14 French Foley catheter, which is loop around the HDL, and whenever you want to apply the Pringle, you can tighten it. So this is a very simple way of applying Pringle during minimal invasive hepatectomy. The superficial transection you can do with scissors. So the main advantage in patients with CLD with minimal invasive approach is actually you can minimize the bleeding. And since we don't have QSA, we'll be using the double bipolar. Now for that, one of the important prerequisites is good traction on the cut surface. So that's why I think Dr. Sindhanathan showed using the rubber band. If you don't have rubber band, this is actually a glove ring. It's not something rubber band is quite expensive. You need to sterilize and keep it. If it is not available that time, you just use a glove ring and then retract it. So this is brought out with the help of mosquito artery forceps. So you can see there's good traction on either side is critical, because that opens up the plane for the liver transection. So now you can see you keep on increasing the traction, and that allows you to do the parenchymal transection with Maryland bipolar. So there are some tips to remember to use how to use this Maryland for liver transection. You can use it almost like a QSA. When you are close to the hepatic veins, you need to use the tip of the Maryland and take very little amount of the tissue, use the sideways movement, and then never be in a hurry to loop the hepatic veins. Always have a good dissection, clearly define the upper and lower edge, and also for a segment, so that you can completely loop. Incomplete dissection and trying to loop the hepatic veins is one of the important causes of bleeding during the parenchymal transection. And you can see there is both the instruments are connected to the bipolar, the fenestrated and the Maryland. And this allows you, so at this stage you can see we haven't applied the Pringle, but you don't see much of bleeding from the transection surface. That's because of the combination of the low CVP and also staying in the right plane. So the settings which we generally use for this is the Maryland bipolar, the effect is kept at 8 watts at between 80 to 100, and we use a soft coagulation mode because the robotic system actually has only one mode, that is a soft bipolar. So you can see after some time there is a bit of tissue which accumulates at the tip. That's why we keep a gauze inside, and you keep on cleaning your Maryland intermittently, so that the coagulation is good. And in case if it really becomes charred, then you can ask your sister to clean the forceps. So the surface marking guides you the initial transection, but once we go into the deeper plane, it's guided by the hepatic vein. And since this is a right hepatectomy, so we use the middle hepatic vein as a landmark, and we stay on the right side of the middle hepatic vein, because as seen on the preoperative imaging, that plane is free. So I've just kept this segment of the video a bit longer just to give an idea that you can do very precise dissection without QSA in robotic hepatectomies because you have the Maryland is articulating. Actually, there's robotic harmonic also, but that does not articulate. And if you use QSA, then it can very well be done. There's nothing wrong or it's not impossible, but it has to be done by the assistant. And you need to plan your trocars in such a way that they don't have much interference. And in fact, one of the tips to use QSA is that time you can actually even remove one of the robotic arms so that the assistant has much more space for them to use a QSA in a proper way. Otherwise, it's safer because one of the important principles in robotic surgery is the most of the key steps should be done by the consult surgeon and not depending on the assistant surgeon the bedside because you have the best view of the 3D view, the immersive view is with the consult surgeon. So most of the critical steps should be done by the consult surgeon rather than leaving it to the assistant. So that's a point to be kept in mind. And we can see here we are doing the anterior approach. We directly started with the inflow control and the parenchymal transection without mobilizing the liver. Because in such a large tumors, if you try to mobilize, you will invariably rupture the tumor, and also in minimal invasive, that is in fact more difficult. In fact, doing the anterior approach is much more easier than doing the conventional technique of right hepatectomy. So now we are gradually exposing the middle hepatic vein, and you can see we all know the middle hepatic vein is formed by the confluence of the segment 4B and the 5 vein. And you can see here, this is the segment 5 vein, which is being dissected. So this is a place where the segment 5 and 4B are joining. And as I mentioned previously, don't be in a hurry to loop the vein moment you see it. Make sure you dissect a considerable segment of the vein because you will not be knowing because you will have some small tributaries draining into the segment 5 vein. So while trying to loop it, then you might injure it. So you keep on dissecting. You can see here, this is actually the middle hepatic. The segment 5 is here. If you haven't exposed that and try to loop it before complete exposure, then you might actually injure the middle hepatic. So that's why it is important to have a good exposure of the hepatic vein before we start navigating. Let's move forward, maybe. So now we have a good segment of middle hepatic vein is being exposed. And at this stage, we will loop the segment 5 vein. So you can see the movement of your Maryland. Once you are close to the hepatic veins, the sideways movement to create space to loop the vein is critical. So now we have a good exposure. We have seen where the 5 vein ends. So as we go very close to the hepatic veins, the amount of tissue which you actually grasp with the Maryland bipolar decreases. So you just use only the tip of your Maryland and do the dissection. When you're on the superficial plane, you can actually catch a slightly larger chunk of tissue. But as you go deeper, especially close to the hepatic veins, then you have to be very precise with a little bit of tissue. And now we have looped the segment 5 vein. That is now ligated, and then you apply the Vimalakar. Hello. Yeah. And I'll just, now this is the segment 8 vein. So once the segment 8 vein, so till that step, you hardly had any bleeding. But as we move towards the insertion where the right hepatic vein is joining, and that is the place where the tumor was compressing on the vein. And so this is important in anterior approach. So once you go over the IVC, you start mobilizing completely over the IVC. And reach up to the hepatic veins. Now, at this stage, when you are close to the right hepatic vein insertion, so you can see here, you will see a hole in the hepatic vein. But the important thing to remember is don't panic, even if there is a hole in the hepatic vein, as long the central, you can see here, there's a bubble which is coming here, but you don't see a significant bleeding as long as your CVP is low. And don't be in a hurry, just keep dissecting it. You nicely expose the hepatic vein. So if you try to grasp the bleeder, then you will actually increase the opening of the rent in the hepatic vein. So that's the important thing. Whenever there's bleeding, just focus on looping the hepatic vein completely, rather than trying to control at this stage, because you can see the weight of the tumor is actually applying traction on the vein. So any slight increase in traction will cause significant bleeding, and then the hepatic vein is controlled. I think we are running short of time, so I'll just go ahead, and this is the final view. You can see the tumor is kept inside because a large one. So we thought once we establish the hemostasis, everything, then we start pushing the tumor down, and that's a specimen. And actually, patient had a uneven full post-operative. Had on day 4, the count was slightly on the higher side. We did ultrasound, showed a collection, but the aspiration showed only a serous fluid. And then patient was discharged on day 7 and did not have any post-hepatectomy liver failure. And the histopathology showed a hepatocellular carcinoma. There are any queries, I'll be happy to answer.
Unmuted. Thank you, sir. That was a very meticulously done surgery. We thoroughly enjoyed the master video and the radiology talk and the integration. Now I request Dr. B.D. Patnaik, sir, from AIIMS Bhubaneswar, surgical gastro, to please show his master video and share his thoughts.
Am I audible?
Yes, sir, you are audible.
Yeah, I'll just start sharing my screen. Yeah, my screen is audible now. My screen is visible now.
No, sir, the slides are not visible. You are visible, but
Yeah, just give me a minute. Look.
Hello. Yeah. Kalersan, are you there?
Now my screen is visible.
Yeah, I'm there. Okay, I think. I think Dr. Fani's voice, whatever I can make out.
Okay.
Yeah, probably.
Sir,
I think
Fani
Dr.
sir,
Patnaik
please
will go
proceed
ahead.
with
I
your
think some.
questions.
Just wanted to ask you about in your workup, you mentioned the technetium 99 scan, right? One traditional thing is that in the previous days we used to think that HCC we should exclude the tumor volume from the functioning liver, but now we know that in some of the HCCs there is functional volume, and especially in your case it's a cirrhotic liver, though it's child's A. That would have been a concern. How did the mebrofenin scan help you in this case, or in general, how are you using it? Can you just tell us?
The main advantage with the mebrofenin scan is you can actually specifically assess the function of the FLR compared to other, the usual, for example, the ICG retention test, the typical cutoff for major hepatectomy should be less than 10%. That tells of the global function. But in mebrofenin, you can assess the function of the FLR. So the cutoff for major hepatectomy is the FLR uptake should be more than 2.7% per minute per meter square. So if it is more than that, it has a very good correlation for post-operative outcome. The liver failure chance is much less. So actually, this is in fact the most important discussion point in this case. That's a background of liver. We are going to do a major hepatectomy, and as that's why you use. So other than the CLD, this patient had a normal platelet count, child A, good function of the FLR, no portal hypertension. So because all these factors were favorable and good performance status, we went ahead. But yes, I think major hepatectomy in CLD, we need to be extremely cautious and good workup is required.
Can we move to BD Patnaik, sir? Sir, can you share your screen? Patnaik, sir?
Yeah, I'm not able to share my screen. The whole slides are shared, but the PowerPoint option is not, I think it is not coming properly. I need to select the first.
Patnaik, because we can see all your slides. Just
Sir.
click on the slide.
Sir, in the below strip, you can see PowerPoint. You have to select it from this.
It is not opening. I think now it is.
Or you can go to the above.
Yeah. Now it is visible.
Your PPT is visible, sir.
Yeah, but I have already started my slideshow here.
No, sir. Can you again place that share screen button?
Now it is visible.
Yeah, now we are visible, sir. Yeah. Now
Okay. Sorry for the delay. Actually, we are already running very late, and I must thank Vimalakar sir for this great opportunity. And after everybody advises not to show your presentation immediately after Kalaisers, but unfortunately I have to start doing my own. And now we'll focus from move ahead from a robotic right-sided tumor from to a open central tumors. So this is a 66-year-old male. Am I audible properly, na?
Yes, sir, you are audible. Sir.
Yes, sir.
Yeah. It is a 66-year-old male with a ultrasound finding of a large SOL on the right side of the tumor with some basic investigations with him. The LFT was normal with viral markers were negative and INR of 1.1. Then after he came to AIMS Bhubaneswar, we did a triphasic CT with simultaneously all the blood investigations. As you can see, there is a large tumor on the central part of the tumor on either side of the MHB. So as a departmental protocol, we for any liver tumors, we strongly believe evaluating in these 4 pillars for liver resection, specifically in cirrhotics. As you can see, this is a 66-year-old with diabetics as a comorbidity, centrally located tumor, child A cirrhotic with MELD sodium score of 9 with stiffness measurement of 14 kilopascal. there was no clinically significant portal hypertension, and the platelet counts were just above the higher normal range. So this is how the schematic looks like. The tumor is on either side of the MHB and it is just touching the right anterior pedicle. So in this, if you can see to the BCLC staging, it comes to the intermediate stage, and in BCLC advocates strongly against offering liver resections, but BCLC, I feel it is a more of a hepatologist's criteria rather than the hepatic surgeon's criteria. So what are the options next? We have so many options for this particular subsets of patients, but it mostly fits into the liver transplant criteria, extended criteria. But unfortunately, the patient was not willing for liver transplantation. So next best treatment would be a liver resection. So our plan was to do a central hepatectomy. And for all cirrhotics, we believe in doing volumetry even for parenchymal preserving resections like central hepatectomy. And for cirrhotic, the minimum FLR should be 50%. And in this particular patient, it was 55% on Miriam. So we basically will have three transaction surfaces. The first one is the left, second one is the right, and the third one is the oblique horizontal surfaces. So the key steps would be a right anterior hepatic artery ligation followed by right anterior portal vein isolation. And the most important step would be identifying the dorsal branch of the V5 to the RHV. So these are the three surfaces. In the best interest of time, I'll just directly go to the video. A short description about the imaging. In imaging, you need to rule out, we need to see for the exact portal venous anatomy, whether it is type A, B or C. On MHB, what are the tributaries? What are the tributaries on RHB on the right transaction surfaces? What exactly is the bifurcation point of right anterior and right posterior arteries? All these things you need to see. So now I'll just go to the video. Yeah. Now I hope you are able to see my video.
Yes, sir.
Yeah. So after, I'll just start again. After this is a grossly cirrhotic liver. You can see we have ruled out significant portal hypertension, good volume. So we are just mobilizing the liver, the right triangular ligament, and the suprahepatic cava mobilization. And after mobilizing the liver well up to the right border of the cava, and we should not ligate any inferior veins here, we will sling the cystic artery and keep a stump to do a propofol test later on. And then we can straight away start doing a left-sided transaction. You can first do hilum and then go to left-sided transaction as well. It entirely depends on the surgeon. So as you can see, we are just skipping to the right of the falci, and we will encounter segment 4A and 4B pedicles along the transaction line on the left-sided transaction. So these are the segment 4B pedicle, and as we come downwards, we will be encountering multiple segment 4A pedicles like this one. This is one of the first segment 4B pedicle, sorry. And this is number of 4B pedicle we are going to get. We believe in doing very religiously intraoperative ultrasound by ourselves. In case of difficulty, we call our radiology friends. And so that we not to injure the segment 4 duct specifically, which is extremely crucial in central resections. So these are the segment 4A pedicles which are being ligated. Left-sided transaction is the easiest of all the three transactions in central. We come back to the hilum, and you can see we are just looping the right hepatic artery. I'll just slightly zoom the camera now, and we'll see you need to do a good dissection here and loop the right anterior hepatic artery. After ligating the right anterior hepatic artery, the whole arterial system will fall down, and you can get a good access to the right. Then only you can get a good access to the right anterior portal vein. Otherwise, it is very, very difficult. So the entire artery is lowered down, and we can see the remaining part of the segment 4A is taken. The right anterior and posterior bifurcation of the portal vein is very deep inside. That is why I am finishing the transaction, and then only I could get hold of the right anterior portal vein. Dividing the portal vein was not feasible, so just I clamped it. Inferiorly, there is a Rouvier sulcus, and we are getting a very nice demarcation line in this cirrhotic liver. So we will just proceed ahead with just to confirm with the intraoperative ultrasound. This is purely optional. We are no more doing it now. and you start with the right transaction, right-sided transaction. Like I said, the most important point would be identifying the dorsal branch of the V5 into the RHP. That point, if you are finding, then you are at the right plane. Like in this particular case, you can see this is the first D5, we call it, the dorsal branch of the segment 5 into the RHP. And after cutting it down, you can see the RHP and just follow the RHP up to the junction with the KEVA. And the mobilization of the right lobe is very, very important, because you can see most of the time I'll be holding the FLR, that is the segment 6 and 7, with my left hand and guide the transaction plane along the RHP. While doing resection in serotics, the KUSA settings are very, very important. We keep it as an 80, 80, 80 with a tissue select 2+ mode that doesn't injure any of the vessels while working closely to the vessels. If you are not close to the vessels, you can use tissue select 0. But otherwise 2+ is a standard mode. Otherwise you may end up in injuring the RHB at multiple times and taking stitches with Prolin 60, which is not a great idea. In this particular patient, you can see there are 2 or 3 dorsal branch of V5 into the RHB, which should be taken properly. And this is how the plane should be. We had a discussion at Srinagar with Kalai sir about what exactly should be the right transaction plane, and I'm still working out on that, what he suggested. But as on date, we are following this particular transaction plane, about just following the RHB up to the KEVA. And for this, the mobilized right lobe is very, very crucial. You can see I'm just holding the right lobe of the liver, the right posterior sector, and just doing KUSA on a very low settings mode. And the traction of the left hand of the first assistant is also very, very crucial. In our institution, we strongly believe that the most important step in a central hepatectomy is the preservation of the right anterior, right posterior pedicle. So we try to join the left and right transaction. You can see this is the left transaction surface, and after ligating the paracaval chordate branches to the segment 5 and 8, this is the RHB territory on the transaction surface. This entire thing is the right anterior posterior pedicle, right anterior pedicle. And after joining the left and right, I'll just pass a tape, so that above the tape there will be tissues around the MHB, and below there will be tissues around the right anterior posterior pedicle. The MHB is taken down, followed by the right anterior pedicle. The most important step, like I said, is the preservation of the right posterior duct, which is reported up to the tune of 20% in literature. So whatever central hepatectomy we have done in this year, it is 5 cases. We fortunately did not have any injury to the right posterior sector. This is a propofol leak test, and you can just suture it back. So the most important step is to rule out a right posterior ductile injury. That can only be done if you are following a pedicle last approach, like we routinely follow, and we tackle the right anterior pedicle at last. So this is what it is. In the best interest of time, I'll not show the subsequent slide. This patient is now close to 15-16 months follow-up and doing well. No post-op decompensation except for a ascites which was managed conservatively. Over to Kalai sir.
Dr. BD, I am Dr. Vimalakar.
Hi sir, how are you sir?
Fine. So it was an excellent presentation. For the sake of students, this is the only hepatectomy, anatomical hepatectomy. Actually, the steps of hepatectomy is inflow control, outflow control, parenchymal transection under low CVP in any case, especially in anatomical. Yes. But this is the only anatomical hepatectomy where you will go directly to the parenchymal transection. Most of the times, you will get inflow and outflow through the parenchymal transection. That is one point. Second point, I think even Madhu sir is there. There is no doubt about the parenchymal transection, right parenchymal transection in the middle in the central hepatectomy. We always will stay just on the surface of the right hepatic vein. But whenever you're reaching towards the IVC, definitely we should be double careful. The chance of injury will be very high. So always you will be on the surface of the right hepatic vein.
Yes, sir. Actually, what we believe, sir, almost all the tumors, except some very bulky tumors near the hilum, we can actually take the right anterior hepatic artery and we can actually clamp the right anterior portal vein in all the cases so that we can get a demarcation line and then start transaction. This is what we believe. But if the tumor is very bulky, doing the hilum at first will be difficult. So we just leave the right anterior sectoral duct transaction intrahepatically, but rest of the vascular transaction we can do it at the hilum right from the beginning, so that it gives a very clear field while operating on a cirrhotic liver. This is what we believe.
Hi, Patnaik. I'm Dr. Madhusudan. Can you hear
Hi,
me?
sir.
Yeah.
Yes.
Sometimes it's a nice procedure, but sometimes in a CLD with a very big lesions, high vascularity. So what I do is, we first isolate right anterior sectoral duct by extraglyconian approach, where you cannot reach the porta by conventional right anterior portal vein and artery. What I do is, like a Japanese, we taught from that. So we apply a Pringle, then I take a Kusa. So we will score just anterior to the right Rilvius sulcus. Then GB plate, anteriorly also we will make a scoring of the parenchyma with the Kusa in a avascular plane because you applied a Pringle. Then we reach into the deep right anterior portal pedicle and we ligate, then we'll go on. Ligation in the sense where I apply just vascular clamp will help for a clear right anterior sectoral demarcation, and also it decreases the flow. This is just my suggestion.
The issue is with type 3A ductal anatomy, sir. So in type 3A ductal anatomy, I think it may be slightly risky of taking a right anterior pedicle altogether extra hepatically. So, and like right anterior hepatic artery and portal vein, we can actually take it, and because the right posterior duct, it goes up to the hilum, it is plastered at the hilum most of the times, and then only it comes back to the roviers. So I think taking vascular control whenever possible, it should be done. But as you said, if it is not possible, you can take it intrahepatically as well.
Brahmadat, like you're saying the type 3 anatomy, exactly the point that when you do the Glisonian approach, right, all the biliary anatomy variations don't matter. Yours was a pretty straightforward case, well away from the hilum. As for a beginner who's starting, I think the central hepatectomy should be done by Glisonian approach. This extrahepatic dissection, separating the right anterior, right posterior, going in, slinging the right anterior portal vein separately, it's very risky, and the same thing you can achieve very safely. See, the segment 4 pedicles, then you go horizontally, like you can do it extra Glisonian, extra parenchymally, or during the transaction, you clamp the right anterior pedicle and you'll get the transaction plane there, then you can follow the right hepatic vein. I find it like, in Delhi also, I think if you're there, we had the same discussion. For central, why would you do extra Glisonian dissection for this kind of a tumor? Which makes it much more complicated, the procedure.
Sir, what I strongly believe is that because we do a good number of pediatric cases here as well, central hepatectomy. I think this year we have done some 2 or 3 pediatric also. So most of the time, if the tumor is big, there is hilar puckering. Suppose the tumor is just at the hilum, Glisonian approach is not at all feasible most of the time.
If it's hilar involvement, actually not good for central hepatectomy also, and you have to do extra
Glisonian. Not intrahepatic tumor, puckering the hilum. Suppose there's a big hepatoblastoma or big SCC sitting just at the hilum. In those cases, separating the tumor from the right anterior pedicle right from the beginning would be very risky, what I feel. But
that I agree.
If you
it's onto the hilum, yes.
Yes, if you are getting a good traction, like you have got a Thompson retractor, you are getting a good hand. If you are taking the right anterior hepatic artery and right anterior portal vein beforehand itself, then it makes things much easier. This is what I personally believe.
That's true. But if it's a ventral tumor, like in the case you showed, I mean, the Glisonian approach is safer. If it's onto the hilum, I do agree that if you want to do parenchymal, you might have to do extra Glisonian. But in the case you showed, like it's a ventral tumor, the Glisonian is much safer, I feel. Thank you.
Actually, honestly, we are used to this technique now, and in one more important thing is that we believe in a pedicle last approach. We do not divide the pedicle. We just leave the pedicle, the entire specimen hanging on the right anterior pedicle like a cauliflower, and divide the right anterior pedicle at last, because the most dreaded complication of central hepatectomy is a right posterior sectoral duct injury. So duct we are personally taking as a last in central hepatectomy. In minimally invasive like Vimalakar sir, we are meeting in 5 days time in Bhubaneswar. He is presenting on laparoscopic central hepatectomy in Celsius. I will be there. In minimally invasive, maybe the glycinial approach is better, but in open surgery where the view is from above downwards, I think hanging the whole specimen on right anterior sectoral duct is very essential. This is what we believe, sir.
Yes, yes. So in GIST, I think whenever you are getting good pedicle outside, if the tumor is away from it, go for. But in these central hepatectomies, you can do parenchymal transection. At the end, you can ligate the vessels and cut it off. That is my opinion.
Yes.
And one more thing, BDP, and do you regularly use intraoperative ultrasound to look at right and left hepatic veins, not the middle, right and left?
Not at all. Not at all. These are the initial cases like last week we are no more using. But if the tumor is just at the umbilical fissure, we are not sure about, because one case we took him for central hepatectomy, but we ended up doing a left trisectionectomy last month only, because intraoperative ultrasound we could not see any plane between the tumor and the umbilical fissural part of the portal vein. So it was difficult. So in those cases, intraoperative ultrasound helps, but otherwise, I don't think. Even we are using C-arm to preserve the right posterior sectoral duct for large hilar tumors. The whole specimen is hanging on the right anterior pedicle, but then again we are doing a C-arm in one or two cases. And once the integrity of the right posterior sectoral duct is secured, then only we are cutting on clips, like in live donor transplantation.
So that's one more important point. If the lesion is very big and if it is abutting right hepatic vein or left hepatic vein based on the location, either right or left trisectionectomy you should be ready with.
Yes, yes,
So
definitely.
that you should be prepared, and mobilization of the right or left liver based on the location is also must. So
Yes,
thank
yes.
you.
And
Thank
based on that, you should have your volumes ready for left trisectionectomy. Everything should be ready beforehand itself.
Next.
Thank you, sir. It was a wonderful presentation. Now we move forward. So next, me, Dr. Manisha Bandari from Team Vimalakar, and I request Dr. Rupesh sir from Interventional Radiology Team, KIMS Secunderabad. So we are bringing you a story of 64-year-old gentleman. So I proceed forward with the case. Yeah, thank you. So this is a 64-year gentleman presented with pain abdomen and mild chest pain. So he was in periphery, so he was evaluated there. So obviously he was mistaken for a gastritis, and ultrasound abdomen was done and routine ECG was done. ECG showed there was a changes of myocardial infarction. So he was referred here. So he was admitted with the cardiologist, and ultrasound incidentally showed a liver lesion that we'll discuss further. So he was admitted with the cardiologist, diagnosed with a double vessel disease, and he has underwent PTCA for the same. So incidentally, the caudate lobe tumor was detected, which was 12 into 8 centimeter, occupying entire caudate lobe. And on CT, it was diagnosed as hepatocellular carcinoma, which will be further discussed by Dr. Rupesh sir. And serum AFP then was only 20. But PUCA was elevated. The significant PUCA is more than 40, where this patient had 200. And so he underwent the PTCA, so he was on dual antiplatelet, and therefore we could not proceed further with surgery at that moment. Hence, he was planned for TACE. Further, giving over to Dr. Rupesh sir with Interventional Radiology Team.
So basically this is a plain CT image which was done. So the plain CT, we are seeing the lesion as Dr. Manisha had described. This was a caudate lobe lesion. But on ultrasound, the whole thing was described as a lesion. Here we are seeing a hyperdense component on the medial side of the caudate lobe lesion. So this is a 3D reformatted image of the lesion with the hyperdense component. So basically this was a large subcapsular hematoma which was extending into the lesser sac region. The good thing about this patient was we didn't have an intraperitoneal rupture. So this is the static images of the all phases. This is the plain CT. This is the arterial phase. This is the portal phase, venous, and the delayed. So on imaging, as it has been described in the previous speakers, so we are seeing a heterogeneous enhancement. This was predominantly from the left hepatic artery. Then this is the portal phase, and again we are seeing a delayed capsular enhancement. So this was a HCC by imaging diagnosis. So we planned for a TACE, but as the patient had, he was on anticoagulation and already he had some comorbidities, we planned for a DEP TACE. So this is the celiac artery run. So right femoral axis was taken. This is the cobra catheter in the right celiac axis, showing the right common hepatic artery. This is the right GDA, and right hepatic artery, left hepatic artery, and the middle hepatic artery. So again, selective runs were taken. So we went into the right, we went further up with the cobra catheter. And here if you can see, you will see a blush in the region of the lesion. So this is the blush we are seeing, which was predominantly being supplied from the left hepatic artery. So this is another image where we took the parent catheter further up. So this is the capsular enhancement which we were seeing on the CT. So we initially cannulated the middle hepatic artery because we knew there was left hepatic artery supply. So we wanted to check the middle hepatic artery also. So when we took the middle hepatic artery runs, we saw one small twig which is supplying the lateral right-sided portion of the tumor. So this small twig. So then we hooked the middle hepatic artery twig, and this is a microcatheter. So with the microcatheter at the origin of this artery, we embolized this medial lateral portion of the tumor. This is the DC beads which are passing. Then selective left hepatic artery runs were taken. So we're seeing this whole blush in the tumor. Then again, this is the embolization image where we used DC beads particles, and this is the final image after the embolization. And this is after removing the microcatheter, we take a final run through the parent catheter again to confirm so that we have just decreased the whole blood supply, but we have not embolized any of the parent vessels. So the advantage with DC beads is that the toxicity is less and there is better drug release as it is released over a period of time. So again, this was a 4-week follow-up CT. So this was a tumor. The hematoma is reduced in size, and there is significant necrosis in the tumor which was enhancing in the previous CT pre-procedure. This is all the necrotic portion.
Switch. So yes, after the TACE, where patient was kept for 4-month follow-up, because he was on dual antiplatelets, so we could not perform surgery. So 4 months we have waited, and then have seen in the CT, as sir has already shown, there was a significant tumor necrosis. That means a successful TACE. And also the PIVCA levels, tumor markers, have come down significantly from 200 to 40. And after complete workup and clearance from cardiology, definitely, we have proceeded forward with isolated chordate lobectomy. So this is the introp video, so where we have proceeded with Makuchi's incision. This is the incision being given, and there were a few adhesions of momentum to the liver bed where we have done adhesiolysis and started with cholecystectomy, where gallbladder is separated from the liver bed. Cystic duct, which is seen there, is clipped and divided. Further, this is the inferior surface of the liver where chordate lobe is seen here. Adhesiolysis was tried, but it was a huge tumor occupying entire chordate lobe, so we couldn't go there. So we opened lesser sac after dividing gastrocolic ligament, retracted the stomach towards cranial end, and we can see inferior surface of the tumor here. sorry, pointer. Okay, no problem. Caudate surface inferior lobe, and this is the lesser sac which we see. So this is the picture at that point where stomach, lesser sac and caudate lobe inferior lobe surface is seen. Then we have proceeded to right side of the stomach where lesser omentum is divided, tumor is being separated and delivered to the right of the stomach. This delivery is helped with the packing there. Now further we have continued with the hepatoduodenal ligament dissection followed by inflow control, where we have just kept the control but not performed Pringle maneuver there. So the inflow was taken in control, and this is the IVC with the tumor over the IVC which we can see. That is the caudate lobe over the IVC. And dissection started from the medial surface, that is the left end. Further dissecting from the left end, the tumor is being separated from the IVC. This is the retrohepatic IVC, where IVC lies behind, posterior to the caudate lobe. And these are few retrohepatic veins where caudate lobe derives its, like tributaries from caudate lobe are directly into the IVC. These are very notorious veins where we have to handle. So hemostasis is very important here, and these veins have to be ligated and taken control of and divided. So here meticulously each retrohepatic vein is dissected and ligated, then divided. Now further continuing with the superior surface of the caudate lobe. And superior surface, it is separated from the extrahepatic IVC which we can see there. So suprahepatic IVC and caudate lobe which we can see there. So superiorly also the caudate lobe is separated. There we can see IVC from left arrangeous ligament is also seen, that is nothing but ligamentum venosum. So this is a 12 into 8 centimeter tumor of the caudate lobe which is occupying entire caudate lobe. And this was taken out in total. So this is after the specimen removal, we have achieved the hemostasis with suturing and specifically that retrohepatic veins which I was talking about. So this is the IVC and the caudate lobe where it was there. This is the specimen which was removed in toto, which was occupying entire caudate lobe. It was a huge tumor. So this is the specimen. So histopathology, it was a poorly differentiated clear cell variant of hepatocellular carcinoma, stage of PT2. And there was no capsular or vascular invasion present. And all the margins are free of tumor. So after this, we have taken the opinion of medical oncologist. He said there was no need of post-op adjuvant chemotherapy. So the patient was doing well. So I would like to discuss few caudate lobe approaches which were mentioned. You have to decide which approach our surgery falls into. So there are 5 approaches which are mentioned: left-sided approach, right, combined, anterior transhepatic and retrohepatic approach. So coming into anatomy of the caudate lobe, so it has 3 parts where there is a caudate process over the right, in between there is a paracaval portion and pygial lobe over the left side. So this is the other thing is this is a superior view where paracaval portion is sandwiched between IVC and here the left side we can see pygial lobe and caudate process, where left portal vein and IVC are connected through arrangeous ligament, that is nothing but ligamentum venosum. So left-sided approach is usually followed for pygial lobe lesions, where we completely mobilize the left side of the liver. Left liver is retracted anteriorly, arrangeous ligament is exposed, and further dissection is continued. So this is the view from left-sided approach, where we can see caudate lobe between left portal vein and left hepatic vein. Next, right-sided approach is usually followed for caudate process lesions, where we mobilize the right liver by dividing right triangular ligaments and retract the right lobe forward and then expose retrohepatic space, and further dissection continues from there on. So combined approach is for large central tumors. So these tumors where both right and left lobe subsequently we mobilize, gain a circumferential exposure from both the sides, ligate the retrohepatic veins and go further. And anterior transhepatic approach is usually for deep tumors, deep-seated tumors, where we resect the parenchyma of the liver and approach to this. This is little risky with more bleeding. And then coming to retrograde IVC approach for posterior lesions. So where total surgery we approach from behind. So this is about the story of 64-year gentleman, and he is a practicing lawyer doing well.
So this is the image of the pre-op, post-embolization, and the post-op image. So complete resection of the tumor was seen. So just a couple of slides. So this is a paper from TMH with a 12-year study, which showed that preoperative TACE, when done in patients, was almost the patient survival was better by almost 3 times, from 30 versus 90 months, and the median disease-free survival also was better in the patients in whom TACE was done, pre-op TACE was done. So which are the tumors which we need to look for, which can present as bleeding tumors? In malignant hepatocellular carcinomas, 3 to 15% of them can bleed. Metastasis from NETs, RCCs, melanomas, choriocarcinomas and sarcomas, and hepatic angiosarcomas. Benign lesions, adenomas with 5 centimeters as the cutoff lesion, hemangiomas and cysts. Again, we can have pseudoaneurysms in case of trauma, in case of biopsies, post-procedures, and in patients with HELLP syndrome. So imaging wise, this is my last slide. So when we have a rupture, we need to differentiate whether it's subcapsular or intraperitoneal, because if it's an intraperitoneal rupture, then you need to check for seeding of the tumor before we take up for a surgery. So usually on imaging, we generally find a sentinel clot sign, which is the most hyperdense portion of the hematoma, is supposed to be closest to the site of rupture. Then in patients of shock, we can have flattening of IVC. When there's a fluid resuscitation, we can see periportal areas of flow attenuation. Why do these ruptures happen? Because there's neoangiogenesis, there is elastin deposition in the vessel walls, and there is microvascular injury. And in patients with decreased peritumor tissue and peripheral tumors, there's a higher risk of injury. Also, some papers have stated that with patients with portal vein thrombus, perihepatic invasion and hypertension, there's a higher risk of bleeding. Thank you.
Thank you, sir.
Yeah, nicely done. Isolated caudate lobe resections. I would like to share my experience because we published 11 cases of isolated caudate lobe resection in Journal of HBV. You can go through also. So commonly, left to right approach, because predominantly left side is easy,
yes,
and segment we call as a 9th lobe, so that will be the very visible on the left side. The problem we see that if it is bigger lesion, the anterior surface of the tumor, because it's snugly attached to the both the portal structures, you won't get plane. If you tear it, entire portal vein will open. We have seen some cases. So what we do in a bigger lesion, even some cases, even cava also, in case we resected cava also, what we have done in a bigger lesion.
Yes.
Medium sized lesion, yes, isolated caudate lobectomy, left to right approach is the best, which is my experience. A bigger lesion, more aggressive malignancy type lesions where you cannot separate porta or below from IVC, I do anterior hepatotomy along the right of falciform ligament. I will go to till the cava side. Then depending upon that, if you able to preserve the cava is okay, otherwise left lobe with the caudate. Left means segment 2-3 with the caudate, IVC resection and reimplant. This is the way caudate lobe cancer-free margin is possible. Otherwise a bigger malignancy. Why the caudate lobe isolate resection is challenging is because it gets blood circulation from both, and bile ducts also both, bile leak. So thing is, circumferential margin getting in a malignancy is difficult in a bigger lesion. So such cases I suggest is anterior hepatotomy and go radical margin. But your case nicely done. with intervention radiology decreased it. And definitely it's a more challenging.
One more point, just I wanted to add, very important chordate for anyone starting off chordate relation. One important relation is the superior border of the chordate, you have the MHV LHV trunk, and that's what you're afraid of worrying. In fact, that is one of the main reasons Madhu was telling you transit the parenchyma to locate. One approach you can do when you're starting off is, after you divide the ligament, Allansius ligament, sling the common trunk of the LHV MHV and use that as a hanging maneuver. You can understand it's excluded, and use that as a hanging and you can save that. That's very useful when you're starting off in chordate lobe resections.
Yes. Thank you. So, yes, it was a very good session. So now we proceed forward for group photo, but only both of us are there.
Yeah.
Rest of us are online. Yes. Thank you, sir. After this very interesting session and cases, now we move forward to the fourth session on cystic lesions of the liver. I request Dr. Vimalakar Reddy from Team Vimalakar to present about and share his insights about the cystic lesions, and I invite Dr. Vishesh Agarwal, consultant radiologist from KIMS Sunshine Hospital, to face off Dr. Vimalakar Reddy sir and discuss the cases.
I know everybody is hungry, but this is very important session because presentations also. Yeah.
I request Dr. Rohan P. Reddy sir, consultant medical gastroenterology, KIMS Sunshine Hospital, and HOD senior consultant Dr. Vijay Kumar Bada sir from Yashoda Hospitals to please grace the dais.
So meanwhile, I'll start. This is a 69 years old gentleman with pain in right hypochondrium and epigastrium, with fever and chills for 15 days. He was a known diabetic. Clinically, he was stable. There was no tenderness. His labs were, except for ALP with minimal raise in bilirubin, with total count of 13,000, rest all were normal. After seeing this X-ray, we were surprised actually. So now about the imaging, my colleague will talk.
So,
switch.
So this is the first case that we had. We noticed that a CECT chest and abdomen was done. On abdomen, we noticed that there's a well-defined hypodense lesion which had internal membranes which were floating. The image on the left is the plain CT, and on the right where the aorta is highlighted is the arterial phase. We can see that the lesion is hypodense, there's internal membranes and there's surrounding mild edema. The lesion is epicentered in segment 4 but also involving other segments of the right lobe. Also, there is some enhancement of the wall on arterial phase. On coronal, we notice that there's mild splaying of the portal vein, but not significantly compressing it. On sagittal, as you can see, there's gallbladder is extremely dilated. There's some IHBRD as well. So that IHBRD possibly is because of some compression on the biliary system. The CCT chest of the same patient showed on HRCT chest window, we can see a well-defined cystic lesion. The anti-dependent part of the lesion shows air, while the dependent part shows fluid density. The lesion is almost reaching onto the anterior chest wall. On coronal, we can see there's no rib erosions, it's not destructing, it's not a very malignant appearing lesion. It is abutting the mediastinum but not significantly causing compression of the vessels. It is a very characteristic cystic lesion, very typical looking hydatid cyst. More typically, what type of hydatid cyst it is CE3A type of hydatid cyst, where we are seeing detached laminated membranes giving the classic water lily sign that we learn. So this is the WHO classification. This will be the base of my talk. I'll be just going through some theory before I go ahead. So what is a CE3A type of hydatid cyst? Where the daughter cysts have detached their membranes and fold inside the cyst as well. So it will give this water lily sign. On CT MRI, we'll have the similar appearance. So on USG, fluid, that is cyst, looks anechoic. So we are seeing anechoic means dark. So we are seeing one black cystic lesion with internal membranes, and there's also a few echoes here and there, which is suspicious for hydatid sand. On CT, this is how it looks, which is very typical of our case, a well-defined hypodense lesion with internal membranes. On MRI, this is a T2 weighted non-fat suppressed MRI. On T2 weighted image, fluid appears very, very hyper intense. So over here we are seeing a fluid cystic lesion with internal membranes. So just a very brief through the theory of hydatid cyst before Vimalakar sir takes to the management. Hydatid cyst has 3 layers, ecto, peri and endocyst. This is not that important, just that endocyst gives rise to the daughter cysts. Now imaging features, plain radiography may have limited role. If we are lucky, like in our case, how Vimalakar sir first picked up on chest x-ray, we can see the lung lesion directly. For an abdominal hydatid, if we are lucky again, we can see calcifications in the liver in the periphery of a lesion. So what is the WHO classification? So WHO classification starts from CE1 to CE5. A CE1 lesion is a unilocular simple cyst with 2 membranes. That is how we differentiate from a simple cyst, where we are seeing 2 membranes on the periphery. This is called the double line sign. Almost every stage has some sign associated with it. So double line sign is with CE1. With CE2, we have multiple septations giving it a honeycomb appearance. So that is called a honeycomb sign or a multivesicular rosette sign. CE3A, the cyst walls have detached and they have floating inside the cyst. So that's called the water lily sign. CE3B, we'll have daughter cysts within a solid matrix. Now we must remember this is not typically solid, it's like a semi-solid, like a jelly-like matrix. CE4, we'll see heterogeneous content solid appearance. So this sign is called the cotton wool sign. And CE5 will be solid calcified wall, or if it's a completely burnt out hydatid, it will be completely calcified. So this was about how hydatid cysts look. Complications, there are mainly 3 complications. 1, rupture. So it can be either ruptured within itself, which is the CE3A type of hydatid, which I just discussed. It can rupture and communicate with the biliary tree, giving rise to intrahepatic biliary radical dilatation. It can rupture into surrounding bowel loops, where we can see air foci within the hydatid cyst. Ideally, we should not see a air within a hydatid in the abdomen, but if we are seeing air, we should suspect if there's some communication with bowel. It can rupture into the adjacent viscera, like in this case, it is going through the diaphragm and possibly will rupture in future into the lung. Also, if you are seeing some air foci in the hydatid cyst without any complication, we suspect infection. Mass effect related complications can be compression leading to IHBRD or on other organs leading to compression like hydroureteronephrosis in this case. Just one final touching point for this case. In the lung hydatid that we can see, we are seeing some air foci in the wall. That is not typical. If we are seeing these air foci within the wall, we have to suspect rupture or impending rupture. That's it from my side, sir. Taking over to you.
Yeah. So, switch. So in that case, we could see the cystobiliary communication. So that's why we have done preoperative ERCP and stenting. We could regarding role of ERCP in hydatid cyst, Dr. Rohan will talk. This was the ERCP picture. Pus was there, around 500 ml of pus. Yeah, we have stented. Then we have taken up for surgery. So why did we do the division of falciform? Just for the retraction sake. And after that, that was the hydatid. So directly we have done that small rent in a cyst, puncture of the cyst, then aspiration, After that, usually I use either hypertonic saline or betadine. In this case, actually, there was a cystobiliary communication we have suspected, but anyway, stent is there. With that confidence, I used 5% betadine for 10 minutes contact time. So after that, reaspiration, you can see the daughter cysts. That is cyst deroofing. Almost possible anterior wall of the cyst was deroofed. Now I was looking for the cystobiliary communications. You can see there was a small communication. So I have sutured from inside with the PDS. That was second communication. I was suturing. So like that, there were three communications were there. After that, we have given thorough wash. We have searched for other communications. We could not find any cystobiliary communication. Then, with that confidence, we have placed drain and we have come out. We have searched for other. So then, lung lesion. So in the same sitting, we have placed the patient in prone position, and I did thoracoscopy. In that, we could see the hydrated of the lung, and if you see, there was a air in the lung cyst. So that's why we thought there will be a definitely communication with the bronchi. With the stapler, I was doing partial pneumonectomy. So after using three staplers, we did leak test to look for any any pleural communication is there or not. So the leak test was negative. So we checked thoroughly, there was negative leak test. With that confidence, we have placed the drain after removal of the specimen. But so this is about cystobiliary communication. If the cyst size is more than 10 centimeter, if it is centrally located, especially 5, 8, 6, 7, the chances of communication will be very high. If preoperatively, if the bilirubin is raised or like this, the patient is having fever with chills, and on imaging, if you can see any defect in the cyst or biliary side, or IHBRD is there, you have to suspect the cystobiliary communication. Surprisingly, after stenting, after suturing from inside, next day we could see lot of bile in the drain. That was on POD1. So again, we went in for ERCP. In ERCP, you can see whole contrast is going into the cavity. So then, after 2 days, that drain got blocked. We have to place few pigtails. And this is a chest X. This was a chest X-ray on POD1. It was absolutely fine. Again, on POD3, we could see the pneumothorax. So we had to put one more ICD and drain that chest, but there was no pleural fluid, just air was there. And in between, he has developed ventricular arrhythmias. We could manage with the amiodarone. But one thing, after 1 week, we could remove the ICD without any intervention. After 20 days, we could remove all the drains without any intervention. So the message in this case is, though you can identify cystobiliary communication before surgery only, if you place drain also, if you identify cystobiliary communication on table, if you suture also, there is a chance of leak from the drain, leak from the cyst. But if you manage conservatively, most of the times you can get out. Even that is true about the lung cyst. In case 2, This is 49 years old gentleman with the jaundice and pain abdomen with abdominal distension for 1 month with loss of appetite and loss of weight. So vitals were stable. There was a tender hepatomegaly with tender hepatomegaly was there, and he was having severe pain in the right hypochondrium. This was referred from outside, from Kakinada actually. So patient was having raised bilirubin with the raised ALP, and GGT was also raised, and total count was around 11,000. This was the video sent by a surgeon from on table. The cirrhotic liver, he didn't do any CT scan, just with the ultrasound, they missed the complete cyst. So that was a cirrhotic liver with acute cholecystitis for them. So then they did MRCP. In MRCP, it was a very large cyst. Yeah. Read.
Yes. So we have the outside CT and MRI films with us for this case. There's a very large, almost like a bilobed configurated cystic lesion. Now note that the density is not completely hypodense as a cyst. The matrix is a little less white than the expected cystic lesion. There are multiple other hypodense cystic lesions in the periphery which represent daughter cysts. So this was, in this case, as we can see, like Sir said, there's frank cirrhotic morphology of the liver, left lobe hypertrophy. Also, compared to the previous case, there is significant compression and splaying of the portal vein in this case. Also, as we can see, in the pelvis region, there's another omental hydatid which is having the same appearance of a semicystic lesion with multiple internal daughter cysts. On MRI T2 weighted images, we can see that the matrix is not completely bright. I agree it is a little bright, but the matrix is mildly hyperintense, but the daughter cysts which are predominantly at the periphery are having multiple cystic lesions. So this was a CE3B type of hydatid cyst where we have daughter cysts within a solid or semi-solid appearance. So on ultrasound, we can appreciate these daughter cysts. On CT and MRI, it will be like a multiloculated cystic lesion like the case we had. This is how it will classically look on an ultrasound. CT case was fairly typical, fairly classical R case. Over to Sir for the discussion of this case.
Yeah, so we went in, there was acute cholecystitis, distended gallbladder was there, cirrhotic liver was there. So first we have decompressed the gallbladder. So for the sake of postgraduates, why gallbladder surgery is difficult in cirrhotic patients? Not because of only bleeding. So the liver will be very stiff, the retraction will be difficult. At the calyx you may have some collaterals. In the bed you may have some venous collaterals. And so that's why. And even the patient may have coagulopathy. All these reasons may contribute for the difficult cholecystectomy in gallbladder. So after doing cholecystectomy, that was the cyst. I punctured it, aspirated. Again, I've used, because there was no cystobiliary communication on imaging, so I've used betadine here for 10 minutes, then reaspiration. If you see, it was densely stuck to the diaphragm. Those are the daughter cysts. Maximum anterior deroofing was done. So always in hydatid cyst, you have to use 10 mm suction because the chance of blockage will be very high with the 5 mm suction. And always you should keep 2 sections ready because it keeps blocking. There is a diaphragm. So I was separating from the diaphragm. You can see the diaphragmatic muscles. So when you aspirated, there was no bile tinge. On imaging, there was no cystobiliary communication, and we could not see any cystobiliary communications on table. Then we have proceeded with this omental hydatid excision. But surprisingly, next day the patient had bilious drain. So, but this was less than 500 ml, so it is labeled as a minor cystobiliary communication. We could manage conservatively. So type 1 is occult, microscopic, So tiny bile ductules will be communicated with the cyst cavity. We can miss in, they may not present clinically, and we can miss even on imaging. So usually they are asymptomatic. So if it is type 2, that is frank or macroscopic communication, it will be large, visible. We can identify an imaging. They will present with obstructive jaundice, cholangitis, and biliary colic. So for that, the management is obviously surgical. But this is a classical Niemann's classification. But in our both cases, both are reversed. So in that case, we had to do post-operative ERCP and stenting. And after stenting, the patient got discharged within 2 to 3 days with a minimal discharge from the minimal drain. And after 2 weeks, we could remove the drain. And after 1.5 months, we could remove the CBD stent. In case 3, she was a 53-year-old lady, diabetic with abdominal pain and bloating for 3 months, clinically stable. There was no tenderness. LFT was absolutely fine. CBP was fine. If you see, there is a lesion which is, we don't know from where it is arising. Over to you.
So this was again an outside case, a very peculiar case rather. There is a well-defined lesion in the left lobe of the liver, but as we continue to scroll further, we see that the lesion, predominantly the lesion is cystic with septations, but the lesion is exophyting, going all the way to reaching up to the anterior abdominal wall. On coronal sequences, we can see that anteriorly it is abutting the spleen, but posteriorly we could not see the spleen at all. So it was suspected that there's gross invasion of the spleen as well. So it was suspected to be a multiseptated cystic lesion arising from the left lobe with extension into the anterior abdominal wall and invasion of the spleen. So this was not a fairly typical case, but we can call it a CE2 type of hydatid cyst, where we are seeing multiple septated cystic lesion giving rise to a honeycomb appearance. So these are the ultrasound and CT MRI findings of a CE2 type of hydatid. It will be an anechoic multiseptated cystic lesion on ultrasound. On CT, we can see multiple hypodense cysts separated by each other from septations. The septal walls are nothing but the walls of the daughter cysts itself. On T2 weighted image, as we can see, contrary to our prior image, over here the lesion is predominantly cystic. The T2 weighted intensity is extremely hyperintense, not like that mildly hyperintense in which the C3B type of lesion. Over to sir.
Yeah. So in this case, we did splenectomy with partial hepatectomy. That lateral segment we have removed with the laparoscopy. Yeah. So this is done in 3D, again recorded in 2D. This will look like this. So that was a lesion densely stuck to the diaphragm, spleen and the liver. So we have done splenectomy, we have done hepatectomy, I mean non-anatomical hepatectomy, and due to lack of time I want to rush. Fast forward. Fast forward. Fast forward. See, that is a non-anatomical hepatectomy, and at the end we could see rent in the diaphragm. The diaphragmatic rent was closed, and we have identified the splenic artery, splenic vein separately. Later, first we have taken up with the ligature, then we have identified the splenic artery, splenic vein separately, and we have done splenectomy with partial hepatectomy with the diaphragmatic suture. This very interesting 63-year-old gentleman present. You have seen partial hepatectomy, you have seen deroofing with the cystobiliary communication closure, and you have seen deroofing without cystobiliary communication. This is cystopericystectomy. So 63-year-old gentleman presented with the incidentally detected cystic lesion in the liver, but it was very big. Labs were normal, radiology, CT.
So this is the next case or the last case that we have. There is a well-defined lesion. At this point, we have the plane and the arterial phase. At this point, I can't even call it a purely cystic lesion because we are seeing heterodense contents within. Some of the contents might be soft calcifications. On arterial phase, if there is minimal to, if any, contrast enhancement that we are appreciating. The whole heterodense contents is in a background of a cystic lesion. The lesion is predominantly in the right posterior upper segments. On sagittal image, we can see that the lesion is confined primarily to the liver. On corneal also, the lesion looks predominantly confined to the liver. There may be some extrinsic compression on the gallbladder. The same case anteriorly in the left lobe had a very densely calcified lesion. So in the background of already a hydatid cyst, possibly a CE4, this lesion could have been a burnt out hydatid cyst. So this was a case which had a both CE4 and CE5 type of hydatid. So CE4 type of hydatid is a cyst with heterogeneous hyper and hypoechoic content. Like I said, every cyst, every stage of hydatid cyst has a sign associated with it. So this is ball of wool sign. We'll see heterodense cysts with mixed hypodense, hyperdense areas. On ultrasound, sometimes this diagnosis may become a little tricky because if you see this image, we can't even call it a cyst at this point. On CT also, this looks fairly typical and like a little like our case. However, there's no dense calcifications like a soft calcifications like that in this case. On MRI, we are seeing a cystic lesion with swirls of heterogeneity. A CE5 type of hydatid has a solid calcified wall or maybe completely calcified. So on ultrasound, if there's any calcification, it throws dense post-acoustic shadowing. That is how we'll determine that there's calcifications within the lesion. On CT, hyperdense calcifications may be at the periphery or a complete burnt out hydatid. Over to you, sir, for the management of this case.
So in this case, we have done robotic cystopericystectomy. So if you see on imaging, it was playing both the portal veins. So it was like almost central hepatectomy again. So after cholecystectomy, after controlling the HDL, most of the times I'll take with the ribbon gauze. Then if you see, it is centrally located in 4B, 5 and 8. This is the advantage of robo. Somehow it is a RB energy source. So monopolar works very well. With the monopolar and bipolar, as our Kalai said, you can complete even hepatectomy. So we are playing around the vessels. There was a right hepatic vein, right side. Both the portal veins are splayed, and there was a feeder vessel. If you see, there was a small rent in the portal vein. The suturing is very easy, comfortable with the robo. If I want to suture the same thing with the laparoscopy, definitely it will be difficult because narrow space, there is a big lesion. So in that angle, if you want to suture, it will be very comfortable with the robotic arm. So I am going in the plane, the proper plane. If you miss the plane, again the bleeding will be very high. If you see, there was a right hepatic vein. On the right hepatic vein, we were playing. So that is completion of the complete cystectomy. So the advantage of laparoscopy is you can reach posteriorly very comfortably. Your arms will be flexible. You can suture comfortably. And with the monopolar, without ligature, you can complete the surgery. So this video got Best Video Award in last IASG 2025 Chennai. So that was a cyst. So with this, so there are 3 procedures basically: pair, deroofing and cystopericystectomy. Absolutely, cystopericystectomy will give better results with less than 5% of recurrence when compared with the deroofing and pair. There are clear-cut guidelines where to go for pair, where to go for deroofing and where to go for cystopericystectomy. I don't want to go into the details of it. If it is a solitary peripheral non-communicating cyst, usually cystopericystectomy is easy. But in our case, it was centrally located. We have gone for deroofing only. After seeing that, obviously surgeon will have that itch. So it was going well, so that I could do cystopericystectomy. Actually, in that case, where the portal vein, bile ducts and the hepatic vein is around, better not to go for cystopericystectomy, you can get out with the deroofing. And pair basic you can do with the ultrasound guided or CT guided in small lesions, CE1 to CE2 cysts. Thank you. Thank you one and all.
Thank you, sir. That was very interesting case series on hydatid cysts. Now I request Dr. Vijay Kumar Bada, sir, Senior Consultant from Yashoda Hospitals, to present and state his insights with the cystic lesions of liver.
Good afternoon. At the outset, I thank Vimalakar and KIMS for this opportunity. I know that most of the minds and the GI systems are in the lunch hall. With whatever little physical presence I've got, I'll try to see that. So you've seen a spectrum of the hydatid disease. I'll just go through one case, which, okay. So this is what you're seeing in that, okay. Can you share my presentation? Pointer. Okay, meanwhile, what we'll do is, when you get a patient with a cystic lesion of the liver, all cysts need not be hydatid cyst. And if you have a complex cyst vis-a-vis hydatid cyst, the difference in the treatment is very obvious. So if you think that it is a hydatid cyst and you end up doing deroofing or a partial cystectomy, then you may be in some trouble. So we have to see little delicately as how we should be looking. This is a middle-aged female, came with dull aching abdominal pain, low-grade fever, no jaundice. On examination, there was an ill-defined lump in the right hypochondrium extending up to the right iliac fossa. The lab investigations were unremarkable. There was no jaundice or cholangitis. Ultrasound said a SOIL in liver, and then a CT was done. I'll quickly go through this. You can see here. There's a plain CT, no obvious calcification. There's a large lesion, predominantly exophytic echogenicity. So then we right hepatic artery and also the right posterior segmental vessel. So this is what you have to remember, that when you are trying to get this cyst out, what are the vessels that you're likely to encounter, and what is your planning. This is another phase. We'll look at this. This is a voluminous phase. So you can see that fairly large cyst. Luckily, predominant component is the exophytic component, and no classical features of hydatid nor to rule out. So in these cases, doing a deroofing might be not the ideal one, so we decide to do what you call a total cystopericystectomy or a enucleation. This, you can see, this is a large component. Where I've marked here is where the bile duct is approximately around. So this has got all the high-risk features of a biliary communication or a close association with the biliary artery. So there is a chance of having a biliary injury or opening up that biliary communication, which you should be aware of. Option of doing a preoperative ERCP is also there in this, but because we thought that we will be excising this, we didn't go for that. So this was a surgical planning. We wanted to, we did the patient in supine position. We used 4 ports. We used the 4K system. We had the option of using harmonic and ligature, and we also did use ICG for this patient. These were the port positions. We had an optical trocar entry through the Palmas point, and then we had one 10mm scope. This is how it looked like. First, we make an assessment of how it is. This is the port placements. Look at how the hilum is placed, what are the attachments and the locations it is. In case it is a hydatid, we cover them with the antiscolicidal. Then we aspirate, inject this colicidal, and then decompress the cyst as much as possible. You can see that it looks like a multiloculated one with little bit of that biliary tinge inside. And then we decide to do use a ICG and demarcate the margins, and I do this whole of the resection keeping the ICG on so that I have the complete margins of the liver. So we start with the more medial one, lift, see the hilum. So we know that when we are coming close on the bile duct, we have to be careful where we'll get this biliary injury or a cystobiliary communication which we can get. So I've used predominantly harmonic in this dissection. We can as well do with the ligature or a bipolar with monopolar combination. So we try to make sure that we are on the surface of the cyst, not opening up the cyst, and also not getting into the liver parenchyma too much, because we just want a complete enucleation, or what you call a complete cystopericystectomy for this lesion. So care has to be taken not to get into deep, because the CT scan has to be in our mind throughout this surgery. And ICG comes handy to tell us where the liver and parenchyma is there, and if there are any biliary communications. So liberally use the gauze pieces and not try to attain the hemostasis too much using energy devices. You can see here that I ended up opening the cyst, so we redefine our margins, get more onto the liver and parenchyma. This is a relatively easier surgery to do, where the component of the cyst is predominantly exophytic, because you don't actually encounter the bigger major pedicles as much as in this case. So, however, most of the dissection when you are on the liver and parenchyma has to be relatively blunt and sharp, and not totally sharp, because you end up injuring one of the portal pedicles when you do totally sharp dissection. So try to separate the cyst wall away from the liver and parenchyma, so that some of the vessels will get exposed and you will be able to delineate those vessels and dissect them quickly. If you see that, I have not shown you completely, but intermittently we take off the ICG and then try to dissect the cyst away, and we keep the ICG and try to go follow the demarcation that the ICG helps us in getting the liver and parenchyma away from this lesion. Can I move a little forward? Okay. So I'm keeping the cyst wall in view. That opening the cyst indirectly helped me to see what is the extent posterior or the cranial extent of the cyst wall. So that will help me to go more cranially into the cyst and not opening the cyst at multiple places, in case this is not a hydatid and it's one of those complex cysts where you do not want too much of spillage and breaches in the cyst walls. So you can see here that the margins are getting clearer now, and this is the place where we will have some of the vessels which we saw on the imaging, which will be closely associated. That is why we will do a little bit more blunt and sharp dissection here. Because this falciform was coming in the way, I just hook it up and I don't divide that one. So when we come close to the hilum, this is where we have to be careful, and this is where the ICG plays a much more important role. You can see here that as I'm doing most of it blunt dissection, separating away, I had in mind in the arterial phase one of the larger feeder was getting into the cyst, so I had to separate that from the hepatic artery pedicle. So in most of the liver surgeries, needless to say that your imaging has to be at the back of the mind always, so that you know exactly where you are dealing. So this is where we get that vessel which is feeding into the cyst. We separate that one, and actually you can closely see the vessel getting into the hilar plate also. So then we clip this, divide this, and then proceed with our dissection. Move forward. So here you can, So as you come here, this is the most important area where I'm close on the bile duct, and I keep separating that one. Come back. Yeah. Okay. If you see here, I'm separating this away. I think we had a small bile gush out with the from the ICG was showing us. I don't know whether you missed that. Yeah. So this is the last part of the cyst. We separated it. This is a small pedicle which was there, which was close to the bile duct. That's why we keep it intact and do it in the end. Encircle all the cyst from on those sides, and then you make sure that you are not actually having one of the main bile duct pedicle, and then you divide this. You can see the end of the cyst wall also, and then we divide and make sure that we are not having any luminal structures there. Actually, you missed that one. So once we clear off all the cyst, we knew that we had a small bile leak there at the bile duct, and then we repair that bile leak once we remove the cyst completely. Small vascular pedicles there, just pack them with the gauze pieces, complete the excision of the cyst completely, and then we place it in the bag and then deal with the bile duct injury or the bile communication leaks or the bleedings later on. So a little bit of that pack actually helped us in stopping the bleeding. So you can see here that pedicle, portal pedicle, you can see very clearly, and we'll have a very good vision once the cyst is completely, specimen is removed, to actually clip it or repair those bleeders and the leaks. So the small ones you do this. So then we handle the biliary injury. So here you can see here, there's a small rent in the bile duct. We keep use ICG on, and that is going into the main bile duct. So this is probably at the origin of the left duct or the confluence, a small one. So we try to close it interrupted using a 5/0 PDS. So the orientation and the angulation for the suturing should be important. You may have to swap your camera and get into a better position to suture this one. So you should also make sure that you don't close the bile duct in the anxiety of closing the rent. So here if you see, after I take the first bite and come on to the second bite, the other option here is to do the cholecystectomy and do a ICG intraop cholangiogram to know which part of the duct it is injured, and then you can repair that one. Because here I was pretty sure using the ICG I could see where it was. So before I close it, I made sure that I have not closed the duct, used a small intracath tube to make sure that I am not closing the duct completely, and then put another 2 interrupted sutures. And then we leave a drain. So this was all about how we manage this one. Multiple options will be there for this. So post-operatively, day 2 and day 3, we had a very clear drain output. Happy that there was no bile leak. But as soon as we removed the drain, we had a gush of fluid coming out that was bile stained. And then we placed a percutaneous drainage, ultrasound guided. And then we did a ERCP to be very sure that also drain output was 100-150 ml. There was a small leak, or probably from the origin of segment 4. We did a sphincterotomy, and then the drain output reduced and the patient is stable now. So the message here is that any cystic lesion in the liver should not be taken as a hydrated cyst with some features and try to do a partial de-roofing, because this biopsy turned out to be a mucinous cystic neoplasm of the liver, which is very rare. And that has got almost 15 to 20% chance of transforming into a cystadenocarcinoma if we have done a partial cystectomy or a de-roofing of this cyst. So that is where the message I think this case should give us. Thank you very much.
Thank you, sir, for the brilliant presentation. Now I welcome Dr. Rohan P. Reddy, consultant from Medical Gastroenterology, KIMS Sunshine Hospitals, to share his insights with ERCP role in hydrated cyst. Over to you, sir.
Thank you. At the outset, I would thank the organizing team and Dr. Vimalakar, Team Vimalakar, for inviting me for this talk today. So I'm going to give a very brief presentation on the role of ERCP in hydrated disease, the clinical role when you should be calling your endoscopist to come in and help you. So a little bit of epidemiology. Hydrated disease represents a significant hepatobiliary challenge where 70% of the time it's hepatic involvement, and out of these about 10 to 20% have the problem is because of a biliary communication. So the biliary communication leads to something called as a cystobiliary fistulas. So they occur when the cyst ruptures into the biliary system and create a communication between the cyst and the bile ducts. So the pathogenesis involves that because of the increasing size of the cyst, there's a pressure necrosis of the adjacent biliary radicals, and thereby creating a communication channel. So they can either be a very minor fistulas, which approximates about 10 to 37% of the cases. These are usually asymptomatic and are not diagnosed preoperatively by imaging. Whereas the major fistulas, there is a wide enough communication between the cyst and the biliary system. Majority of the time, these can also cause obstructive jaundice leading to cholangitis and other biliary sepsis. So the clinical presentation most of the time in these major communications is obstructive jaundice, because the scoliosis go into the biliary tract, thereby causing obstruction to the normal bile. These represent about 20% of the cases, and especially true when the size of the cyst is more than 10 centimeters. When the obstruction is severe, these can also lead to cholangitis and other pancreatitis. The biliary pancreatitis is also a possibility. So the key predictors is the cyst size most of the times matter, where the mean size of the cyst, about 18 centimeters, is associated with significant cystobiliary communication. And anything more than 10 centimeters, there is a risk of some minor fistulas that can be there as well. And 69% these cystobiliary fistulas results, if they are not preoperatively managed, can lead to fistulous formation post-surgery. So the cyst size was an independent predictor of fistulas, and most of the multivariate analysis represents that these are the independent predictors of post-operative bile leaks also. So the imaging characteristics, I think Vishesh did a good job in telling about most of the imaging findings. So when is ERCP actually indicated in these patients? So preoperatively, when there is a significant, when the pre-imaging clearly mentions that there is obstruction prior to the surgery, there is biliary decompression is a role. When patient presents with significant obstructive jaundice, there is features of cholangitis, there's features of obstructive jaundice, then preoperatively ERCP is indicated. Intraoperatively, when there's significant bile leak during the surgery, when there's bile leakage, which is not controlled by operative sutures, then intraoperative role is there. And post-operatively, when the drain amount is significant, more than 300 ml, so is usually indicated post-operatively. So when do you consider ERCP preoperatively is when there's a history of cholangitis, there's history of obstructive jaundice, or when the cyst size, even without a definitive imaging feature of cystobiliary communication, when the cyst size larger than 10 centimeters, a preemptive ERCP stenting can be considered in these patients. So now the success rates preoperatively is anywhere between 80 to 100%, and it is very important to decrease the post-operative fistulas and post-operative bile leaks. So some additional advanced techniques where there is a couple of studies which show that there's nasobiliary cystic drainage which can be done, and these 7-day saline irrigation can be done with a nasobiliary drainage tube. And there's one study which showed that about 12 of the 14 patients in this study with a cyst size about 10 centimeters, there's complete cure without the surgery. But this was only one particular study which showed these results. Case from our unit, there's a 52-year-old female presented with progressive obstructive jaundice with the features of obstructive jaundice and imaging showing a clear-cut hydrated cyst. A pre-operative ERCP was done in this patient where the papilla was cannulated, and once the cholangiogram was done, cholangiogram showed a significant dilatation of the CBD with multiple filling defects in the proximal and the mid CBD level. So this is the cholangiogram image. So once in this patient the sphincterotomy is done, majority of the CBD was decompressed. You can see a significant amount of obstructed bile that is draining out. And once the balloon trawl is done in this patient, there's a lot of cyst fluid debris and a lot of protoscoliosis which are coming through the biliary tract. So these cases are usually stented to mitigate the risk of post-operative communications, post-operative bile leaks, and the stent is usually removed 4 to 6 weeks later after the surgery. Post-operatively, the primary indications include recurrent symptoms or biochemical abnormalities, any persistent drainage through the percutaneous drain, and sometimes there can be also strictures which can be formed, especially in patients where the scolicidal agent or PAIR procedure is done prior to the surgery. ERCP is the gold standard for post-operative cystobiliary fistulas, where ultrasound or a
8 cases are like 8 stories where we learn moral from each story. So now I request everyone to please stand up for the invocation song to invoke positivity and grace as we begin the session. Let's have the invocation song, please, to officially begin the session. Thank you, sir. So now the traditional lamp lighting marks the beginning of every auspicious occasion. Now may I invite the dignitaries, Mr. Sudhakar Jadhav, COO Kim Sunshine Hospitals, onto the dais, Professor Dr. R.A. Shastri sir, Senior Consultant, Surgical Gastroenterology, KIMS Hospital, Dr. Pratap Reddy sir, HOD, Senior Consultant, GI Oncology, Baswatarakam Indo-American Hospitals, Dr. Birappa Nagari, Medical Director, HOD Surgical Gastroenterology, NIMS Hospital, Dr. Suresh Sepuri, Secretary, Telangana Association of Surgical Gastroenterology, Dr. Madhusudan, Professor, HOD Surgical Gastroenterology and Liver Transplant, Usmania Medical College, and Dr. Sridhar, Telangana ASI President-elect. Sir, please join the dais and we'll move forward with the proceedings of lamp lighting. Yes, sir. I now invite Mr. Sudhakar Jadhav, COO Kim Sunshine Hospital, to share few words and convey message on behalf of the institution.
Thank you, Manisha. I think I'll be very brief because it's lunchtime and I think we're running late for about an hour or so. Just wanted to convey, first of all, congratulations to Team Vimalakar. The commitment which I think Dr. Vimalakar has been exhibiting, quite outstanding. In fact, he just completed about 10 years. And some of the highlights this particular year is that apart from completion of 10 years of Team Vimalakar, I think we are also celebrating the fastest 100 robotic surgeries in KIMS Sunshine Hospital, which itself is a huge, remarkable milestone, I would say. Second, I think from a brand perspective, KIMS Sunshine always people used to feel that it is an orthopedic institute, but I think Team Vimalakar, in fact the other specialties including medical gastro, we are kind of becoming a center of excellence specifically in GI surgery department. I think all credit goes to Team Vimalakar. The final word which I wanted to kind of leave some thoughts is that we are committed to the academic excellence, and this is the first series which Dr. Vimalakar has started, and as management we are with him to fulfill the commitment of these kind of academic programs and academic series. So with this, thank you so much. Would invite everyone for lunch now. Thank you so much.
Thank you, sir. Thank you for the kind words and immense support you have provided us. Now, we are very privileged to have the opportunity to host the next 2027 IHPBA prestigious conference right here in our Hyderabad. So I invite Dr. R.A. Shastri sir, organizing chairman of the IHPBA conference, to unveil the first look official poster of the conference and also the logo. Yes.
It's a privilege to launch the logo for the prestigious
Thank you, sir. Thank you so much. And we are very privileged. So now we can proceed forward for the lunch. After the brief lunch session, we'll conclude it around 15 to 20 minutes. And then we'll come back with interesting cases again. Thank you.
Even level 1 evidence also. So, for a postgraduate purpose, whenever you are planning for a major hepatectomy in the background of CLD, two things is important. One is bleeding, another is post-hepatectomy liver failure. There are so many maneuvers came. One is to stop simple, Pringle, intermittent, continuous, hemi-Pringle like that. Sometimes, if it is not able to control, you can apply a total vascular. Sometimes ask anesthetist to keep a low CVP, liver hanging anterior approach. But sometimes what will happen is, after you are doing a successful surgery by controlling bleeding, some patients will die of post-hepatectomy liver failure. To prevent that, you should start from pre-operative, intraoperative and post-operative. When pre-operative is, liver function test should be normal, no portal hypertension, and volumetry is very important. Once you have done it on table, or if the volume is less, so if the volume is less, there are future liver enhancement, increasing the size of future liver remnant by a portal vein embolization or two-stage hepatectomy, HALPs. Once you achieve adequate future liver remnant, either you do extended hepatectomy, all these things. Sometimes what will happen is, after doing extended hepatectomy, the remnant small liver will get a hyperperfusion. So intraoperative portal pressure manipulations in the form of sphenic artery ligation, hemiportocaval shunt, Sometimes what will happen is HCC occupies near the K1 hepatic veins, all three hepatic veins. Such cases you cannot do by a conventional method. You need to have a total vascular exclusion. When you make a total vascular exclusion, the thing is, liver will not tolerate not more than 1 hour clamping. In such situation, liver will suffer ischemia. And sometimes what will happen is, when you apply a total vascular exclusion, patient will develop splanchnic congestion, bowel edema, sometimes kidney will occur, sometimes hemodynamic instability will occur. So what we do, one more step extra is in situ hypothermia. We use the transplant principles, use the liver preservative solution into the liver, and while you are applying a total vascular exclusion, and venous decompression you done by mesenteric as well as lower limb venous bypass. So this is the background. I will start my case. So this is a 72 years male, elderly male. He's a known case of HCV positive. He's a farmer by occupation. He's presented with a pain abdomen and weight loss for 3 to 4 months. No addictions, but significant comorbidity. This is very important for a liver surgeon. Any patient diabetes more than 10 years will always carry some amount of fatty liver or NASH features. He is having a 10 years duration hypertension, history of pulmonary TB. And another important thing is, we always need, whenever you are planning extended hepatectomy, always look at the height, weight, very important, because to calculate future liver remnant volume, as well as BMI high fellow NASH will be there. Oh, it's not moving. Yeah. So he was performance status, even though he's 72 years, he's a good, well-preserved fellow. So there is except hepatomegaly, no other features. He came with the already reports because he's diagnosed outside. AFP was 2.69, CA99 was normal, and LFT is within the normal limit. HCV positive, we went on doing a viral load, HCV RNA, which is undetectable. Next level, we have to always look for a liver elastography, future liver remnant, which is within the normal limits. Then we look for portal hypertension, upper GI endoscopy, no evidence of portal hypertension. With this background, this came with this films. If you see this, CECT abdomen was done outside one district level. They diagnosed like a malignant SOL and went to one oncology unit. They did a true cut biopsy. With that he came, that suggests to have hepatocellular carcinoma. But for a liver surgeon, this will not be adequate because it's not showing what is the status of middle hepatic vein, what is the status of portal vein, what is the status of liver remnant, whether it is fibrosed or not, what is the status of future liver remnant. It's so, as a surgeon, we need a lot of more information apart from this. So this is playing. No, it's not playing. Yeah, you take over and plain pages. So these are not good.
Single face, sir?
No, all are there. This is the plain face. Yeah, you can see that. So this was not done in Osmania, it is done outside.
All right, sir. So the
Let's start with it. So not proper timing actually. Just enhancing or not.
Yes, sir. So in the background of hepatitis C infection, HCV, one thing we can observe here is it is not an overtly cirrhotic liver. There is possibly background some inflammation, but the elasto shows that the left lobe doesn't have significant increased stiffness. 6.3 kilopascals is like borderline, still considered within normal limits. And the right lobe shows a fairly circumscribed lesion, which is showing arterial pace hyperenhancement. We can consider this is the late arterial phase further. We're beginning to see maybe some areas of washout. We'll have to check the next phase.
So we did it.
MS.
So what we have done is, because as a surgeon, we need so many other factors also, because future liver remnant, quality of the remnant, and MHV status, and right portal vein status, any tumor thrombus is there like that. So we did it a triphasic CT with, triphasic MRI with a liver elastography. The reason is patient is having a creatinine of 1.9, and so.
This washout is very serious.
Yeah. So you can see that. Yeah. So this MRI.
So that's florid arterial phase hyperenhancement that we saw here. Yeah, in the portal phase, we're beginning to appreciate areas of washout where some parts are less enhancing compared to the liver parenchyma. That's a very nicely defined pseudocapsule in the delayed phase, which forms another major criteria for LIREDS. But even if we don't use LIREDS for HCC, this is a very classical sign, seeing a delayed pseudocapsule.
If you look at also right portal vein, just after division, tumor is starting. That is very important, because you can't do portal vein embolization in such cases.
Yes, sir. Trying to freeze that. So one is here, the middle hepatic vein is involved here. It's very close. It's probably going a little beyond also into segment 4. This area. Beyond the MHV into segment 4. And that's a compressed right portal vein.
Thank you. So this is coronal plane. We want to know how much cava side. It's not.
Come out of the laser mode. I think you can just say use slideshow.
Yeah. This is a coronal section to know, because it is going into the more towards the diaphragm side. So with this, they given a radiologist given like this. So volume is important in this case. If you see that already tumor is averting at the MHV. So you think without MHV volume, it is coming around 22%. And only segment 2, 3, it is coming 11%. So what is the best treatment in this scenario? Is it resection, transplant, tear, or immunotherapy? Our patient silent features is elderly male, 72 years, but good performance status. Is HCV positive, but viral load is undetectable. But diabetes mellitus, more than 10 years. AFP, biologically not much elevated, that is a good feature. Liver elastography within the normal limits. No portal hypertension and endoscopy. And single lesion, more than 14 centimeter, MHV averting and reaching up to the right portal vein. FLR is like this. So this is fitting into like BCLC revised criteria as well as Japanese criteria for ideal surgery, because creatinine is very high, so we cannot go for a well-preserved patients. We can't go by a palliative procedures. Yes, transplant, we thought one option, but he's an elderly man. At present, Jivandan will not give any organ for above 65 years. That is the limitation. And one interesting thing is village. He came from village in Srikakulam. Almost 40% are HCV positive. His 3 children, wife, everybody is HCV positive. So there is no fit living donor also in this family. So then, as you know, because future liver remnant is very less, 11% if you take 2, 3, if you take without MHV left lobe, it is 22. As you know, CLD background, you need to have at least 40% liver. So normally done procedure, easy method is portal vein embolization. There is a portal vein embolization limitation is when a large tumor reaching up to the confluence, you cannot occlude because intervention radiologist clearly says the embolic material reflects back into the future liver remnant and patient may land in a problems. So another important thing, portal vein embolization, failures occur. What condition? All 3 are there. Elderly people will not go much hypertrophy. Diabetic fellow will not go. Chronic liver disease background like hepatitis C, NASH, all these fellows, future liver remnant hypertrophy may not be that much compared to others. So all risk factors against of portal vein embolization. So whatever left is ALPS. So ALPS is a 2-stage hepatectomy. 1 stage we do tumor site portal vein ligation and liver partition, which increases rapid hypertrophy. But original ALPS criticized lot of mortality and morbidity. Morbidity went up to 40%. So there are ALPS consensus, ALPS net. So there are ALPS benchmarking. So many things. How to decrease the complication rate. Always remember that stage 1 ALPS is not a cancer surgery. It is a surgery for a future liver remnant, enlargement. So what we have done in our case is, so yeah. So we did a stage 1 ALPS laparoscopically. So it's tumor occupying almost right lobe and segment 4. You can see that leftover remnant liver also showing features of chronic liver disease. And we first ligated the, divided the right portal vein with the staplers. So always remember, don't injure the right hepatic artery. During the first stage, never mobilize the native tumor side liver, so that will induce us more complication rate. Do minimum of porta dissection. That is the most important. Otherwise, during second stage, hell of occurs because dense adhesion will occur around the porta. You may injure so many other structures, colon, duodenum, all these things. We use the Pringles manual preparation with the Foley's catheter like Kalera has shown. So we are also regularly does that method only. I generally use 14 number Foley's catheter for a Pringles, intermittent Pringles. Because if you use like a umbilical tape, sometimes elderly people know hepatic artery intima will get a break and dissection of the arteries will occur. So better, this type will be better. So I apply 10 minutes clamp, 5 minutes declamping. I went on dividing a parenchymal transection along the right of falciform ligament. So once you apply a Pringle, usually that will be avascular. That is a segment 4B pedicle. So most important thing youngsters should remember that when you are doing a laparoscopic major hepatectomy, the three important pressures compartment is important. One is pneumoperitoneum, that is intra-abdominal pressure. Another is intrathoracic pressure. Another is central venous pressure. So apart from regular contraindication, patient with having a chronic obstructive airway disease, never select such cases for a laparoscopic liver resection. Reason is intrathoracic pressure always will be high, and to maintain saturation also, anesthetist has to keep a high PEEP. If you keep a high PEEP, there is always bleed intra. So that is difficult to control. Another thing is, when patient is bleeding, you ask your floor fellow to increase intra-abdominal pressure, pneumoperitoneum. It can stop bleeding. But remember, whenever there is a small rent in a major hepatic vein, it will suck air, air embolism can occur. So you need to have a constant capnography when you are doing a major hepatic resection by laparoscopic. Apart from anesthetist keeping a low CVP. These are the three important things we should remember when you are doing a laparoscopic. That's it. 1 minute, it's over. So, thing is, whether completion parenchymal transection versus partial parenchymal transection, there are so many level of evidence were there. Partial parenchymal, that is up to 50% is also equally gives good results because regeneration rate was equal, but complication rate is 0 when you done a total complete parenchymal transection versus partial parenchymal transection. So never try to do total parenchymal transection in a first stage. Your first stage is only like a portal vein embolization. You are doing a non-cancerous surgery to increase the future liver remnant. You can see that there is MHV. This is totally draped to the tumor. So we had a bleed also. I clipped it. You can see this. So this is completed one. So after 10 days, you can see we always use a right hepatic artery sling because next time you go surgery, you will see that porta is always encased. That is why people criticize us that. So right portal vein we already divided, so left portal vein. You can see that tumor is getting feeding by only hepatic artery. But one important thing remember is in HCC when you do ALPS, rapid hypertrophy of the tumor will occur. We thought initially 12 to 13 centimeters. When we doing a surgery, it is more than 16 centimeters. You can see that future liver remnant. Initially it was 22, sorry. So this was actually Gayatri inspiration. So when we are in Yashoda, she has shown once this. So we told our radiologists to make it as a pictorial way of hypertrophy of the future liver remnant. So from 22%, it went on 34%. We thought that will be okay. Stage, if patient develops liver failure, never do second stage. That is important. That is why I made it this LFT serial chart. You see that never bilirubin cross 5%. So this is important. Yeah. So 1 minute. So this is the completion. So we did it open because it's a too big tumor. So I kept a. You can see that there is a lot of bulkiness increase, definitely. But still chronic liver disease changes were there. Always there is a dense adhesion around the porta will be there. So just a simple right hepatic artery ligation will make a porta completion because already portal vein is you are divided. So no need to worry. Because tumor is too big, if you do conventional right lobe mobilization, dividing a falciform ligament, you may increase dissemination of cancer. So we went on anterior approach with the liver hanging maneuver. So you can see that we have removed laterally. It's a big increased size. That is another important thing you should remember. So this is a second stage, and liver function is well preserved. And you can see that he's an elderly man, but physiologically is well fit. The first stage, our ports 10 mm like this. And 3 months follow-up, significant hypertrophy segment 2-3 and caudate lobe. So HPE, well-differentiated HCC with no lymph nodes, but microvascular invasion. Just 2 slides here. So classical ALPS versus partial ALPS and laparoscopic ALPS, tourniquet ALPS, there are variants were there. So there I told how much parenchymal transection, whether complete or partial. They says that both are equal hypertrophy, but complication rate in a partial is less compared to the regular full completion. This is very important. So sometimes your purpose is to separate from the tumor site to remnant liver vascularity. Why a transection? You can use a microwave ablation, you can apply a tourniquet also. So this is also described way. So people are started even extension of ALPS for a liver transplantation also. When the tumors are bilobar, so left lateral segment remove, only left lateral segment from split liver transplant, and right portal vein ligation. Once after left lobe is hypertrophied, this transplanted liver hypertrophied, this remaining right lobe of the with the metastasis can be removed. So this is called rapid. This is last year we have presented this. This is the way of doing. So ALPS can be extended for even bilateral liver metastasis also. So the only message is how to decrease the morbidity mortalities. They always say that FLR cleanup, if there is a colorectal metastasis, remove it. Partial parenchymal transection, never mobilize the liver, dissect minimum of portal pedicle. So first stage should be, only goal is liver function increasing. Second stage is aggressive surgical procedure for removing of it. So this, I think time is not, this video I will play it here. 2 minutes. Yeah, this is a HCC in a young girl or boy, 12 years, involving all 3 veins. You can see that he is having an acute Budd-Chiari syndrome. So he received 12 cycles of adriamycin-based chemotherapy, thinking that hepatoblastoma. So we started that veno-venous bypass, inferior mesenteric vein cannulation for portal vein, portal circulation, mesenteric circulation, decompression. You can see that entire liver is congested. So it's not that easy to do a transection where all 3 hepatic veins are involved by tumor, not responded by any of the conventional chemo. So we thought to give a immunotherapy, but patient presented with acute Budd-Chiari syndrome is dying, so forced to take up. But we apply liver transplant principles. What we have done is, so you can see that entire KY is encased. So I always open the intrapericardial portion of the IVC by transdiaphragmatic route, not by a sternotomy. And portal vein we have clamped it. So into the left portal vein, we are using a cannula to use a liver preservative solution. 1 minute. So this is the Pringles manual. So we are doing an anti-CTM procedure. We are dividing the IVC. You can see all 3 veins, all osteums were involved by the tumor. So because it's a total vascular exclusion, and we are going to do more than 1 hour, so we continuously segment 2-3 perfused with the UW solution in a hypothermic way.
Allowing the specimen to be extracted.
So KY is replaced with PTFE graft. And left lateral segment was re-implanted like any pediatric Budd-Chiari syndrome we do, left lateral segment re-implantation. This is recalled as a transplant oncology, where using a liver transplant principles, previously thought unresectable, making into resectable, and avoiding a liver ischemia by making a in situ hypothermia with a liver preservative solution. Thank you.
Thank you, sir. Very interesting cases. We thoroughly enjoyed your presentation. I now welcome Dr. Sachin Daga, sir, from Liver Transplant Department, KIMS Hospitals, to share his insights. Yes. Over to you, sir.
Good afternoon. I know everyone is full stomach and post-lunch session. At the outset, I would like to thank Team Vimalakar and all who have given us opportunity to present my work about liver transplant, and also to my teacher, Sir Dr. Shastri Sir, Dr. Birappa Sir, and Pratap Reddy Sir sitting over here, because of whom I am able to do whatever work I am doing today. So I'll be a little fast. I'm sorry for that. I'm just giving a brief introduction about the HCC in cirrhotic patients. Etiology most common is hepatitis B related, and followed by hepatitis C. And more interesting is even NAFLD is associated with HCC. What are the selection criteria for liver transplant? The most standard and widely acceptable criteria is Milan's criteria, which everyone knows. And nowadays we are stretching our limit by selecting the patients beyond Milan criteria, which again depends on how we are able to treat the disease and know the biology of the disease. Like either we are doing loco-regional control therapies, or we are giving immunotherapies, and then we are doing liver transplant to them. And it has made a huge difference in survival of these patients. As a student, when I started, it was like HCC, more than one lesion or multiple lesion, and it is inoperable, and then we just leave them. But now with increasing multimodality treatment, we are able to make feasible transplant even in complex multiple liver lesions or lesions with vascular invasion. So we can see there are a number of criteria here, which include tumor burden, biological marker, and other additional criteria. And depending on who has used what, they are various. And as we see, we try to stretch our limits. The survival decreases. The more and more complex things. Here they have selected very small lesions and did transplant for this. Whereas as size increases, we can see the survival decreases. So we need to be very selective while choosing the case for liver transplant with HCC. So what should we do when patients are beyond Milan's? Because most of the patients which present to all of us are either advanced with either vascular invasion, or they are with multiple liver lesions, or even if lesion is small, it will be sitting on the hepatic veins, or it will be sitting on a portal vein with alpha fetoprotein level is very high. In these cases, it is a good idea to downstage them depending on whether their size or multiple lesions or whether they are invading. So we prefer to do either TACE or TARE followed by SBRT. And suppose if these are not feasible, then usually we go ahead with immunotherapy. Also, it is important to keep in mind whenever we select these patients, their other fitness, whether how is their cardiopulmonary status, how is their nutritional status, and we also take into consideration whether tumor is sitting near the hepatic veins or tumor is sitting near the portal vein, because that will decide us to plan the transplant. Preoperative planning includes imaging and bridging therapy, which I have already discussed, and multidisciplinary evaluation including with hepatologist, oncologist, and intervention radiologist and surgeon. So I'll just present a brief bits about the procedure. The surgical technique overall, there are two types of transplant which we do. One is either deceased donor or a living donor transplant. And approach will depend on either it will be an open approach, minimal invasive approach, which include laparoscopic and robotic. Most of the time, laparoscopic and robotic is limited to donor, yet it has to be applied for recipient surgery. So steps of recipient hepatectomies, it includes mobilization of liver, dissection of IVC and hepatic veins, control of hilum and division. And during these three steps, the important things which we should keep in mind about HCC, particularly HCC, is whether there are any adhesions because of post-procedure, like if there is any taste done or tear done and there has been a neovascularization with blood supply coming from the adjacent thing, we need to be keep in mind. If there is adhesion between the diaphragm and the tumor, that also we need to keep in mind. So nowadays we are performing since last 1.5 years all the liver transplant with midline incision, and this is the case where it was a small HCC of around 3 centimeter. First we do left lobe mobilization. We divide the left triangular ligament so that it gives us a space to push the left lobe on the spleen, and then we can retract the right side of the liver for the division of the right triangular ligament. We have kept one mob behind it, and then we are trying to divide it. This is division of falciform ligament, trying to reach up to the IVC, suprahepatic IVC, and then connect the left triangular ligament division and this area. This is division of the lesser omentum, wherein we divide the lesser omentum, try and palpate whether there is any aberrant artery coming through this. If there is any aberrant artery, then we double ligate it, and if it is not there, we try to divide it with ligation. So we can see, because it was a post procedure, there was adhesion between the diaphragm and the, so this is the adhesion with the diaphragm. We have divided it, and once the division is over, we again try to palpate. If we see any firmness, we try to take out the disc of the diaphragm along with it and see whether there is any invasion in it, which can be helpful for further management. With the help of Roberts, we have captured of the diaphragm and try to retract the right lobe of liver, and then in between the diaphragm and the liver, try to do the opening, try to divide the right triangular ligament. Classically, this is called as open book technique, wherein we try to open the, we try to separate the liver from the diaphragm superiorly and inferiorly from the adrenal area. This step, if a large tumor is there, we may not be able to do this with midline incision, wherein we have to give a generous incision so that we need not put a lot of pressure on the liver during retraction, as it can increase the chances of dissemination. Here we have retracted the right lobe above, and this we are trying to divide the peritoneal attachment, which is from the inferior side towards the, in the region of adrenal. This is near the IVC and adrenal area. A lot of people use here monopolar forceps. I prefer to use the just straight cautery rather than forceps. And other preference of mine is to use the bipolar forceps. Usually veins are encountered here during the dissection, which are supplying to the caudate lobe. This is where we are exposing the IVC. It is my routine practice to do the portocaval shunt in almost all cases. So I usually dissect IVC a little bit more below. In this case, we have not done the portocaval shunt, but usually I do almost 99% of the time I do portocaval shunt. This is the division of the adrenal area. We are trying to separate the attachment between the adrenal area and the liver. This is the large vein which is draining from the caudate lobe to the IVC. We ligate on the liver side and then put a vascular clamp on the other side and try to suture it. Most of the people, sometimes they may prefer to use clip and ligature, But if we are doing side-to-side anastomosis during implantation, these clips may hinder, so we prefer to double ligate it with suture. This is the dissection of hilum. Here I am trying to define the right hepatic artery. Usually, in most of the cases, this is for just demonstration purpose, I have done this right hepatic artery, left hepatic artery dissection first. I prefer to divide the peritoneal covering laterally between CBD and portal vein, wherein first try to loop the portal vein, because it is my routine practice to do portocaval shunt, and then followed by right hepatic artery and left hepatic artery division. And it helps me in minimizing the blood loss during the surgery. Implantation, routinely we are following piggybacks technique with doing hepatic vein to the IVC, middle hepatic vein and extension to the right with IVC, portal vein to portal vein, hepatic artery to hepatic artery, and bile duct to bile duct. Of late, we have done almost, in last 6 months, 10 retransplants. So we have realized that during transplant, we need to be careful not to dissect too much, because we don't know when someone else will need a retransplant. And during retransplant, the life will be hell. So as minimum dissection possible during the surgery will help in future. This is the this was the case of HCC, which was sitting right onto the in between the hepatic veins, where we resected the IVC along with the liver and then did a conventional implantation. This is the top end of IVC we are anastomosing with the recipient IVC. Regarding living donor liver transplant, in this the right lobe is preferred from the adult recipient and for left lobe for the pediatric. In pediatric cases with hepatoblastoma, we have done liver transplant, but they are like very less. We do more of a liver resection for them. And ideal graft size acceptable is graft recipient weight ratio more than 0.8. And vascular reconstruction of hepatic vein tributaries and portal vein variations may require. This is the donor liver, where this is the implantation for the hepatic vein. This is the neoadjuvant graft prepared for the arteries. Sorry for this poor quality. Here this is the implantation of the segment 8 and segment 5 vein. This is after implantation. This is portal vein anastomosis. We do continuous with 6-0 suture. This is the hepatic artery anastomosis. We do interrupted using 8-0. Nowadays we have started doing it, this also continuous. So in living donor also we do continuous hepatic artery anastomosis, portal vein continuous, and bile duct also continuous anastomosis. So intraoperative consideration, particularly during transplant for HCC, is we should avoid too much of handling of liver so that dissemination of the liver tumor cells occurs through the hepatic vein, and perfusion, cold ischemia time should be minimized for the better outcome. Survival rate, 5-year survival of more than 70% if we follow the Milan's criteria, and even with now new advances of SBRT with tear and TACE, even if we select the advanced cases with proper selection, giving them time to see the response, decrease in their alpha-fetoprotein level, and no evidence of any new lesion, in those cases also we can increase the survival. And definitely if we can get some biological markers and post-immunotherapy better outcome, we will be able to increase more survival in these patients with HCC. I would like to conclude, liver transplant remains a main cornerstone in curative treatment of HCC. Surgical precision, patient selection, and multidisciplinary care are the key. Ongoing innovations in technique, I hope that in few years we will be able to do all these things robotically, including implantation. And with expanding criteria for selection of HCC patient and response to the treatment like SBRT and immunotherapy, we will be able to transplant to more and more patients with HCC. Thank you.
Thank you, sir. Thank you for the brilliant presentation. Now I request Dr. Narendra Kumar Thota, sir, from Medical Oncology KIMS Hospitals, to share few thoughts on newer chemotherapy agents in HCC and current standard of care. After this, our AIMS team is waiting, sir. Please try to confine to time. Yes.
Okay, good afternoon. At the outset, I would like to thank Vimalakar team for giving the opportunity. So whenever we see HCC, actually the surgeons, they enjoy a lot doing the handling of the management of HCC, but as a physicians, since the advent of the immunotherapy, we started enjoying, but before that it was hardly anything to do from our side. So I'll be discussing especially the immunotherapy in the advanced stage. Okay, this actually treatment strategy has already been shown, and my area will be here in the advanced phase, so I'll be discussing about this and to certain extent few slides about the intermediate stage. So these are the mainly determinants of the process of clinical decision. You stage it, and based on your disease control or tubular ablation, you'll be looking at this depending on the stage of the disease. And what are the other determinants? As all the doctors have been discussing, portal hypertension, liver function, PAS, comorbidity. These are all the very important variables which helps in treatment decision making. So these are the recent phase 3 trials in advanced HCC actually. You can see here in intermediate and in advanced phase. These are all the trials which have helped in improving the treatment care. In intermediate phase, these are the trials. This is actually a failure trial which was negative trial. Subsequently, these are all the positive trials which I will show in the subsequent slides. In advanced phase, these are the initial SHARP trial, which is the first trial which has shown 3 months survival benefit. Subsequently, these are all the trials which have helped in improving the OS and PFs. So same thing, in view of the short of time, I'll just skip all the intermediate these things. Actually, phase 2, which has given the significant PFS advantage. Actually, this was a failure trial. Subsequently, these are all the positive trials. I'll just skip through. These are all actually positive trials which has given very significant PFS benefits. And Emerald also, which has given significant PFS benefit. So these are all the trials actually in intermediate stage. So I'll be discussing especially of the advanced stage in view of the lack of time. So advanced phase, this was the first SHARP trial which has given only PFS of 3 months advantage. But it was very challenging to treat a HCC patient with this drug. So we hardly used to start the 50% of the dose, and we used to escalate the dose. Because of the toxicity, sometimes we used to stop the treatment altogether, and we used to observe the patients. Those patients used to do much better than the patients who are on sorafenib actually. So this is a lenvatinib, which is a non-inferiority trial. This drug has come after 10 years of sorafenib. You can see the advances. It is very late and slow in the HCC, especially in the medical oncology side. After 10 years, we got one drug which is just a non-inferiority trial, which has shown the equivalent of the results. So lenvatinib has been used since 2018. So this is a trial which is actually a landmark trial which has helped in improving the patient's outcome. EMBRAVE trial, EMBRAVE 150, this is actually study design. Atizo, that is a immunotherapy drug, and bevacizumab versus sorafenib, which was the standard which is shown in the SHARP trial. So this treatment was continued until unacceptable toxicity or until the loss of clinical benefit. And you can see the advantage of using this drug. At the 6 months, you can see the difference. 85% of the patients were doing well. The OS is 85%. Subsequently, as the time passes, at the 1.5 year also, it has shown 52% versus 42. So it has shown very clear-cut benefit that these drugs were working well and doing much better than the initial sorafenib or lenvatinib. And this updated PFS also shown that the benefit was continuous and it was persistent beyond even 1.5 year also. So this trial is landmark in treatment change. Actually, since last 4 or 5 years, it has made our treatment actually very smooth, and even though it is very costly, but it is giving a good results. You can see the duration of response also persisting beyond certain levels. This is again a Himalaya trial, which is actually 2 types of immunotherapy drugs, which is PD-L1 versus CTLA inhibitor. Both were combinedly used to get the advantage of each individual mechanism of action. It has also shown very good results. I'll show the curves. These are the OS and PFS, which has gone a significant benefit. So that's how it was FDA approved and has come into the first line of management of HCC treatments. Similarly, OS, which has shown the advantage. The 3 years OS also has shown the advantage. It is shows to continues to have the advantage of the OS benefits. This is very interesting actually. I'll just in few seconds I'll finish off. This is a Chinese study which is very interesting actually. They have used the TKA versus with the PDL1 inhibitor and versus sorafenib, which is a standard which is always been used in all the trials. But this study actually shown very high PS and OS advantage than all the studies which has been present all this year. You can see the last slide, the purple color. Here the OS is almost 22.1 months compared to all the treatments which I have shown till now. It has the highest OS benefit among all the studies, but it is not yet available in India, but probably they will be launching shortly. So if it is launched, this would be preferable treatment of choice for all the physicians from our side. So these are all the effectivity, the tumor shrinkage, all those things, which is significantly better than all the drugs. Side effects profile also, which is superior to all the drugs which have been we are using in our practice. So this is the first report, significant PFS and OS benefits in combination to all other studies, and this is the, to our knowledge, this is the longest or highest survival of 22.1 months, which has shown in HCC till now. So a few slides, just 3 slides, because the today's topic is basis on the background of the cirrhosis. So HCC management doesn't change much, but in cirrhosis, when we are dealing these patients, we'll be looking at these factors especially. Bleeding is important for us because when we are using a bevacizumab, we are concerned with the bleeding. So the presence of ALB score or CPS score, all these things are associated with the high risk of bleeding. So we'll be always worried about the bleeding, but these are the criteria which is used for the assessment of the bleeding. But when we are dealing with the HCC in the background of cirrhosis, we'll be using the liver stiffness and the screening esophageal varices, which helps us to decide in the management of these patients. So the IMBRAVE is the only study which has included all the patients and which has shown that they don't have any increased risk of bleeding if their basics at the start of the treatment, if the basic endoscopy shows that there is no much varicose bleeding or there is no much higher risk features of bleeding. These patients can be comfortably, safely treated with the bevacizumab and immunotherapy, which has got lesser complications. So these are the guidelines. You can go back and read. I'll just skip all these things because in view of time, I'll be just skipping all these things. So at the end, the most important things to remember is IMBRAVE study and CARES study. These are the 2 important studies which has given the highest OS and PFS benefits. Already IMBRAVE are being used in the practice. Probably in short time, we'll be getting the CARES, drugs, the study results, which maybe we'll be using shortly in future. So this is what about the management of HCC from medical oncology perspective. Thank you.
For the enlightenment. And so there's a small change, and it's so kind of Dr. Faisal. So due to shortage of time, his session on spectrum of IR in HCC will be combined with his same session in colorectal liver mets in the last session. So now, sir, please join for a group photo. All the speakers from the previous session, please join for a group photo. So our next session will be case 6 on benign liver SOL. So this session will be heading up by AIMS team from New Delhi. They'll be joining us online. Thank you, sir. So I now invite Dr. Sujay Paul Professor HOD, Surgical Gastroenterology and Liver Transplant from AIMS New Delhi, and Dr. Rajendra Behra from AIMS New Delhi, Assistant Professor in the Department of Radiology for the image discussion. Dr. Sujay Paul, sir, the mic is yours. The stage is yours, sir.
So can you hear me? So if it is clear, I would like to share the screen, but I thank Dr. Vimalakar and his team for giving us this opportunity to present this rather simple case after the complicated liver resections and the transplant that you've seen. But this can be a difficult diagnostic conundrum and lead to difficult clinical decisions to be made before we actually operate. So can I share the screen?
Yes, sir. Your screen.
Yeah.
We are still not able to see your screen, sir.
Are you able to see?
Not yet, sir. Yes, sir.
Yeah. So is that clear?
Just a second, sir. We are able to see now. We'll just minimize.
Are you able to see?
Yes, sir. Yes, sir. Segment 6 and.
Yeah. So this is about a patient, a male patient, 30-year-old, who presented to us with a history of 2 months, gradually progressive dull aching pain localizing to the right upper quadrant of the abdomen. It was non-radiating. There was no relation to meals. It was not relieved with other analgesics. There were no aggravating or relieving features. The patient denied any vomiting, nausea, fever, anorexia, or weight loss, and there were no history suggestive of jaundice, GI bleeding, or melena. So there was no significant limitation of the physical activity, and the patient appeared very fit otherwise. He was ECOG 0 status. Abdominal examination did not reveal any positive findings. So when he did the investigations, the blood investigations, again, there was nothing remarkable in it. The LFT was perfectly fine. There was no elevation of any of the enzymes, and the coagulation parameters were also normal. We also did the tumor markers, although sequentially they were just done after the ultrasound. The tumor markers are also within normal limit. So the patient came to us with a CT scan which was not properly phased and an ultrasound evaluation, which showed that he probably had a tumor in the right lobe of the liver involving the segments 7 and 8. It was heterogeneous in the acoustic enhancement, and this the details of the imaging will be discussed by Dr. Rajendra subsequently. But when you have such a situation in the OPD or whenever you are clinically evaluating such a patient, there's very little that you can pinpoint just on a clinical examination, except for the fact that the patient has not had any prior chronic liver disease, any prior evidence of, viral hepatitis, and whether the patient is having a rapid course or a slow course. That is the thing that you can ascertain from the clinical evaluation. So looking at this patient, he had a short history, but there was no systemic problem. There was no anorexia, there's no weight loss, there's no jaundice. So we would like to look at it properly and critically examine in a 30-year-old patient who doesn't have any liver disease after you develop such a lesion. So I would like to hand over for a short while to Dr. Rajendra Behra, who will discuss the imaging evaluation of this patient. Dr. Rajendra.
Thank you, sir. Thank you for the opportunity. Can I share my screen? Hello.
Hello.
You can share. I have
Please share. Are you able to see my screen?
Not yet.
Your screen is not yet visible, sir. Below share button, you will have to put share button below.
Okay.
Yes, sir. Now we are able
Yes,
to
we
see
can
the
see
screen.
Okay. So it's clinically pointed out that patient has right upper quadrant pain. So in this setting, as a radiologist, we need to investigate the
Can you
patient
center the
and
screen, please,
to
sir?
reach a common diagnosis. Hello, am I audible?
Yes, sir. Your screen is a lot
Okay.
zoomed, sir. Can you zoom in a bit? Oh, too enlarged. Yeah. Okay. No.
Too enlarged. Okay, so the patient has a clinical complaint of right upper quadrant pain. In this scenario, the right upper quadrant pain, common initial imaging modality is done is ultrasound. Ultrasound usually delineates the hepatobiliary system. So commonly the cholelithiasis, choledocholithiasis, or the presence of hepatic masses easily delineated by ultrasound. So in this patient, we have the patient undergone a ultrasound image. So ultrasound usually shows morphology of the liver parenchyma and presence or absence of the mass. So in this case, as we can see, the echo texture of the liver is completely normal, and we can see there is a heterogeneously hyperechoic mass in the right lobe of the liver, and predominantly it is solid. And further, as we see on the Doppler images, we can see some vascularity within the mass lesion, and in addition to that, there are multiple echogenic foci can be seen within the mass lesion. So these are significantly brighter echogenic foci within the mass lesion. So in this ultrasound, we can appreciate that the parenchymal echo texture is normal. There is a solid lesion in the right lobe of the liver, and there are certain bright echogenic focus within the mass lesion. So echogenic solid lesions in the non-cirrhotic liver. The common differential diagnosis in the benign category could be hemangioma, hepatocellular adenoma, or focal nodular hyperplasia. Among the malignant categories, it can be hepatocellular carcinoma, intrahepatic cholangiocarcinoma, or metastasis. So to further characterize the lesion, either we can go for a multiphase CT scan or multiphase MRI. So in this case, we gone for a multiphase CT scan. Multiphase CT scan is primarily based to exploit the dual blood supply of the liver parenchyma. Commonly, the hepatic artery supplies approximately 20 to 30% of the liver parenchyma, and portal venous supplies 70 to 80% of the liver blood supply. When a tumor develops in the liver parenchyma, commonly the HCC, it recruits the arterial supply and the portal vascular supply diminishes. So that hepatic arterial supply easily appreciated in the arterial phase. So that is the part, that is the basis on which the multiphase CT is based on. So in multiphase CT, we do 3 different phases: late arterial phase, venous phase, and delayed phase. In this patient, late arterial phase usually done approximately 25 to 30 seconds, and it usually tries to find out whether the lesion is enhancing or not, and if it is enhancing, then whether the enhancement pattern is Rehm kind or non-Rehm kind. So this is the arterial phase image of these patients. We can see as we scroll down, the lesion is located in the right lobe of the liver, predominantly in the segment 8 and some part extending to segment 7. As you can see, the lesion is arterial phase hyperenhancing. As we can see, it is brighter as compared to the background liver parenchyma. That means it is arterial hyperenhancement. And it shows solid kind of enhancement, that is non-rim kind of arterial phase hyperenhancement. So non-rim kind of arterial phase hyperenhancement usually seen in 3 different tumors out of those differential diagnoses which already seen. One is hepatocellular adenoma, second is FNH, and third one is the hepatocellular carcinoma. Rim kind of enhancement usually seen in intrahepatic cholangiocarcinoma or metastasis, or sometimes rim kind of nodular peripheral enhancement is seen in hemangioma. So this, from the arterial phase, we can have a differential of hepatocellular adenoma, FNH, or hepatocellular carcinoma. And venous phase usually taken in and around approximately 60 to 70 seconds. In venous phase, usually we see the washout character and internal characteristics of the tumor. So in the venous phase, we can see this is the tumor. We can see washout. There is tumor washout, which can be seen. There is lesser density of the tumor as compared to the background liver parenchyma, and as we can see, there are certain areas which are not enhancing. The central part of the tumor is not enhancing. They are tumor necrosis. And in the delayed phase, usually taken approximately 3 to 5 minutes, and it delineates the capsule. As we can see, this is the delayed phase. So we can see there is no presence of the capsule. So from the multi-phase CT scan, what we observed, there is non-rim kind of arterial phase hyperenhancement. We can see. So from non-rim kind of arterial phase enhancement, the differential will be FNH, hepatocellular adenoma HCC, and it shows washout. Washout is commonly seen in hepatocellular carcinoma, and one type of beta-catenin positive type of hepatocellular adenoma can also show washout. And as we can see, there are certain low density foci within the lesion. We can see these are actually macroscopic fat. Macroscopic fat usually seen in the setting of some steatohepatic type of hepatocellular carcinoma and some variety of hepatocellular adenomas. And these internal necrosis is usually seen in the setting of hepatocellular adenoma and some HCCs. And there are certain focus of calcification within the mass lesion. We can appreciate on the right side red arrow. Now the question is where the anatomic localization is, whether the tumor is resectable, and if there is extrahepatic disease present or absent. So this is the tumor in the right lobe of the liver, which usually seen in, we can see this is the right hepatic vein, this is the middle hepatic vein, this is the left hepatic vein. The tumor is situated predominantly between the right hepatic and middle hepatic vein, and part of the tumor extends into the segment 7. And it lies above the level of the right portal vein, and so this is predominantly located in the segment 8, extending some part into the segment 7. There is no evidence of tumor thrombus in the right hepatic vein or the right portal vein. There is no extrahepatic disease. So in summary, in a 35-year-old male, when there is non-rim kind of arterial enhancing solid lesion in the segment 8 with focal extension into the segment 7. So showing washout on the venous phase with the internal areas of necrosis and foci of macroscopic fat and calcifications without any tumor venous thrombosis or extrahepatic disease. So the common differences will come into is benign etiology like hepatocellular adenoma, commonly the beta-catenin type of hepatocellular adenoma. They show non-rim kind of arterial phase hyperenhancement. Sometimes they show washout. These internal necrosis, foci of calcification and fat can be seen. Similarly, the malignant differential diagnosis will be hepatocellular carcinoma. So to find out what is the tumor, we need to get it sampled. And we done a percutaneous liver biopsy. It found out to be beta-catenin activated hepatocellular adenoma. Over to Sujay sir.
Yes. If you can stop sharing, I'll start.
Okay. Yes, sir.
So, thank you, Dr. Rajender, for making it relatively clear. So the thing is, after the imaging analysis, it boiled down to two diagnoses. Either it's a hepatocellular adenoma or we are dealing with a malignancy. So since we're not very clear, this slide which I have shown, I don't want to go into details of this, but this summarizes the kind of enhancement patterns which are important to be evaluated while we are trying to make the distinction between a benign and a malignant. And within the benign, we are trying to distinguish between hemangioma, a fibronodular hyperplasia, or a hepatocellular adenoma, the three common benign diagnoses which presents as a SOL. So the FNAB was done. It reported it as a possible, actually the thing was that the first FNAC was done outside at a different hospital where they reported it as a highly dysplastic nodule. This was again reviewed at AIIMS, which they clarified that it's a beta-catenin activated hepatocellular adenoma, which made our decision making for surgery more clear. So otherwise we are almost tending to plan a right hepatectomy, and as you could see, the left lobe was not sufficiently enlarged or sufficiently good in volume. But of course, we did the volumetry. But our plan was, once we got the diagnosis of a hepatocellular adenoma, we thought of doing a segment 7-8 resection. So before we go on to that, I would like to take you through the portal venous CT again, because there's one technical thing which a surgeon would like while you're planning a, sorry. Here, I'd like you to watch the venous face properly.
Sir, can you make your screen a little smaller, sir? Part of it is getting cut.
Smaller?
Make it a little smaller. It is getting cut.
Are you able to see?
Go ahead.
Now?
Go ahead. Yeah. Go ahead, sir.
So I would like you to see the venous face clearly. Can you? Sorry. This is where you can see the accessory inferior hepatic vein on the right side. Apart from the original right hepatic vein that you already saw in the earlier cuts. Right. This is the right hepatic vein, and as you come down, you can see accessory right inferior hepatic vein here coming in. So that made a decision making sort of more simpler to go ahead with a plan to do a segment 7 and 8 resection, because that would mean that the remnant of segment 7 and 6 would have an independent drainage because of this. Even otherwise, it is possible in a situation where you have to take the decision to conservatively resect, to do a 7 and 8 bisegmentectomy, even if you don't have this. But this gives you a degree of comfort while you're trying to, do this operation. So, should I go full screen or is it all right?
This is okay, sir.
So this, I have skipped some of the initial steps. The incision we used was a Makuji incision. Here we are doing the hilar dissection first, and the right hepatic artery was looped. The cholecystectomy has already been done. This is the cystic duct stump which is being handled by a artery forceps and everted so that the undersurface of the CBD can be dissected. Cauterization is being done so that the suprarenal IVC and infrahepatic IVC can be identified and kept in readiness in case we have to resort to IVC clamping if required. So that's the IVC that you can see. Then, of course, we went on to do the looping of the main portal vein. This is the CBD and the cystic duct, which is being diverted. The main portal vein has been looped. So we are making preparation to loop the right portal vein. We tied the caudate branch, which often comes from the right portal vein, goes into the caudate process. Here you can see the right portal vein is being looped. This I did this in preparation for a possible need for a the right hemihepatic clamping at a later time during the parenchymal dissection phase. This was we use a size 14 Foley's to do the Pringles maneuver because this is a gentle technique and avoids injuring the vessel. Thereafter, we proceeded with the mobilization of the right lobe so that both the segment 7 and segment 8 are free of its right triangular attachments and can be, so we can proceed with the parenchymal dissection after that. You can see part of the tumor here on top is visible. This is where the tumor was located. It was actually permission consistency, and I was just marking all around the tumor, making sure that you get a thin sliver of hepatic parenchyma around the tumor without any breach of the tumor per se. So this I was marking with the cautery. After having marked it, we start the parenchymal transection. Of course, we told the anesthetist to keep the pressure down, and because of its location on the the right aspect of the middle hepatic vein, I did not want a messy field, so that I could identify the middle hepatic vein, which was stretched on the left border of the tumor. So that's why I applied the Pringles. Normally I use the intermittent Pringles technique, and this is basically proceeding with the parenchymal dissection on the left surface of the tumor. The small tributaries draining into the middle hepatic vein are being secured. As we proceed with the dissection, you can see now that the middle hepatic vein anterior surface is becoming clear, just near my suction probe. You can see that very clearly now. So we achieved hemostasis while we were doing the parenchymal transection using a bipolar cautery, which serves very well. And once this part of the dissection was over, we proceeded on the inferior aspect of the tumor, again circumferentially skirting the tumor boundary. You can see that there is no clear demarcated capsule, just the liver parenchyma that you are going through around the tumor. just announce this. Again, the same structures coming in from behind. Below were also ligated serially. And then till we get to the point that we get the segmentate pedicle. That will soon come into the picture. This is the segmentate pedicle, which was ligated and transfixed. This is on the segment 7 side of the tumor now that we are proceeding with the dissection. And you will soon see that the right hepatic vein will come in view. Before that, we encountered another portal pedicle, possibly to the part of the segment 7 that we are removing along with this tumor. After ligating this, some tributaries to the right hepatic vein individually getting ligated.
Sir, can we wrap up a little faster?
Now you can see that the tumor is on both sides of the right hepatic vein, which is draining into the IVC, suprahepatic IVC. This was skeletonized and dissected all around before stapler, a vascular stapler was used. Echelon 45 white cartridge was used to fire, and this completed the process of the tumor dissection. And this is the residual raw surface area, which was initially packed with a sponge. You can see the middle hepatic vein here. And we proceeded to do the hemostasis, followed by the biliary leak test. Normally prefer to use propofol solution to inject it from the cystic duct stump to see if there is any leak from the cavity side. And once we are satisfied with this, we completed the hemostasis, put a Surgicel and sometimes a snow, and transfix the cystic duct and close the patient. This was just argon for some superficial oozing from the raw surface area. Half hours. So the patient was very smooth, but the drain had bilious effluent after 48 hours, so waited for a week, remained around 200 ml per day, did a ERCP stenting, and then gradually decrease over the next 3 weeks. The drain was removed. Now, patient is 3 months post-op, doing well. Will be kept on surveillance 3 to 6 monthly for at least 2 years and yearly thereafter. Now, the thing is that this was a well circumscribed lesion on histopathology with a solid sheet-like architecture and well-differentiated hepatocytic cells. And the diagnosis again pathologically was a tie between a HCC and a hepatocellular adenoma. But there were other features, like there was the nuclear changes were not pleomorphic. There were some inflammatory areas. There were areas of fat within the tumor area, and the immunohistochemistry, which helped in diagnosing and confirming that we're dealing with a hepatocellular adenoma. Now, it's important to realize that there are 5 subtypes of hepatocellular adenoma. The HNF1 alpha variant, which is HCA-H, then the beta-catenin variant, which is HCA-B. Then you have the inflammatory variant or the telangiectatic variant, which is HCA-I. And then you have an unclassifiable HCA. And there is a recently described subvariant, which is called the hepatocellular adenoma sonic hedgehog variant. This last variant is more prone to rupture and hemorrhage. And the beta-catenin and the inflammatory variants are more prone to both rupture and also malignant transformation. Plus, what is important is that if you see this in a male, more often they are more aggressive and have a more higher potential of transforming into malignancy. So they should be offered surgery even if they are less than 5 centimeters in size. So these are the types of immunohistochemical markers which are required, like the amyloid A, which is an inflammatory marker, the glutamine synthetase, which is a marker for the diffuse thing which is picked up in hepatocellular adenoma, a beta-catenin marker, which is in this case, it is a mixed type of hepatocellular adenoma, where both the inflammatory component and the beta-catenin component are present. So this is a bit about the final histochemistry of the patient. You can see, I'm sorry, it's a slightly low power slide, but you can see sheets of hepatocytic cells which are normal. Then you have the certain positive markers like the beta-catenin, the glutathione synthase, and the scar with hemorrhage and steatosis, all of which combined together helped us in making the diagnosis of a mixed type beta-catenin positive hepatocellular adenoma. So this is what the current classification is of hepatocellular adenoma. We are dealing with a male patient with a hepatocellular adenoma. Commonly, the exon 3 variant of beta-catenin is the one which is involved in these kind of patients, which have cellular atypia. Sizes are often bigger than 5 centimeters, and they often are more aggressive than the other varieties of adenoma, and also higher level of premalignancy is noted in them. So I would conclude by saying that you need to diagnose SOLs of the liver by using proper multiphasic cross-sectional imaging, which may be either a CT to start with, and may be complemented with an MRI with a liver-specific dye, like the gadolinium bofta. Then you have biopsy is often indicated because sometimes it's difficult to differentiate between a well-differentiated HCC and a hepatocellular adenoma, and you need to characterize and prognosticate. And once you diagnose it's an adenoma, you can be conservative on the resection. But in males, you have to almost always offer a resection. In females less than 5 centimeters, you can play the waiting game, specifically if they are on estrogen contraceptive pills, because it has been shown that if you stop the pills, the size often diminishes. And in obese people with metabolic syndrome, again, in the ladies, you can actually play the waiting game. And it has been shown that if weight is controlled, metabolic syndrome has been also put under control, the adenoma can shrink in size. But in other instances, it's better to take them out, and especially in males, there is no chance for conservative management. So a parenchyma sparing is often preferred, and even a non-anatomic dissection can be done wherever possible. So I conclude my presentation here. I'll be happy to take questions from the audience if there are any.
Sujay sir,
Thank
thank you
you
so much. Hello. Sujay sir.
Yeah.
Thank you so much, sir. It was great talk. So I think nobody has questions. So we'll continue with the next benign biliary cystadenoma session, sir. Thank you so much, sir.
Okay. So can we log out?
Thank you, sir. Now I request Dr. Gayatri Senapati, Consultant Radiology from KIMS Sunshine Hospitals, to discuss triphasic CT versus MRI. And from Team Vimalakar, I call upon Dr. Gopal Nayak to discuss the case videos.
Hello, myself Dr. Gopal from Team Vimalakar. I will be presenting a benign liver as well. So this is a lady, 30-year lady presented with a dull aching pain in upper abdomen with history of OCPL intake. The liver function test and the serum alpha fetoprotein and CA99 were normal. So we have done a CT of this patient, and the CT will be discussed by the madam.
Right. So first set of all these are representative axial images. The first is the plain study. What you can see, the huge thing to the left of liver, all of that is an exophytic left lobe lesion, completely projecting out. So in the first image, that is a plain study, you can see there are multiple hyperdense areas of increased density, which means that there is hemorrhage in it. Now next is the contrast in the arterial phase. You can see there is peripheral solid component, which is arterial phase hyperenhancing. Now what we can see in the subsequent two phases is that in the portal and in the venous phase, the contrast is retained in that enhancing component. It is not washing out. So there's a large exophytic lesion with, previous. All right. So the same thing in the coronal projection. You can see all along the periphery there's a solid component which is arterial phase hyperenhancing. Thanks. And all the central hyperdense part, which is hemorrhage, is not enhancing. It is completely exophytic from the left lateral segment with some mass effect over the stomach. Next. Now another important finding here is the presence of small pockets of macroscopic fat. Look at this small pocket inside and a few more here. So this is an attenuation of minus 40 HU, minus 8 HU, which means that there are areas of macroscopic fat. Next. And one more thing in the arterial phase we found is there were very prominent arterial feeders to this mass. This is the left hepatic artery, which is so much hypertrophied and tortuous, giving such prominent arterial feeders to this entire tumor. Next. All right. So we have a young female. One very important point in the history is intake of oral contraceptive pills. There is a mass with hemorrhage with areas of macroscopic fat and prominent arterial feeders. So it narrows down the differential diagnosis because we are not seeing contrast washout. Atypical, one thing is when something doesn't show classical imaging features, we have to always suspect or keep in mind the possibility of a malignant neoplasm because we never know. When we're calling something benign as radiologists, we really have to be sure that it is benign. But when it is atypical, we have to also propose a possible differential of an atypical appearance of a malignancy. In this case, this is a vascular mass, enhancing, hyperenhancing, prominent arterial feeder. Now, macroscopic fat can be seen both in adenoma as well as in HCC. The other thing, which can be very vascular, have areas of hemorrhage, and have areas of macroscopic fat, is an angiomyolipoma. Though we more commonly see it in kidneys, it can also sometimes be seen in the liver. So these three were the differentials proposed, but given the fact that it's a young female with OCPLs intake, an adenoma with hemorrhage was thought of.
So keeping in the differentials, we proceed with the surgery for this patient, and during the surgery it was found it was a large exophytic mass arising from the left lobe of the liver. So we can proceed with the just a resection of the tumor with the endo-GI tri-stapler, and it was a simple surgery. So next one is a and on histopathology, it was found to be a adenoma. So the next case is a 29-year lady presented with a dull aching pain in the right hypochondrium, which is associated with the vomiting. Similarly, liver findings, liver function test and the serum markers were normal. So the radiological features are like?
Right, so we have another young female. This is a mass in the left lobe of liver. Now what we see here is, it is large, unilocular, hypodense and cystic appearing. Now in the multiphasic contrast, we see that there is no enhancing solid component per se, but what is there is, it's predominantly cystic. There are a few very small and thin internal septations seen predominantly in this dependent region posteriorly. Next. Yes. So the multifanal reformatted, especially in the coronal, we can see that it is large, subtle obulated margin in the left lobe, and look at these thin septations within. So young female, these are the possible DDs. Yeah. Next. Large unilocular cystic lesion in the left lobe. It has thin internal septae. So the first thing would be a biliary cystic neoplasm, because we are not seeing very well-formed locules, but only a few internal septations. So biliary cystic neoplasm, earlier it used to be called biliary cyst adenoma. It's still a used terminology, but the more appropriate term now is a mucinous cystic neoplasm, a mucinous tumor, because it's almost, most of them have ovarian stroma, they're mucinous, and almost seen only in females. There are very, very few case reports of isolated cases in males. So biliary cystic neoplasm, other differentials being complicated hepatic cyst, a hepatic cyst into which probably there's been some little bit of hemorrhage, or a hydatid.
So keeping in the diagnosis of biliary cyst adenoma, it is accounted for less than 5% of the cystic liver lesion, predominantly affect the women, and commonly there is a no communication with the bile duct per se. And the most commonly located in the intrahepatic bile duct, especially on the left side of the left lobe of the liver. So for this case, the indications for surgery per se, all biliary cyst adenoma should be surgically removed, as there is a high chances of conversion into the malignancy. So there is about 20 to 30% chances of conversion to biliary cyst adenocarcinoma. So other indications are like increase in cyst size, diagnostic uncertainty, suspicious features of malignancy like septations, mural nodules and papillary projections. Sometimes the large lesion more than 5 to 6 centimeter can be resected, and the biliary cyst adenoma presented with the complications like infections, rupture and hemorrhage. In this case, we are proceed with the laparoscopically, and with the help of the ICG, we can demarcate the, there is a no intake of the ICG, so it is not communicated with the bile duct. So the adhesiolysis done, and we aspirated the controlled mannerly aspirated the cyst, and the secretions from the cyst was found to be a mucinous. We have done a cholecystectomy for this patient simultaneously, and after that the dissection of the hepatoduodenal ligament is done to gain the inflow control. So the inflow control is taken. This is the hepatoduodenal ligament. With the help of a ICG, we are able to make the margins of the cyst, and we done a scoring with taking care of some margins with the normal liver. So the parenchymal transaction is done initially with the harmonic, and followed by with the CUSA. So during this, proper hemostasis is achieved with the ligation of the segment 4 pedicle and the hilar dissection to separate the cyst from the cystic plate, and segment 5 portal vein is also ligated. So hilar dissection is done. And proper hemostasis is achieved with the suturing of the bile segment 4 duct also. So the histopathology suggests of thick fibrocollagenous cyst wall lined by the biliary type of ulcerated columnar epithelium with underlying ovarian type spindle cell stroma. So this is the histopathology slide which suggests of ovarian stroma with biliary type of columnar epithelium. So this is the, yes, thank you.
So a few slides on how do we differentiate a FNH from an adenoma on biliary cystic neoplasm imaging, and where CT helps and where MR helps in liver lesions. Now we've spoken about arterial phase hyperenhancing liver lesions in the first talk. So of those, especially in young patients, there are two important lesions to keep in mind: a focal nodular hyperplasia and a hepatocellular adenoma. Now there's some important points to differentiate these two. So this is another young female. There is a T2 hyperintense lesion in the non-cirrhotic liver background in segment 8 that you can see here, and there's also T2 hyperintense central scar. This scar is hypointense on T1. Now this is the triphasic study. Okay, arterial phase, there is hyperenhancement. Extracellular phase, that is the portovenous phase, is there washout? No, there is no washout. It is still retaining contrast. And then in the further delayed phase, you see that there is a central enhancement in the scar. So all of these together help make the diagnosis of FNH. But there is one other important sequence which helps clinch the diagnosis. Now there is something called hepatobiliary contrast agents. That is, it's called multi-hands in the market in India. So what this does is, it is a hepatocyte specific contrast. It is taken up by all the hepatocytes. So the other contrast which we see, the brain will enhance, the liver will enhance, the kidney will enhance, everything. But hepatobiliary phase specific contrast agents are only taken up by the hepatocytes, and they are excreted into the biliary system. So this is the hepatobiliary phase. We know it is this phase because you see contrast in the CBD. Look at this. Now, the whole liver background is a little bright, but you see that this lesion is brighter than that. So any lesion which retains hepatobiliary contrast more than surrounding liver parenchyma is a focal nodular hyperplasia. Now, why do we need to know this? FNH is basically something like a hamartoma. It is just hyperplasia of hepatocytes. It will have hepatocytes and take up the contrast of hepatobiliary agents just like surrounding hepatocytes. But it doesn't have a communicating excreting system. The rest of the hepatocytes will excrete contrast, but this can't excrete because it doesn't have a excretory ductules and the portal venous connection. And therefore they retain contrast. Now what's the closest differential for this? Another young patient, a well-defined segment 4 lesion, arterial phase hyperenhancing. We see that in the subsequent phase, the veins are opacified, IVC is opacified. So this is a venous phase, but there is no washout. So arterial phase hyperenhancement, no washout in a young patient. But in the hepatobiliary phase, we find that this is not bright. It has not taken up the hepatobiliary contrast. So it is not as bright as the background liver parenchyma. So this is a adenoma. Now these two are important to differentiate because we've seen just in the previous talk that adenomas tend to have various immunohistochemistry types. You have the beta-catenin, you have the inflammatory, HNF-alpha mutation, etc., some of which have a propensity to develop into malignancy. But if you know that for sure this is an FNH, it can probably be left alone, but an adenoma needs to be on close interval follow-up or probably excised depending on what type of tumor it is. Now when the adenoma grows large, they are seldom homogeneous. You won't see homogeneous enhancement because they tend to have areas of hemorrhage, areas of necrosis, calcification, etc. And they also recruit more vessels. But when small, differentiating these two, hepatocellular contrast agents definitely helps. So FNH versus adenoma to differentiate, MR is definitely superior to CT. Now coming to other conditions like characterizing liver masses, liver tumors with signal intensity, because T1, T2, diffusion, presence of hemorrhage, internal architecture. For example, hydatid versus biliary cystic neoplasm. We just had Vijay Kumar sir talk to us in the morning about a case of a multiloculated cyst which was probably thought to be a hydatid, but then turned out to be a biliary cystic neoplasm. Now such architectural detailing can be done much better on MR than on CT. So their MR scores over CT. Where else? To pick up early HCC, so in case you're having a patient with chronic cirrhosis, we want to screen them serially. If there's a doubt if there is an early lesion, slight elevation in alpha-fetoprotein, MR is certainly superior to CT in picking up small lesions. Now look at this example. Not very different from the case we've just seen. A large lunilocular exophytic lesion, left lobe of liver, it is cystic. There are internal septae dividing into smaller locules. So this was again a biliary cystic neoplasm. What can this be mistaken for? It can be mistaken for a hydatid. So in such cases, this is another different example. MR can help. So mucinous contents in any tumor will be hyperintense on T1. Now once we see that, we know we are not dealing with a hydatid, but it is a mucinous cystic neoplasm. So one such example where MR scores over CT. Now I'm not going through the details of this, it's just to convince the audience that when in doubt and when MR and CT are both available, to detect early HCC, please always prefer MR over CT. And where does CT score over MR? Two things. One is vascular anatomy in relationships. CT scores over MR because it has much better spatial resolution. So Dr. Hariprasad from JUPMA showed us beautifully how in an HCC, a variant vascular anatomy and vascular involvement helps in surgical planning much better than an MR can do. Other is volumetry. Now volumetry can also be done both on CT and on MR, but it's a lot more accurate on CT because the spatial resolution is better. So Madhusudan sir just showed us in his case how volumetry was useful. So how is CT much better? It's because we can delineate. So this is just a reconstructed image in the venous phase, removing all the other vessels. So in a volumetry, you can superimpose all the vessels, the middle, the right and the left hepatic vein together with the draining veins. And the liver can be segmented and the right and left lobe volumes can be known. For example, in this case with a tumor in the right lobe, where a volumetry helped both determine the tumor volume and the residual liver volume, helping the patient undergo a right hepatectomy. So vascular anatomy, volumetry, CT better. In every other case, MR has an advantage. That's about it. Thank you.
Thank you for your insights. We move further to our case 7. That is session 7, and the tea will be served to the tables. So I request Dr. Mahesh Shetty, Senior Consultant, Surgical Gastroenterology, AIG Hospitals, Dr. Gayatri Senapati, Kim Sunshine Hospitals, Consultant Radiologist, and Dr. Raju from Team Vimalakar, Surgical Gastroenterologist, Consultant, and Dr. Monica Bopanna, Consultant Medical Oncologist from KIMS Hospitals, to please grace the dais. I request Dr. Mahesh Shetty sir to present his case and simultaneously Gayatri ma'am to discuss the radiology.
Good afternoon, everyone. At the outset, I would like to thank the organizers, Vimalakar, for this invitation. I was asked to present a case capsule. We went through HCC and benign cystic lesions, which are more common through the day. And benign SOL, solid SOLs are a little rare in the liver. This is one such case. This is a 54-year-old female patient who had presented to us around 3 years back with generalized weakness, loss of appetite, loss of weight, vague discomfort in the right upper abdomen. And that loss of weight was very vague, very unquantifiable. No other positive history, no other negative history. So physical examination, again, nothing significant here. Physical examination, again, abdomen, no positive findings. Respiratory, CVS, CNS, everything was fine. No comorbidities. Investigation, CBP, normal, no abnormalities. Peripheral smear was normal. LFT, absolutely normal. Renal functions were normal. We went, as normally it happens, these patients never come to you as a primary presentation. They have already seen some consultant outside. They have done some basic evaluation, and then that's when they present to us. So this patient actually had come with a ultrasound and a CT done outside. The ultrasound had shown well-defined SOL in the segment 6 of liver. They had done a CT. The CT films were not very good, so I have not included here. They also went ahead and did a biopsy, which I'll show a little later. When this patient presented to us, we did do some tumor markers. CA99, alpha-fetoprotein, CA, all were normal. PUVCA was normal. Upper GI endoscopy and colonoscopy were also normal. The liver biopsy with which the patient had presented to us had shown positive for malignancy. The features were of carcinoma, probably adeno-CA. IHC was requested. IHC was also done, and then the IHC was morphological features were suggestive of adeno-CA. Again, suspicious of cholangiocarcinoma. We were not very sure. So that's the time when we actually did a upper GI and colon, just to make sure that we are ruling out secondaries in the liver. And a PET scan was done. Just a minute. Okay, sorry. No. A non-contrast CT didn't show anything much except for a hypodense lesion in the segment 6 of liver. Here you can see in this area. Since the patient had a previous biopsy, there was a small air foci which was noticed. The arterial phase CT, this is a small hematoma with a little bit of inflammation in the area, and when we keep coming down, you can see that there is a well-defined SOL which is not taking contrast. And when we come to the portal phase, there's a hematoma there. Now we can see that there is some amount of contrast which is filling up in the tumor. And as we come to the delayed phase, we can see that the tumor, the contrast enhancement is a little more prominent in the delayed phase. There is a uptake of contrast, which is in a delayed phase. So when we look at the reporting, it is showing a heterogeneous arterial enhancement which is persistent, and it is enhancing in the venous and delayed phases. The impression again was suspicious of a intrahepatic cholangiocarcinoma. No other lesions were noted in PET-CT. So we went ahead with surgery because this was a well-defined lesion, no other lesions noted, suspecting that it could be a intrahepatic cholangiocarcinoma. We had given ICG for this patient 2 days prior to surgery, and on laparoscopy, no other lesions were noted. There are 5 centimeter SOL in the segment 6 of liver. Rest of the liver was normal, no other positive findings. And on IR, we found that there was a rim type of fluorescent signal around the tumor. This is a short video of the surgery. You can see the SOL, and that's the tumor, and this is the rim enhancement around the liver. This typically happens in adenocarcinoma secondaries of liver. We all know that if it is a HCC, the tumor enhances on ICG. So we went ahead with laparoscopic resection. That's the area where the FNAC was done, a small adhesion there, which was also included in the surgery, in the resection margin. So a mark is done around on the liver, way beyond the fluorescence, just to make sure we give a good margin on the tumor. The adhesions were released, and these are stay sutures taken to help us retract the tumor better from the liver. I'll just rush a little through, short of time. We have used a combination of cautery, harmonic scalpel, and CUSA in resecting dividing the parenchyma. CUSA being used. That's the pedicle of segment 6 which we have encountered, which was clipped and divided. I'll finish. The parenchymal dissection was continued. That's the right hepatic vein. The parenchymal dissection was completed. Hemostasis achieved. We did a check ultrasound to see if there are any more lesions. No more lesions, and the abdomen, a drain is placed and surgery closed. Sorry, I didn't include the lymphadenectomy at the HDL in this edited video. We had done a lymphadenectomy. The post-operative course was uneventful, and the patient was discharged on day 5. When we look at the biopsy again came out to be intrahepatic adeno-CA, moderately differentiated, G2 mass forming type. The margins were free and no perineural or lymphovascular invasion noted. So it comes under T1B AJCC classification. There are no nodes were involved, and the rest of the liver showed some mild cholestasis and steatosis. I'll rush through. The follow-up patient was doing well. We did a 3 months CT, which didn't show any more lesions, and the CA99 post-operative on follow-up was normal. I'd like to close here. Thank you.
Thank you, sir. It was a brilliant presentation. I now call upon Dr. Raju from Team Vimalakar to present his case.
Good afternoon, one and all. I am Dr. Raju, Team Vimalakar, Consultant Surgical Gastro. To coming straight away going into the case, this is a 52-year-old lady, known diabetic with dull aching, upper abdomen pain for 3 months. On initial evaluation, our laboratories were normal, and radiology part, there is a space occupying lesion in the segment 2 and 3 and part of segment 4B. And in detail, Dr. Gayatri ma'am will discuss.
Right, so on MR, this is the plain MR, axial T2 diffusion, coronal T2. There is a hyperintense lesion, left lateral segment, crossing the falciform ligament to go into segment 4. And what is important here is this dilatation of biliary radicle. So it's involving the biliary system. There's also subtle overlying capsular retraction. And in the first subsequent phase, arterial, late arterial, extracellular, and delayed phase. What we can see is initially the periphery is enhancing, and in the delayed phase there is significant central enhancement. So there is no washout, but there is significant central enhancement. There's almost a hypointensity in the center, which is only enhancing in the delayed phase. So T2 hyperintense, left lateral segment lesion, partially segment 4, restricted diffusion, capsular retraction, IHBR dilatation. Peripheral enhancement initially, central enhancement subsequently. So all of these clinch the diagnosis of intrahepatic mass-forming cholangiocarcinoma.
So in this case, we have planned for a proper laparoscopic left anatomical hepatectomy. After preoperative evaluation and volumetry, we took for surgery. This is intraoperative table position, that is head up with the leg split with a sandbag under right upper quadrant of the abdomen. We usually take central line and arterial line. This is the port position, 3 5 mm ports under subcostally, and a 12 mm port lateral to left midclavicular line with a camera port. And then going into the inflow control, before going into proper porta dissection, the cystic duct being taken, and which is gallbladder is used for retraction throughout the procedure. That is porta dissection, that is the left portal pedicle, that is left portal vein. This is skeletonized and kept aside. That left hepatic artery slooped with a vascular sloop and clipped and divided, and then that is the left hepatic vein, which is taken with endo-GIS stapler, that is left hepatic duct taken. After achieving complete left-sided control, the left lobe is mobilized, the triangular ligaments are divided, and left hepatic vein is looped. Then moving on to the, after achieving this. Moving on to the scoring. Parenchymal transaction has been started initially with harmonic, then moving on to with the help of QSA, the parenchymal transaction, rest of the parenchymal transaction has been carried out. In the interest of time, I am skipping as previous presenters has presented this. So this is the just above the IVC, the small portal, small hepatic veins draining that segment of the liver being clipped and divided. So that is left hepatic vein, which has been skeletonized and divided. And here the important point is, before dividing the left hepatic vein, make sure that the segment 5 and segment 8 drainage is good. Otherwise, we have to sometimes we have to reconstruct segment 5 and segment 8 drainage. This I convey. Thank you.
It was a very great presentation. Now I call upon Dr. Monica Bopanna, consultant medical oncologist from KIMS Hospitals, to share her views on chemotherapy in IHCC.
A very good afternoon, everyone. I thank Dr. Vimalakar sir for giving me this opportunity. So I'll be discussing a medical oncologist's perspective of intrahepatic cholangiocarcinoma. I'll mainly focus on adjuvant therapy, how it has evolved, and I'll just touch upon the latest advances with respect to molecularly targeted therapies. I don't want to bother the surgeons here with too much of molecular jargon, so I'll just touch those topics. Adjuvant chemotherapy after curative resection, this is the 2025 NCCN guidelines, and when there is an R0 resection, the options that are given are systemic therapy or enrollment in clinical trial. We can observe also in some cases, if there is an R1 resection, margin positive, or there is a regional lymph node involvement, systemic therapy has to be given. Again, here also clinical trial enrollment has been given as one of the options. Whenever there's margin positive, we add radiation also. And gross residual disease, we treat like metastatic disease. Relapses are very common after curative resection. Usually they are local, but distant relapses are also frequently seen. Post-op radiation or chemoradiation helps in local control, and systemic therapy helps in distant control. So why do these guidelines recommend clinical trial enrollment? That's because we lack level 1 evidence in biliary tract cancers as far as adjuvant therapy is concerned. That's because very few patients present with resectable disease from 2000 to 2014, more and more patients were put on adjuvant therapy after a curative resection. And with this, overall survival improved from 32 to 41 months. So especially in patients with lymph node positive disease, adjuvant chemo was the only factor that decreased the hazard ratio for death. So the authors state that probably this improvement in OS may be because of increased utilization of adjuvant chemotherapy. Why adjuvant capecitabine? Now we are using capecitabine. It's become a very popular adjuvant therapy post-resection in BTCs. This data comes from the landmark trial, that's the BILCAP study, which is a UK-based study that was designed to test chemo versus observation. The drug they used was capecitabine. 450 patients with 225 in each arm, 60-month follow-up, which is a 5-year follow-up, which is a significant duration. They did not find any benefit in the intention to treat population, but when they did a per protocol analysis, there was an overall survival benefit. So this discrepancy in the result of the ITT analysis and per protocol analysis means that benefit was seen only in patients who could strictly adhere to the dosing regimen and they could complete the protocol. This is the largest prospective randomized data set that we have in this setting as of today. The long-term update on BILCAP study showed a good survival difference of 13 months, but again, the hazard ratio was just short of statistical significance. So benefit was clinically meaningful, but it was modest. The main benefit seems to be by delaying the time of recurrence and thereby contributing to overall survival and RFS benefit. So this has emerged as a very popular adjuvant therapy because it's very easy to give, it's oral tablets, so we use it. So why do medical oncologists use gemcitabine cisplatin? Again, we don't have strong data in the adjuvant setting. We have data in the metastatic setting that it's better than single agent gemcitabine. So we extrapolate results from the trial that showed benefit in the metastatic setting. There is one trial called ACTICA-1 that is ongoing and it is comparing GemCis versus observation. Results are awaited. Why S1? Now, many centers are using S1 also as an adjuvant therapy because hand-foot syndrome, that is a problem with capecitabine, is less with S1 and it's cardiac safe also. And we have data from a Japanese study that shows a 3-year overall survival benefit by substituting capecitabine with S1. Is adding another drug to capecitabine beneficial? Again, we have this Korean trial, the results are awaited. So we do use GemCape regimen, we use 5FU also. So if you ask me cytotoxic therapy wise, is there anything new? There is nothing new. We are just juggling the old timers in different permutations and combinations. So to summarize, there is very sparse phase 3 RCT data for supporting the use of adjuvant therapy in intrahepatic cholangio. In our institute, we are mainly using it in node positive disease and margin positive disease. And in margin positive, we are also adding radiation. In heavy nodal burden cancers and gallbladder cancers, we are preferring gemcitabine cisplatin. So just a very brief discussion on the molecular targeted therapies, what are evolving now. We are understanding the molecular drivers better. We are using NGS, that is next generation sequencing. It can be done on paraffin block tissue or on liquid biopsy by making use of cell-free DNA. And our mutations of interest are HER2, IDH1, BRAF, FGFR2 mutations, fusions or rearrangements, and NTRK gene rearrangements. The ones that I've highlighted in green are the drugs that are currently available in India. The others are unfortunately not available, not marketed in India. They need to be imported. The use of immunotherapy drugs like pembrolizumab and durvalumab in metastatic unresectable biliary tract cancers, we have good data from TOPAZ-1 study where the addition of durvalumab to the standard gemcitabine cisplatin, it led to a very significant overall survival and PFS benefit. This trial is very important because 55% of the patients were intrahepatic cholangios in the TOPAZ-1 study. And then subsequently, even pembrolizumab was approved in this setting, in the metastatic setting, based on the results of Keynote 966 trial. So with that, both these regimens, that is GemCis with either durvalumab or pembrolizumab, is recommended as a category 1 regimen in advanced BTCs, unresectable. Thank you so much for your patient listening.
Now we thank you, ma'am. Yes. So now we proceed forward with last session of today on colorectal liver mets. We have our RELA team from Chennai for this session. They are connected to us through online. I request Dr. Ram Kiran Reddy Cheruku, Senior Consultant Transplant Surgeon from RELA Hospital, to present the case, and the radiologist from RELA team to take over the case radiology details. The stage is all yours, sir.
Good evening, everyone. I am Dr. Ramkiran. I am one of the consultant surgeons in HPV surgery and liver transplantation from RELA Institute, Chennai. I thank Dr. Vimalakar for giving me this opportunity to present in this forum and discuss regarding colorectal liver metastasis. I'll start sharing my screen now. Can you see my screen?
But it's zoomed in. Can you please zoom out?
I can see it normally here. Is it, are the pages moving? So it's still very zoomed in, is it?
Zoomed in, yes, but we can see the slides.
I don't know why it is like that. Let me just reopen that and then.
Yes,
I think
now,
it's, yeah, is it better now?
Yeah, now
looks better now. Sure. So I'm going to discuss a case of colorectal liver metastasis and a brief discussion about the principles of management. We know that liver is the most common site for colorectal liver metastasis. Colorectal metastasis overall, and at presentation, a third of patients present with liver metastasis synchronously, and eventually more than half the patients go on to develop metastasis in the liver in their lifetime. It's rare to have non-hepatic metastasis without liver getting involved first, because the metastatic cancer cells from the colon travel through the portal system and initially get deposited in the liver in the sinusoidal system. So the liver is the first solid organ to receive metastasis from the colon after the regional lymph nodes. Historically, giving chemotherapy or immunotherapy alone without resecting the liver metastasis has given a 5-year survival of not more than 20 to 30%. But with addition of surgical resection of the liver metastasis, the 5-year survival has been shown to be more than 60%. So the metastasis can be either synchronous or metachronous, depending on when they are identified. If they are identified at the time of initial diagnosis or within 6 months of colonic resection, they're called synchronous. Whereas if they are diagnosed at follow-up or 6 months after resection, they are called metachronous. So let's get into the case scenario here. Our patient was a 51-year-old lady who was a homemaker, presented to us with diffuse central abdominal pain of 2 months duration and occasional altered blood in stool for 3 months prior to presentation to us. She also had tiredness, anorexia, and weight loss of about 3 kilograms, which is nothing spectacular, but there was some weight loss as well. She had mild constipation, but no features of intestinal obstruction and no features of anything to do with liver disease. She had no jaundice and no pedal edema. Pedal edema can signify both problem with liver function or also problems with nutrition, which can affect the management of the patient. She was diabetic and had a hysterectomy before. There was no significant family history. In all patients with colorectal cancer, it's very important to elicit a proper family history because especially patients who are younger than 40 to 50 years old, they can have familial syndromes which can predispose to this colorectal cancer. So it is important to have a good family history in these patients. On clinical examination, nothing great was revealed. Her BMI was 21.6, normal vitals, mild pallor but no icterus, again no pedal edema, no peripheral lymphadenopathy. It's important to examine for peripheral lymphadenopathy, supraclavicular, especially in these patients, and no specific abdominal findings, although in patients with large T4 tumors or hanging liver metastasis from the edge of the liver, it's easy to palpate the liver and the colonic tumor as well. Blood tests again were completely normal. The platelet count is 230,000, which is again indicative of which shows that there is no significant portal hypertension. The kidney function was good. The liver function tests were all normal. Albumin was 3.8, slightly low, but still okay. The CEA, which is the tumor marker for colorectal tumors, was significantly elevated at 156 nanogram per ml. So because of the history of abdominal pain, weight loss, and GI bleed, a colonoscopy was performed, which showed a circumferential growth in the ascending colon with a narrowing of the lumen, and there were no other polyps or growths in the rest of the colon. So it was a solitary circumferential narrowing tumor in the ascending colon, and biopsy showed that it was a moderately differentiated adenocarcinoma with these molecular markers. So we went ahead and did a CT scan. Our radiologist is not on board, so I'll discuss the imaging myself. And the radiologist of KIMS Hospital can add any other points if she's happy. So this is the plain CT scan of the patient. This is the liver. Liver looks normal. The spleen looks normal. And then as we go down, first I'd like to show the colonic tumor. This is the area of the IC junction, and then up here you can see a circumferential growth there, which is the colonic tumor. As we go back to the liver, in this plain scan, we can see that there are areas of hypodensity. I don't know if you can appreciate on the screen there. There is one area of hypodensity here in segment 7 posteriorly, and as we come down towards the lower part of the liver, we can see a hypodensity here again in the caudate lobe and a small hypodense area next to it extending into segment 6, and one more small hypodense area that is there in around segment 5 to 6 region around here. So the colorectal metastases on plain scan appear as hypodense regions. They are less dense compared to the rest of the liver parenchyma. And then going on to the arterial phase, you don't see much enhancement of these lesions in the arterial phase because they are predominantly supplied by the portal blood. So the arterial phase, you can see that the right hepatic artery is replaced, but rest of the arterial anatomy is normal. And again, the lesions appear less dense. This is the one in the caudate and segment 6. And there is another, the segment 7 lesion also is seen as a hypodense area here. And the same with the segment 5, segment 6 lesion. So we can see multiple areas of hypodensities, at least 4 lesions seen in both, in all the sectors of all the segments of the right lobe. And this is the portal phase. Portal phase is when you can see these lesions much more clearly. Sorry, this is still the arterial phase. Yeah, okay, this is the portal phase. In the portal phase, you can see the portal anatomy clearly that it is normal. And then this is the lesion in the segment 7. There's a central hypodensity with a slightly rim enhancing kind of appearance in the segment 7 lesion. And as you come down, you can see a lesion in the caudate, and so that's a lesion in the caudate lobe extending into segment 6. Similarly, a lesion in segment 5 as well, segment 5 to segment 6, which is it's a surface lesion in the segment 5 to segment 6. So the patient also has had a PET scan which showed all these multiple lesions and the lesion in the colon as well. So this is the segment 7 lesion seen on the top of the liver, and as we come down we can see the 2 lesions in one in the caudate, one extending into the segment 6, and this one in segment 5. This is the gallbladder. Next to the gallbladder we have a lesion in segment 5 as well, quite a significant lesion. And as we come down, this is the colonic tumor, all the tumors with good high SUV values at initial presentation. And on an MRI scan in colorectal liver metastasis can help in identifying very small lesions in other areas of the liver which are not very clearly visible either on CT or on PET. In T2 phase of the MRI, we can see that this is a hyperintense lesion in segment 7 that we can see correlating with the previous imaging. Similar lesions that we saw in the caudate and segment 6 and segment 5 are seen in this imaging as well. And that's the tumor in the colon. So the final conclusion of the imaging was that there is a 5 centimeter tumor in the ascending colon and multiple lesions, at least 4 lesions in the right lobe of the liver and the caudate, all with high SUV of close to 15 to 20, and the one in the colon up to an SUV of 30. So the patient was considered for neoadjuvant chemotherapy in view of multiple lesions in the right lobe, non-complicating primary colon tumor, and high SUV in the PET. So she received 3 cycles of capecitabine and oxaliplatin. Last cycle was on 8th August of 2025. And post neoadjuvant chemotherapy, the CEA reduced from 156 to 63 nanograms. That's a significant reduction in CEA. And post neoadjuvant chemotherapy, the imaging showed a good reduction in size of both the segment 7 and the caudate and segment 6 tumors, whereas the segment 5 lesion is almost the same size. Anyway, I'll skip through the imaging. We did a PET as well, but again, post neoadjuvant chemotherapy, PET is not very sensitive picking up the lesions. The SUV in all the lesions in segment 7, 6, 5 and caudate, all the SUV significantly reduced from more than 15 to 17 to close to 3 to 7. And the same happened for the colonic tumor also. So following neoadjuvant chemotherapy, 6 weeks after that, we went in for a simultaneous resection. We did the right hemicolectomy along with the right hepatectomy and caudate lobectomy. I'm going to skip showing the video because nothing special in a standard right hepatectomy and right hemicolectomy. You've seen so many videos, laparoscopic open, robotic since morning. So technically there was nothing special about this surgery. Rather than that, I'd like to discuss the management principles of patients with colorectal liver metastasis. Anyway, post-operative course for this patient was uneventful. Peak bilirubin was 3.2 and INR was 2.3 on day 1, but everything settled down. Orals were started and she was discharged by day 7. So things to consider in management of patients with colorectal liver metastasis. Coming to basics, very important is the patient performance status and nutrition. Somebody with poor performance status or poor nutrition cannot be considered for a major combined resection of both the liver and the colon. So that is something that needs to be kept in mind. Tumor biology is very important. Molecular profiling and the response to chemotherapy, assessment of response to neoadjuvant chemotherapy is very important, because for somebody who has very aggressive disease which is progressing on chemotherapy, doing a major liver resection may not make much sense, because they're bound to have very quick recurrences and the surgery may not extend their survival. Similarly, you need to keep a watch for extrahepatic disease. Presence of extrahepatic disease again worsens the prognosis. And patients with complex colonic anastomosis, very low rectal anastomosis, we have to be very careful, because a leak from that anastomosis is going to delay recovery. It's going to delay initiation of chemotherapy. And if they have liver metastasis, it's going to delay resection of the metastasis as well. So in such patients, it's probably more prudent to do a stoma and then consider chemotherapy, liver resection, and stoma reversal at a later date. It's important to assess background liver quality, background liver function. This can be poor because of age or because of diabetes, or in patients who receive neoadjuvant chemotherapy, especially from oxaliplatin or irinotecan, they can develop sinusoidal obstruction or steatohepatitis, which can affect regeneration of the liver. So we have to be very careful to leave enough liver parenchyma in the remnant, at least 35 to 40% if possible. And what kind of resection is necessary, that is something that we need to consider. Never combine major liver resections with complex colonic or rectal anastomosis. So we would generally do, if it's a right-sided resection, which is more straightforward, right, hemicolectomy with a simple anastomosis, straightforward, not non-obstructing, you can add something like a right hepatectomy or an extended right hepatectomy to something like that. But if the patient is having a low rectal tumor, you're doing a low anterior resection with a critical anastomosis, adding a right hepatectomy with leaving a remnant of 35% may not be safe. If there is some complication from the colonic anastomosis, if there is a leak or infection or sepsis, a smaller liver remnant will not be able to cope up with that, and the patient will land up in liver failure and can lead to mortality as well. So never combine two major resections. If you do a rectal resection with a complex anastomosis, you can probably do a non-anatomical resection of the liver or a left lateral segmentectomy, but not really a major right-sided resection. We can either approach it by laparoscopy or robotic approach or through an open approach. We nowadays do very commonly robotic surgery. We don't do much laparoscopic resections. But we can add both the surgeries through an extended midline incision, a colonic resection, and the liver resections. Always consider parenchymal sparing resections because these patients may come up with recurrent tumors in the future. So always consider parenchymal sparing resections and aim for R0 resections. You don't need a 1 centimeter margin. You can get away with negative microscopic margins. And sometimes after neoadjuvant chemotherapy, there can be disappearing metastasis. It's always important to resect these areas also, although sometimes you can't see it. Use a Pringle maneuver liberally. Use an intraoperative ultrasound to pick up small metastasis inside. And after resection, check for biliary leaks. And always cut and check your specimens after wide local excisions, because you might think that's the right area, but when you cut, sometimes rarely you may not find the tumor within that. So always verify that you've actually removed the right part of the specimen. So we have either simultaneous or colon first or liver first approaches. It's important to see which one to select, which approach to select. A simultaneous approach is almost always the best approach because the patient can get the entire tumor burden removed from the colon and from the liver at the same time. The overall cost, the overall hospital stay is much lower. The patient can go on to have chemotherapy at a much earlier date. So overall recovery will be much faster. But for this, the patient has to be fit, nutritionally fit, I mean, surgically should be able to tolerate a major surgery like a combined resection. And also the liver burden and the tumor burden in the colon should be small enough to, so that the overall morbidity of the surgery is not too high. So smaller liver tumors, fit patient, always consider a simultaneous resection. Whereas if you have a patient who has a complicated colonic tumor, somebody who is bleeding or somebody who has obstruction, you can consider a emergency colonic resection first, leaving the liver tumors for later. Or somebody who is not fit for surgery, you would do a sequential resection. You would do a colonic resection first, give them chemotherapy, improve their nutrition, and then go on to do a liver resection later. And that also gives time to assess the response to chemotherapy for the liver tumors. A liver first approach is very rarely considered, where maybe there is a borderline resectable liver tumor, a large tumor which is centrally located, which might become unresectable with time if you leave it for more time, considering a colonic resection first and give on chemotherapy. If the liver disease progresses and it can potentially become unresectable later, that situation you can consider a liver resection first, then give chemotherapy and do the colonic resection later. So various scenarios, if you have something like a solitary small less than 3 centimeter tumor, you can consider ablation. Or if you are going for a colonic resection, you can do a wide local excision of a single tumor at the same time. If it's a single tumor which is much larger, it may need major hepatectomy as well. If you have multiple tumors in one side, in the right lobe or in the left lobe, we can consider multiple wide local excisions, multiple ablations, or even a right hepatectomy like we did in the case that I presented. Multiple options here depending on the expertise, depending on the patient fitness, and access to interventional radiology facilities as well. Again, if there are multiple bilobar lesions, here the options are again complicated. We can do one major resection and wide local resection of the other lobe, or we can do ablation of the other lobe, or we can do staged resections where we do one major resection, allow the liver to regenerate, and then do a partial resection of the tumors in the remnant. And in cases where it is still unresectable, liver transplantation has now come up as a new treatment option for patients with multiple unresectable colorectal metastasis. This is a patient where we've had who presented with obstruction elsewhere because of the colorectal tumor, and they've done a Hartmann's procedure, created a stoma that you can see there. Patient again still had a tumor in the left lateral segment and probably 2 suspicious lesions in segment 5 and segment 8 area. So this is the tumor seen intraoperatively. So we did a left lateral sectionectomy, intraoperative IR guided microwave ablation of these 2 small lesions, and also a stoma reversal. You can see the stoma here, which is covered, a stoma reversal in the same setting. And it's often we see that for patients with multiple tumors in the right lobe, segment 4, we have a small liver remnant volume. In these patients, doing a major resection can risk failure of the remnant liver. So we have various strategies like portal vein embolization, ALPS, and recently a concept called venous deprivation, where you also block off the hepatic veins in addition to the portal vein to get much faster regeneration of the remnant liver. With portal vein embolization, we can see almost 30 to 40% enlargement of the remnant liver, which helps in safe resection. Similarly, with ALPS, where we do a near total parenchymal transection and ligation of the right portal vein at the first stage, and in the second stage, we consider completion of the hepatectomy. There, the remnant volume regeneration is much faster and maybe even higher in quantity compared to portal vein embolization. But again, it's a surgical procedure, it carries higher morbidity. So the preferred method for increasing the remnant liver volume would still be portal vein embolization, at least in our unit. So various prognostic factors in colorectal liver metastasis which show poor prognosis. There is a form clinical risk score where when the primary tumor is node positive, disease-free interval of less than 12 months from the primary to discovery of metastasis, more than one liver tumor more than 5 centimeters and CA more than 200, all of them carry 1 point. When the score is 0, you can see that the 5-year survival is close to 60%. And if the score is 5, the 5-year survival drops from 60 to 14%. So all these things should be kept in mind before we go for a resection. And finally, touching on liver transplantation, again, this is a controversial topic coming up in the recent days. Because organs are scarce, we need to keep in mind equitable use of organs using utilitarian principles and double equipoise, considering living donor scenario as well. And also we have to consider the effect of immunosuppression. So immunosuppression can cause faster growth of tumors. But the trials from Norway, SICA-1 and SICA-2 trials, they have shown that in selected patients who are good risk, who have no extrahepatic disease and only tumor limited to the liver, and who have no progression and good response to chemotherapy, when there are multiple unresectable tumors in the liver, doing a liver transplantation has very good 5-year survival, close to 50 to 75%, especially when the score called the Oslo score is less than 4. Low Oslo score of 0 to 1. I conclude my talk here and we can have a discussion. I think interventional radiologist is going to present IR techniques to deal with these tumors. If you have any questions, I'm happy to take.
Thank you, sir. That was a brilliant presentation. Now I call upon Dr. Faisal Syed, from interventional radiologist from KIMS Sunshine Hospitals, to give his brief discussion on scope of interventional radiology in colorectal liver metastasis.
So I would like to thank Dr. Vimalakar sir and the gastroenterology team for giving me the opportunity to present this talk on role of IR in colorectal liver metastasis. As already discussed by our colleague, that the colorectal liver metastasis is a common cancer, and more than 50% patient develop liver metastasis and 25% synchronous. So the uniqueness of the colorectal liver metastasis or the C colon is that even if it is a stage 4, it can be curable, because if the lesion is in the liver or a few lesion in the lung and other, if we can treat those lesions, the survival are very good. So we know when we, even if the stage 4, if we resect all the tumor from the colon and the liver, we can get more than 60 to 70% 5-year survival. So the goal of the treatment should be a complete clearance via resection or ablations. The pathways are either straight away we'll go with the resection or ablation, or plus minus chemo, or convert those few cases which are large, which is unresectable, to resectable, and then do surgery. So the different modalities we have for CRLM is one is local. We have in local we have resection, ablation, sometimes SBRT, and regional we have TACE, TARE, and then we have a systemic chemotherapy. Recently we have started doing HIC for colorectal liver mets, which have a good results also. So the main thing is we have to be we have so much options available to choose colorectal liver metastasis, and we should have a tumor board to decide which type of treatment should be given, which type of treatment should be given first and after that. So the IR should be in the tumor board team to decide which lesion to be ablatable, and with the surgeon we show which lesion to be resectable. And over the time we have seen the MDT involvement improve the survival outcomes. So what are the different IR tools? So first is if you talk about the curative intent, we have ablative treatment like RFA microwave, or if a patient is planned for surgery with less FLR, we can do portal vein embolization and or the venous deprivation. And in some cases of the progressive liver disease, we can have catheter therapies like Debiri and Y90 TARE. So the local ablation in CRLM, we have a traditional indication like lesion should be 3 centimeter and up to 5. And if it is a deeper lesion, the ablation is preferred. And it can be used with a combination therapy, like if we have a large tumor on the left side and a few smaller tumor on the right, so surgeon can resect on the left and the smaller tumor on the right can be do ablation to give a complete cure for the patient. So this is how the decision making should be. So if it like first patient, if you can see, we have for the first patient, there is a subcapsular, very small subcapsular lesion in the left lobe of the liver, which is easily targeted by the surgery, and that should be resected. So now, if you see the patient 2 and 3, the lesion is somehow subcapsular, is in the parenchyma and somehow deep. So in those cases, surgery and resection both are possible, but and both have, if it is less than 3 centimeter, both have similar outcomes. But the cases which have very near to the bile duct or very near to the major vessels, we can have an option of IRE or SBRT. So this is one of the groundbreaking trial which shows which compare the survival of colorectal liver for the small colorectal liver metastasis between the resection and ablation. So basically they have decided the ablatable or resectable patient into 2, and the first arm undergo resection and the second arm undergo ablations. So if you see the result, there are exactly the same result. They have similar overall survival. They have similar local recurrence rates. So long-term outcome or overall survival has no difference, and local progression-free survival has no difference. So, and the mortality and the side effects are more in surgical arm. So if it is for the lesion less than 3 centimeter, we can give similar outcomes as compared to the surgery. So this is the basic principle. Just run it. It's RFA. We just give a RFA will give the electric current into the lesion by the antenna, and there is a descending pad. So this or theory, I'll just skip it. So now we have exclusively using a microwave because it has a higher intratumoral temperature, faster heating, and there is less effect with the heat sink effect. So if a lesion is near to the blood vessel, the RFA efficacy is lesser, so we use microwave in those situations. So how we do the ablation, we can use the image guidance like a USG guidance. So if a lesion is very well seen on USG, we can directly do ablation in the USG guidance if we are very well aware of the margins. We can also use CT guidance, so we can know the margins. We will require at least 1 centimeter margin around the tumor. So in this case, you can see there is a small lesion in the segment 7, and it is easily ablatable by using microwave. You can see the adequate margins after the ablation. So sometimes we do neoadjuvant chemotherapy very commonly. So sometimes after the neoadjuvant chemotherapy, the lesion disappear. So in those situations, we have to put some marker into the tumor. Like this is the solitary lesion near the gallbladder, and they have planned for chemotherapy. So we put some small coil like into the lesion before the chemotherapy, and you can see after the chemotherapy, the lesion disappear. But we cannot ignore such lesions because they have a micrometastasis in it. So we ablated with the fluoro and the CT guidance, and we also did hydrodissection, which is a complete response to the tumor. So before doing neoadjuvant chemotherapy, it's important to assess the lesion size and try to put some marker, as the majority of lesion can be disappeared after the neoadjuvant chemotherapy. Timing of ablation is important. We have to do ablation as early as possible. So if you're starting a systemic chemotherapy as neoadjuvant chemotherapy, we have to assess the patient within 4 to 6 weeks to see whether we can ablate it or not. Now come with the portal vein embolization. So we know the major surgeries, if FLR is less, are have a major complication after the surgery. So we should have at least 30% normal liver, and in majority of colorectal liver met, they receive a chemotherapy, and so in those cases we require FLR of 30 to 40%. So portal vein embolization we can do, like if we embolize the branch of the portal vein, it causes reversal of the flow and cause the contralateral hypertrophy. So there we have two approaches, which one is contralateral, ipsilateral, both we can do. Now we have moved toward the ipsilateral approach to not to disturb the FLR liver. Now the recent concept come with the hepatic vein deprivation, in which in addition to the portal vein embolization, we will also embolize the right hepatic vein to have a major FLR increment. So this is the study which compared the only portal vein embolization with the portal vein with hepatic vein occlusion. You can see over the time FLR percentage is significantly larger in portal venous deprivation. And this is the PVA case. We have a multiple lesion in the right lobe, and it's planned for the and the FLR is 27%. And then we did a portal vein embolization in this case, and you can see after 4 to 6 weeks the FLR has increased to 42%, and the patient underwent surgery uneventfully. Now we have if we have a systemic therapies the patient has multiple liver lesions and it is progressing on second line of chemotherapies, then we have some transcatheter therapies like debiretase and Y90. So principle is we can selectively go inside the hepatic arteries and selectively put drug-eluting beads inside the those lesions. In this case, irinotecan is used as a chemotherapeutic agent. So DEP particles have this principle. We directly go into the liver parenchyma, and due to the DEP particles, it will release slowly, and the drug will be in the liver without systemic toxicity. Y90 has also come in the colorectal liver metastasis when we can give a high dose of radiation to control the disease, and it also comes in the ESMO guidelines. If it is resistant to multiple systemic therapy, we can use the STAIR, or it can be HIC into the liver. So this is the EPOCH trial which compare the systemic therapy with systemic therapy plus TAIR, which shows a good progression-free survival over normal systemic therapy. So the conclusion, the IR is not a last resort for the colorectal liver mets. IR can be used for the curative intent like a thermal ablation, and also for the surgical partnership to increase the FLR, and at the last resort, if the systemic therapy is failing, we can use transarterial therapies. Okay, thank you.
Thank you, sir. It was a great presentation. So now we move forward with the final keynote presentation, keynote lecture by Dr. Subhash Gupta, sir. Sir, it gives me immense pleasure to extend a warm welcome our immediate past president of IASG and chairman, chief liver transplant surgeon at Max Super Specialty Hospital, New Delhi. During his tenure as president IASG, sir has been a guiding force, always encouraging academic growth, research, and collaboration with our fraternity. It was a strong support and encouragement that we successfully organized IASG Midterm Conference 2025 in February, an event that brought together experts and learners from across the nation. We remain deeply grateful for your vision, mentorship, and continued encouragement, sir. So on behalf of the organizing committee and everyone present, I extend a heartfelt gratitude and warm welcome to Dr. Subhash Gupta, sir. Dr. Vijay Kumar Bada, sir, from Yashoda Hospitals, Hyderabad, and Dr. Mahesh Shetty, sir, from AIG Hospitals, Hyderabad, will chair the session, sir. Welcome, sir.
Thank you very much. Can you hear me?
Yes, sir.
Okay, thank you very much for those really kind words. And if you allow, then I can share my screen.
Sir, you have the access, you can.
Can I? Okay. So let's see how it does not give me an option to share screen though. It does not give me the option to share my screen in this. Share. Please could
we have given the access
somebody
at the bottom. There will be an option called share. Green upward arrow.
No, it is. I didn't know. I can't see the share. Yeah, yeah.
Yeah, we can see your slides now.
Okay, sorry. So thank you very much once again for giving me this opportunity to speak, and I will begin straight away. So it's been a long journey for us, and we've been actively engaged in liver transplantation, HPB surgery, and GI surgery for many years in this country. And last year we celebrated completion of 5,000 transplants in our center. Now, coming to the core part of my talk, which is living donor liver transplant skills that may help the GI surgeon. The first one, you know, there are major blood losses, coagulopathy, and hemostasis necessary. These are skills I think every GI surgeon must possess because they're often faced with these problems. Of course, LDLT skills allows you liver mobilization, right lobe and left lobe, vascular anastomosis, particularly reconstruction of hepatic artery, which I'll show you some slides, how important it is for a GI surgeon, microscopic loop, enteric anastomosis, duct to pancreatic duct to bile duct, portal vein thrombectomy, and why that is important also in GI surgery practice, cable replacement for cable tumor thrombectomy. So these are some of the skills that you learn as a living donor liver transplant surgeon, and they have application in dealing with major liver trauma. You can manage hepatic artery injuries during cholecystectomy, can even do primary repair of bile ducts, as we often do in living donor liver transplantation. Can do resection in gallbladder cancer and cholangiocarcinoma, which has vascular involvement, particularly the right hepatic artery. Whipple's operation, complex portal vein reconstruction, where you can actually join the various tributaries into the portal vein if they are involved by the tumor. And revascularization of ischemic duct, which can be both arterial and portal. And of course, ex situ resection. And I'll show you some slides for that as well. But more importantly, as a LDLT technique, you learn much more beyond surgery, which is intensive care management. So important to give good results nowadays. Infection control. You are a general physician, you're a team leader, you have to have a knowledge of hepatology, nephrology, drug interactions, toxicity, and of course radiology and 3D anatomy, so that you can give the best performance in the OR and to your patients. So as you can see, this is a hepatic arterial anastomosis, which I think all GI surgeons should learn. And it's not very difficult to do if you mobilize it enough, removed all the adventitial tissue from around the artery, so the intima is popping out. You'll have to wear loops for magnification, learn how to deal with fine sutures without breaking them. The tricks here is not to pull the thread up, but to pull it down so that you're not touching cystectomy. Unfortunately, even now, I had to repair one last week by another cholecystectomy done somewhere else. The porta can be clamped. The right hepatic artery, as I showed, can be dissected for a centimeter or so, then clamped, and the bleeding can then be quite nicely stitched under magnification. Of course, we can ligate the right hepatic artery if there's a brisk back bleeding from there, because they're often suprahilar connecting vessels. And as you can see here, there's a connecting vessel between the right and left side in this CT scan. Most cholecystic bile duct injuries, again, quite commonly seen nowadays, and in spite of so much improvement in technology and that monitors are so good, 3D anatomy, but yet they do continue to happen every now and then. LDLT has taught us variations in biliary anatomy, and primary repair can be done if recognized immediately. And although controversial, hepatogenosis in dilated ducts, undilated ducts is also possible with magnification. What it does is it minimizes the morbidity, and the second repair then becomes easy. So these are some of the common variations that you see, and all sort of GI surgeons should generally be familiar with this this one, the one where the posterior duct comes and joins below. This particular one is the one which is most commonly prone to injury in cholecystectomy. So a little small video which will show you how to do an anastomosis to undilated duct under magnification. I hope you can see it's a ruined loop done, and there is a so these skills that you pick up from by some training in living donor liver transplantation, and you can do a nice hepaticojejunostomy with interrupt stitches under magnification. And believe me, you may think that the stricture rate is high, but the restricture rate is perhaps less than 10% if done properly to vascularized tissues, as you can see in this picture. So place interrupted stitches at both ends, and then the middle stitch, and then you can tie them one after another. Living donor liver transplantation will teach you how to do biliary anastomosis with non-dilated ducts. It can be less than 4 mm. You need to lower the plate if possible, clamp the porta, and push the liver parenchyma superiorly, and so that you get a good length of it. What about gallbladder cancer and cholangiocarcinoma? Both of these lesions are likely to invade the right hepatic artery, and which will often require right hepatectomy, for which you may need to do a portal vein embolization, and if the bilirubin is high, preoperative biliary drainage. But by the time this happens, the cancer is probably metastasized and you cannot do anything. Whereas left hepatectomy can be done without these adjunctive procedures if we cannot reconstruct the right hepatic artery. As you can see here, this is a situation where there's a distal right hepatic artery is free, proximal right hepatic artery is free. So you're able to resect and then reconstruct the hepatic artery. Then another situation where you have the left hepatic artery is already involved, and the right hepatic artery is also involved with the tumor, and we're able then to do a left hepatectomy and then reconstruct the right hepatic artery in cholangiocarcinoma. So these are some of the skills and things that you can learn from LDLT techniques. At our own center, we have been very active in cholangiocarcinoma resection, mainly for these reasons, that we will often reconstruct the right hepatic artery. So preoperative biliary decompression is not done routinely. Distal cholangiocarcinoma excluded in this, about 121 patients, and 51 had left hepatectomy and 3 had arterial reconstruction, and 4 out of these 121 died post-surgery. The others survived the surgery. Portal vein resection can also be done, although it may be sort of debatable whether it adds to the survival benefit or not. But if it can be done, it's increasingly becoming popular. And as you can see, we've done a cholangiocarcinoma resection with both portal vein reconstruction in this case. So the REX access approach has also been popularized. Again, living donor liver transplant technique. You isolate all the branches, isolate the left portal vein, the REX sulcus, isolate all the branches, clamp, then put a graft onto it, and then join it to the portal vein, and then you can carry on with resection. Intuitively, will often form a pseudoaneurysm which can be embolized later, which you can suspect if there's hemophilia later on. So rapid mobilize the right lobe, clamp port and pack if even not possible to resect. So liver resection is possible by most GI surgeons if they're sort of skilled in LDLT. So, so you can identify segmental vessels with use of Puja. You can do posterior sectorectomy and delineation of anterior sector. So you can see here there is a ischemic line between the right and left, and then we clamp the middle and left hepatic vein and the right hepatic artery, and you can see the entire sort of anterior sector, which is dusky as compared to this normal area, and this is area drained by the middle hepatic vein. So it gives you the boundary between anterior and posterior sector by this simple maneuver. So this is a liver resection technique for posterior sectorectomy. So you learn this dissection, the right posterior portal vein, right hepatic artery, and you resect along the you resect the liver along the anterior to the right of the right anterior artery, and you can then safely excise the posterior sector. Then what about tumors with HCC with tumor thrombectomy? So this is somebody who had a tumor in the right lobe with portal vein tumor thrombus, and we were able to do this resection and tumor thrombectomy by isolating the portal vein and common portal vein and the left portal vein, and then excising the tumor. So what has not been realized that resection can be used as a downstaging modality for large tumors, portal vein tumor thrombus invasion, those with high FPN. These are contraindications for transplant, but for resection, of course, you can do it, and later with immunotherapy and tyrosinase kinase inhibitors, after a period of time, you can think of transplanting them. So this is another case where, as you can see, the bile duct tumor thrombus in a cirrhotic patient. So we did the segmental resection and bile duct tumor thrombectomy. The P2 and P3 pedicles were ligated, and portal vein suction tumor was sucked out. And this is the scene after tumor thrombectomy, the bile duct. Now this is a large tumor where you can see the middle hepatic vein is invaded. So we removed the tumor and then put an extension graft on the middle hepatic vein, and so that it does not have liver failure. You can combine IR techniques that we use routinely in surgery for portal biliopathy. There's a lady who had complete portal vein thrombosis, portal biliopathy, and multiple stent stains and GI bleeding. So IR person then put a stent across the portal vein, and later we were able to do a hepatocogenostomy and remove the stents. And she's now over 2 years completely well. So pancreatic resection, pancreatic duct anastomosis and ripples can be difficult. Microsurgical techniques will give you good results. Duct to mucosa, interrupted single layer. I think important to recognize small segmental branches on the duct on the resection side and stitch it as well. And in a huge series, about 52 cases we done like this, and we had a fistula in only one patient and delayed gastrine time and hemorrhage in one. So IVC tumor thrombectomy can be done. HCC and RCC are notorious for venous thrombosis. Liver techniques can, such as venous bypass and right lobe mobilization will allow for thrombectomy. Cava can be replaced after vascular exclusion, and combined with cardiothoracic surgeons, you can also excise tumor extending as high up into the atrium. What about mesenteric ischemia? Arterial grafts can be placed distally on the SMA. You can either dissect the aorta, which you've learned from retrieval techniques. Any vessels can be used for inflow with loop magnification. Portal vein thrombectomy after resection of gut from portal vein thrombosis. So you can put a suction cannula in the portal vein branches and restore the flow of the portal vein branch. Now, you can also resect lesions that are very close to the hepatic vein using LDLT techniques. This is one lesion that you can see which is engulfed by all the veins. We did portal vein clamping, porta clamping, and then separated right hepatic vein by starting dissection from the top. So you only use the accuser right from the top, and this avoided major liver resection. As you can see that here, the right hepatic vein has been exposed, the middle vein and the left vein and the forehead vein has been exposed, and the middle of vein, of course, had to be excised. So we did a segment 8 and caudate lobe resection. Caudate lobe was also involved. So in summary, exposure to LDLT technique is essential for all surgeons and particularly to GI surgeons who will often have to face these issues. These techniques will allow for expanded GI surgical practice. Right hepatic artery reconstruction will sometimes shift right hepatectomy to left hepatectomy. Ex situ resection can be avoided by separating right hepatic vein with CUSA by starting resection from the top of the liver. Thank you very much for your attention. I'll be happy to answer questions if there are any.
Thank you very much, sir, for your wonderful lecture. So that in the summary, the first sentence is so very important, that exposure to the LDLT techniques will make the GI surgeons a learning curve for doing hepatic surgeries very easy. Any questions from the floor?
Yeah, thank you,
So
sir.
are you using any advanced technology for assessing the vasculature during your liver surgery, sir? Like the VR, or you still imaging is the...
I think we've experimented with many techniques, and but sitting with the radiologist and looking at each image frame by frame is perhaps the best thing. But I know groups in Singapore and use lots of sort of HoloLens and navigation aid. But I think just sitting with the radiologist, which we do in all our cases, and they help us guide how to go about it. But yes, that's something that in the future we can have images that will tell you. But the important thing to remember is that the porta and the distal right hepatic artery is often free, and that you have to study carefully so that you can be able to reconstruct them.
Thank you very much. Vimalakar.
Yeah, thank you, sir. I'm Dr. Vimalakar Reddy.
Hi.
Yeah. Sir, it was a great talk. I want to thank you on behalf of Team Vimalakar, KIMS Sunshine Hospitals, and TASG, Telangana Association of Surgical Gastroenterology. Thank you so much, sir. Thanks for joining us.
Thank you very much.
Thank you, sir. It was a privilege to learn from your experience, and thank you for the enlightening session.
Thank you very much. Can I exit? Thank you. Shall I leave, or
Yes.
do you have anything else? Thank you.
Thank you, sir. So we'll conclude today's session. May I now invite Dr. Vimalakar Reddy, sir, the visionary and driving force behind the GICS, to give the vote of thanks.
First of all, let me thank all of you who stayed till this 6:30. My special thanks to Vijay Kumar Anna and Mahesh Anna and Radha and Raghu Anna, many of my friends who stayed till last minute, because we got 250 people at 2 o'clock. We got 150 people at 4 o'clock. Now we are, I think, 30 to 40. So I should definitely thank you guys. And apart from that, I thank all the speakers who connected on Zoom or who has come here physically to present. And I thank all of the participants who stayed at least till 2 o'clock. Then I thank all my marketing team, especially Santosh and Ajay, many and his team who has worked for almost 1 week to 10 days to gather people. And apart from that, you know that my team, my special thanks to Dr. Gaurang, Dr. Raju, Dr. Pavan, Dr. Jayant, and Manisha, Dinesh, and Dr. Gopal, and who are supported by Mr. Teja and Giri. They are working for almost 15 to 20 days, almost 2 to 3 days. They were not sleeping at all. My postgraduates are editing videos, preparing presentations, and every day we were torturing them. So thank you so much. And one thing I wanted to tell, We have learned many things out of this one-day session. I mean, how to manage the time, how to control the speakers, how to prepare the plan. And with this, I think next time in GICS Pancreas, we will come up with a very good program. But anyway, one thing I am sure that keeping people on Sunday till 6 o'clock is a difficult task. And we can't end our sessions by 4 o'clock. Obviously, if you want to cover one organ, you have to give up at least 5 o'clock. So next time we'll try to make it more crisp. We will try to keep short lectures, but it is not a lecture-based conference. It is a case-based conference. It is more of interactive type of. That's why we had to give 1 hour time. Next time we will try to divide that 1 hour into pieces, and we will give it to the speakers, and we'll ask them to stick on to time. So I think with that we will improve in next GICS Pancreas. Thank you one and all. I invite all of you to join us gala dinner just in this Green Park Hotel in Open Lawns. Please join us. Thank you so much. Yeah, so Pancreas will be in January. In April, biliary will be there. In GICS conclusion will be in 2026, July. Thank you so much once again.
Organizing